So good morning, everyone. Before I review the agenda for today, our thanks to Ian Lewis for standing in as chair today, as neither Mark Galley nor Sandra Hernandez are able to be here today. And Don Moles just let us know that he is not feeling well, but I believe participating virtually. Good morning. My name is Elizabeth Landsberg, Director of HCI, and happy to call this meeting to order. And I'm going to talk a little bit about our agenda for today. So
let's do roll call.
Yes, thank you.
All right, Secretary Dr. Mark Galley. Dr. David Carlisle.
Present.
Dr. Sandra Hernandez. Richard Kroenig.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell. Dr. Richard Pan.
Present.
Don Moulds. Noting we have 4 members present, 3 members absent.
I think that makes a quorum. Back to you, Elizabeth.
Thank you very much. So looking at today's agenda, our only action item is the minutes, but we have 5 very substantive informational items. First, talking about the spending growth target and the methodology, including hearing feedback from the at the last meeting, and also some follow-up from a number of issues that the board had asked for follow-up information about. We're pleased to be joined by Memorial Care for a presentation on some of their cost-reducing strategies. We're joined by Assistant Deputy Director Margareta Brandt, who will be talking about the alternative payment model standards and adoption goals, something about which the board will be taking action in a few months. So we'll look forward to that presentation. Then we have a presentation from folks from the UC Berkeley Labor Center about measuring consumer affordability. And last but not least, a very important topic that we've been talking about since our first board meeting, which is about how to measure out of plan spend. And do we want to go back to the roll call?
Yes. So Elizabeth Mitchell.
Here.
Welcome. 5 members present, 3 members absent. Thank you.
Okay, going on to executive updates. And first, in recognition of Black History Month, we have included in the slides HCI's Black Liberation Statement, which was developed by HCI's Racial Equity Team. I'm not going to read it to you this morning. I do encourage you to read it. Equity is at the core of HCI's mission. And we do believe that a foundational step in furthering equity is to acknowledge our long history of intentional inequities, including intentional racism perpetrated by the U.S. government and the California government, to name that violence and the racism that has been perpetuated on Blacks and African Americans, and the results of which we still see today, both in health disparities and in other inequities. We also think it important to celebrate Black culture and the incredible resilience of Black communities, and so our liberation statement seeks to do both of those things. An especially troubling area is that of Black maternal health, again in terms of focusing on health disparities. Black birthing people in California experience pregnancy-related mortality at 3 to 4 times the rate of other racial groups. And the rate of severe maternal morbidity among Black women increased dramatically in recent years. So it's really staggering to have those numbers and to have some of those indicators be getting worse. The Department of Public Health's report centering Black mothers in California also states that preterm birth rate among Black infants did not improve between 2011 and 2019, while the mortality rate among Black infants in California declined over the past decade. In 2018, Black infants were still twice as likely as other infants to die before their first birthday. Also an incredibly sobering statistic. We got to do better by both the babies and the mamas. These deeply troubling statistics highlight the deep equity divide entrenched in California's healthcare system, as well as structural racism that impacts Black maternal health. So we at HCI are committed to addressing that in many of our programs, including our OCA equity and quality standards, as we seek to set the cost growth targets and enact our value-based quality measures. Okay, in terms of, I didn't give updates at the January meeting and so didn't cover the budget update, which I'm sure many of you are tracking. So of course, in January, Governor Gavin Newsom released the proposed 2024-25 fiscal year. As with last year's budget, this year's features a significant deficit. The governor's proposed budget for fiscal year is $291 billion, and in January estimated a $37.9 billion deficit. Of course, you've seen the headlines noting that that may well be worse. While Governor Newsom is proposing changes to offset the deficit, the budget does preserve core state programs, including expansion of Medi-Cal to all regardless of immigration status, and still providing the ability to continue implementing new investment in future years. For HCI, the most significant pieces of the state budget are some proposed delays in our workforce programs. So there is a proposal to delay $70 million for nursing or nursing programs and $70 million for our social work initiatives, as well as $189 million for various behavioral health programs. HCI's budget for this year is proposed at $523 million and growing to 748 positions, which is another year of growth for our department. So budget hearings are starting, and we'll see where the revenue projections are as of the May revision. The last program update I want to give is around HCI, in terms of HCI program updates, is HCI's work to develop a new health profession, certified wellness coaches. So folks may remember the governor's budget 2 years ago unveiled a children and youth behavioral health initiative, which really recognized the behavioral health crisis that youth in our country are facing and in our state. So there are a number of elements. If you have a teenager, please encourage them to download Saluna, which is an app that was just developed by the Department of Healthcare Services. And one of the, I've told my teenagers, and my husband's a high school teacher, encouraged him to spread the word about those apps. The fact is our youth are often more comfortable doing chat and online modalities for some of their behavioral health support. One of HCI's major initiatives as part of this youth initiative was to develop this new workforce, these wellness coaches, originally called behavioral health coaches, but that doesn't really roll off the tongue. So youth, through some focus groups, we came up with a wellness coach moniker. So we have peer support specialists and many licensed behavioral health professions, but we don't have very many at the associate and bachelor's level. Youth have told us clearly that they want a younger, more racially diverse, linguistically diverse in terms of LGBTQ plus status and lived experience, to provide support to them. So we're really excited to unveil this new wellness coach profession that is at the associate bachelor level. We're working closely with the community colleges and the CSU system to provide training, and our certification has officially launched, and we have our first handful of wellness coaches. So this is just one of the efforts of California to really focus on primary care, primarily to improve health outcomes and provide youth the support they need. But we do think allowing this range of health professionals also helps with costs, that we need to have professionals at every step of the health workforce ladder to really allow folks to operate at the top of their licensure and to provide the preventive primary care that folks need. So we're proud of that work. And the last announcement I want to give, and we can go to the next slide, on February 14th, we got to spend Valentine's Day together. Governor Newsom's 4 appointees to our Healthcare Affordability Board, Elizabeth Mitchell, Sandra Hernandez, David Carlisle, and Rick Cronick, appeared before the Senate Rules Committee, where we had a robust discussion about the board of OCA and the board. And then last week they were confirmed by the Senate. So congratulations to all of them. And with that, I will turn it over to Deputy Director Pagani.
Thank you. Good morning, everyone. I'll provide an update on OCA's proposed emergency regulations regarding total healthcare expenditures, or THCE, data collection. After posting the notification, next slide, please. After posting the notification of proposed emergency regulatory action to HCI's law and regulations website on February 12th, this kicked off a process to allow interested parties 5 working days to submit comments on the proposed regulations. Last Wednesday, February 21st, OCA filed the regulatory package with OAL. OAL has 10 days to review and make a decision on the proposed emergency action. This 10-day period ends Monday, March 4th. If approved, OAL will file the regulations with the Secretary of State, and the emergency regulations will become effective for 5 years. Next, and then this isn't on a slide, but I'd also like to remind everyone that OCA is accepting submissions of interest to serve as a member of the Healthcare Affordability Advisory Committee. We have a link available now through April 1st on our website for those who would like more information or would like to complete an interest form. The term for these appointments will begin on July 1st, 2024, and last through June 30th, 2026. You could always email our inbox at oca@hchi.ca.gov if you have any questions. And then, as we do at every meeting, I'd like to remind the board and the public about our slide. The statute denotes different roles for the board in different areas. We use a yellow area in the presentation for areas for which OCA or the office has the decision-making authority. It's important for us to get stakeholder input on these areas, and these meetings are an important way for us to engage with the board and members of the public. For areas where the board has ultimate decision-making authority, we note it with a green arrow. And lastly, I wanted to review some updated data on consumer affordability challenges from the California Healthcare Foundation NORC California Health Policy Survey. So, we've shared CHCF data before, and we're including select data points that are new that we haven't covered in the past. So this slide shows a new question in the 2024 survey, and the responses show that due to high costs, Californians are accumulating more and more medical debt. The trend is significantly worse for Black and Latinx consumers, as shown in the orange and gray bars. Next slide, please. In addition to impacting the healthcare of Californians, the high cost of healthcare is contributing to personal bankruptcy in California and across the nation. There is an increase in Californians reporting medical debt from 36% in 2022 to 38% in 2023. More Californians now report having trouble paying medical bills, from 1 in 10 in the 2022 survey to now 2 out of 10 individuals in the 2023 survey. Next slide. So as shown here, medical debt is more prevalent in communities of color compared to white communities. There was an increase in Black consumers reporting medical debt from 48% in 2022 to now 53% in 2023. And that concludes my portion of the executive update, and I'll turn it back over to the chair.
Thanks very much, Vishal, and thank you, Elizabeth. Open it up first to board members for questions or comments. Richard?
Thank you. Appreciate the presentation. I did want to make a brief comment about the, quote, creation of a new profession, as they say, and also the title, and I appreciate the process that went through. One of the things that I guess a caution, I would say, is that the term wellness has also been used, unfortunately, as a way to promote a lot of non-evidence-based, we call it care or not. We spend time here talking about waste in healthcare and unnecessary, quote, care. And so it's going to be important that that the folks in this, that they receive evidence-based, that they're providing evidence-based care, right? And oftentimes there's a lot of conflation in the term wellness between things that are actually effective and things that are frankly ineffective or even sometimes harmful under the guise of wellness. And so I have that caution in terms of being sure that we don't create confusion in the public, and especially since we're here concerned about spending dollars appropriately, that frankly the quote wellness industry is worth billions and billions and billions of dollars of ineffective care. And so I don't want us to create confusion in the public or the people we're serving about what is appropriate care and what may actually not be effective care that they are frankly spending their own dollars on. So, I mean, people can spend their money however they want. That's their own choice. But we should not be creating confusion.
Thank you. Other comments or questions? Elizabeth?
This is just, I think, building on the presentation that we just had, but there is considerable national evidence that affordability is the primary barrier to access, which also impacts equity. And I'd just like for the staff to identify some studies that support that, because I know we're dealing not just with affordability as the statute directs, but also access and quality and equity. And actually addressing affordability, according to the National Institute of Health and others, will actually have a very positive impact on access. So I just want to make sure we're addressing those together.
Thank you. Others? No, I have one question. With regard to our cost and market impact reports, I'm wondering if we've received any submissions yet?
We have not, but we do get a lot of questions from industry and regulated entities.
Thank you. That's it from the board. I think we'll open it up to public comment.
And we will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to public comment, we will alternate between members of the public in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. If you are dialing into this meeting on the conference phone line and you would like to provide public comment, we ask that you submit your comments via email at ohca@hcai.ca.gov, or please join the meeting online. If possible, please keep your comments to 2 minutes or less so that we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Beth Cabell on behalf of Health Access California. First, we would commend to all of you the discussion that occurred in Senate rules from your fellow board members. It was a very good discussion about the task ahead and a thoughtful discussion with legislators about the important responsibilities that this office and this board has. And so we would commend that discussion to you. I will also note that Senator Laird, who presented the slate on the floor, when he did so, noted that he had had many questions and all of them had been answered in the Senate rules process. So that's the way a confirmation process should work. Second, lack of affordability means lack of access. We, in our letters, provided a number of California-specific citations to that, including the survey, which you heard some of the results of. Half of Californians, more than half of Californians, say that they skip or delay care, doctor visits, prescriptions, other necessary care, and because of cost, and half of those get worse report that they're worse as a result. You have before you some of the impacts on communities of color, but it cuts across all of us who are not in the upper echelons of the income brackets. Thank you.
Seeing no hands raised virtually, we'll go to the individual at the podium. Thank you.
Members of the board, Steve McDougall representing CFT. As Black History Month is in its waning hours, I guess, at this point, well, it's leap year, we have another day. I'm going to quote James Baldwin. And one of his quotes that's been repeated over the years and decades is, "I can't believe what I hear you say when I see what you do." The CEO of the community hospital of the Monterey Peninsula in 2021, that's the only data I have had my hands on, received a compensation package of $2.4 million. Now, if that same individual went to play a round of golf at Pebble Beach every day of the year, including a caddy and a four caddy. I didn't know what a four caddy was. If I knew what a four caddy was, the once or twice that I played golf each year, I would come back with the same balls that I started with. A four caddy goes and finds your ball for you. With tip, greens fees, cart, and a dinner at the whaling station on Cannery Row in Monterey every night of the year, 4-course filet mignon. It comes out to about $1,200 a day. If the CEO of Chomp were to play a round of golf at Pebble every day in his 2021 compensation package, and he hit the whaling station every night, he'd still have $1.9 million to make ends meet. I don't know what he's making this year, but I assume it's more. We got to make this right. We have people of color going into bankruptcy, and we have CEOs making that. It's got to stop. Thank you.
Looking back virtually, seeing no hands raised, looking to the individuals in the room. If you'd like to make a comment, please step to the podium. Seeing no one at this time, that concludes public comment on this agenda item.
Thanks very much. So we're moving on to our action item, which is approval of the January 24th board minutes. Vishal?
We just have the January board meeting minutes. They've been distributed and include written public comments received since the meeting.
Thank you. Any comments or observations? Public comment then?
Let's move for a motion on the.
Move approval.
Do we have a second?
Second.
So we have a motion to approve the minutes.
Now we'll go for public comment.
Thank you.
If anybody'd like to make public comment on this item, please step to the podium in the room. If you're online, please raise your hand. Seeing no hands raised and no one at the podium in the room, that concludes public comment on this item.
Thank you. So let's take a vote, please.
Dr. Mark Galley, Dr. David Carlisle,
Abstain due to absence.
Dr. Sandra Hernandez, Richard Kroenig,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Richard Pan.
Aye.
That's 4 yeses, 1 abstain, and 2 absent.
Thank you very much. So I think we'll go back to Vishal now for item 4, which is our spending target methodology.
Thank you, Chair. So I'll be covering this item along with Assistant Deputy Director CJ Howard and Andrew Fair, who's a research manager in the Healthcare Spending Targets branch. And then Michael Bailett is joining remotely, and he'll be available to answer any questions if needed. Next slide. And then just one more. So as a reminder, we've included this timeline here. Our 45-day comment period closes on March 11th, which is 12 days from now. The board is required to adopt a final target by June 1st at a board meeting. This final target can align with the office's recommendation, or it could be another value as determined by the board. And then next slide. For reference, we've included our proposal for a 3% spending target. And I'll now turn it over to Assistant Deputy Director CJ Howard to provide a more detailed summary of advisory committee feedback on the proposal.
Good morning, everybody. Again, my name is CJ Howard, the Assistant Deputy Director of the Healthcare Spending Targets Branch in OCA. As you'll remember, we did a brief summary of the feedback that we heard at the Advisory Committee in January, but given that the board meeting was the very next day, we wanted to make sure that we took some time to communicate more thoroughly and fully some of the feedback that we received from the Advisory Committee. We go to the next slide. So below is a summary of the feedback that we received related to the recommended spending target. So some members had voiced concerns with OCA's recommendation to tie the spending target to historical median household income growth over the 20-year period from 2002 to 2022. Some of the comments included or concerns voiced included that the time frame includes the Great Recession and near zero interest rates, and that this 20-year period may not be representative of today or the future. And additionally, that the population is aging and may need to be taken into consideration. The time frame doesn't account for inflation or other cost trends for uncontrollable expenses, including legislative or regulatory mandates, and that using the 20-year period could compromise access. Some members suggested using a different time frame altogether, namely 2013 to 2022, where median household income grew by 4.1% on average. Other members indicated that the 20-year historical household income with low inflation is not correlated with medical costs, and targets must be believable and should not reduce access to care. Other members indicated that applying adjustments to historical household income growth to account for medical cost inflation and new minimum wage laws, because costs will go up. Others voiced concerns about access to care and demands on the system, especially with CalAIM, an aging population, and higher acuity of patients. There was also comment in favor or supportive of the 3% recommendation and tying it to the consumer experience and median household income. Summary of the comments includes that one member indicated that they couldn't imagine a target being any higher than 3%, as healthcare costs are currently unaffordable and impacting access to care as people are inclined or prone to skipping care. Other members indicated that they agree with the 3% target with no adjustments or no additional adjustments. There's already system gaming, rates increasing now in anticipation of a target. Even 3% won't address the problem in some areas. Some indicated that healthcare is even more expensive for rural families and that we need to keep a human impact perspective. Others mentioned that under OCA's recommendation, at least healthcare costs wouldn't outgrow wages and income. It also aligns with Oregon and Washington or other West Coast states with spending target programs. Others suggested that the 3% is quote, the least we could do with no population adjustments. It won't make healthcare more affordable, but may keep it from becoming more unaffordable. Others suggested that higher wages due to healthcare worker minimum wage law or labor contracts do not automatically mean that costs will go up proportionally. Higher wages could mean more productivity, less turnover, and lower recruiting costs, resulting in better care so patients are healthier and could ultimately drive down costs. Some members did have concerns with the 5-year statewide target timeframe and encouraged getting to sector-specific targets as soon as possible. These comments included different entities are starting at different places, so there's geographic or sector-specific diversity that needs to be taken into consideration. Others indicated that costs are skyrocketing due to certain failures, such as network adequacy, which can lead to delays in care, and that costs are not always realized where they are created, and that we should not make the job harder to reduce costs by restricting the tools that providers have access to because of outside forces. Some suggested that it doesn't make sense to assess the same target to a high-cost provider versus a low-cost provider. Early sector targets could help with credibility. Members had differing opinions and comments regarding adjusting the future cost target based on trends in the price of healthcare technologies, such as some suggested that it's hard to quantify what any adjustment might be, maybe discuss in real time as new technologies are introduced. Others suggested that we should consider adjusting the target downward as well. For example, more effective drugs should reduce costs and improve outcomes. Electronic medical records and AI should increase productivity. Some technology components have known costs. For example, specialty drugs and devices. There's a suggestion that we look at the price trend over the past 5 years and include it in the target calculation rather than doing this retrospectively. Otherwise, plans and providers will limit access to managed costs. Others suggested that retrospective analysis is the right direction. Any technology or new unknown will impact sectors differently. A new drug that increases costs may not impact other parts of the system. Adjusting prospectively will create inequalities within the system, and we need time for this to play out. Prospective adjustments is an inappropriate use of pharmaceuticals and would push prices up if cards are shown to the pharmaceutical industry. And retrospective sounds like a big carve-out or an exemption. What would be the incentive to manage prospectively if folks get a hall pass on the backside or on the side of enforcement? So this was just again, trying to capture the themes and summaries that we heard and some direct comments that we heard from the advisory committee. Board Member Lewis, I know that you were the board member attending, and I know that we discussed this back in January, but if there's anything else that you wanted to add or highlight from the discussions in January.
The only other item I wanted to flag, it was one comment that really stood out for me from one of the advisory committee members, speaking to cost as barrier to access and just staggering infant mortality rates among the Black population in rural areas. Really goes to underscore what Director Landsberg opened our meeting with, and it really stood out to me in that meeting. That's all I wanted to add. Thank you.
I'll hand it back to you, Michelle. And
I just wanted to also give the board members a chance to react to any of the feedback we're providing.
Richard?
Thank you. I know we brought this up at the last meeting, and of course we're taking public comment. Is the advisory committee going to have an opportunity to meet to review the public comment prior, and then, so appreciate this discussion, but this is obviously in absence of being able to review public comment, which of course is still coming in, so the deadline has not passed yet. So will the advisory committee be meeting to review the public comment and then giving us additional input into before we make our decision as a board?
Yes, we rescheduled and we moved up the advisory committee meeting to happen before the March board meeting, and we'll be relaying the public comment received to the advisory committee, and then also relaying it back to the board.
Okay, that I appreciate that. Another comment I guess I would make is that, and I appreciate the discussion about cost as a barrier. Certainly as a physician, I see how cost can be a barrier, but I also make note that I think it was yesterday, LA Times had a report about Medi-Cal and well child rates, right? So we, as a pediatrician, we do these exams to screen patients, and so we can intervene earlier if we identify problems. Medi-Cal, there's no cost share for these visits. So in some ways, price is not the problem, but yet we have a very low rate of people getting to those visits. And in fact, this is not a one-time finding. This was based on an auditor's finding that went back. I actually had a hearing about it when I was in the legislature, and this seems to be an ongoing problem. So, and when we're talking about things like, for example, Black infant mortality and maternal, et cetera, I mean, a lot of times what happens is when people are missing screening, for example, they're not getting prenatal care. Obviously, this was not about prenatal care, or they're not getting their well child visits. We're missing opportunities to intervene. In fact, actually later on in life, for example, even the military has commented that when people come and try to join the military, that they've oftentimes identified people with unmet, with care that they did not get, problems they did not identify in childhood that could have been averted. So I think and one of the one of the issues that was raised was actually perhaps that payment for physicians who were providing this care was way too low, and so that made access a problem, right? So there wasn't a case of the patient having a financial barrier, although there was other barriers certainly that they have, but that was the access barrier. And so I think it's important we look into this, and that we don't, in our actions, don't make that problem worse for patients. So as we look at, Medi-Cal covers half of all children, half of all deliveries. So, and in fact, disproportionately has a higher percentage of people of color who are in that system. So I think we need to look carefully at what we're doing so that we're not exacerbating the problems and baking in. I think some people have commented, not everyone's at the same place at the starting line. And so part of it's how do we apply this cost target to different entities, different groups. And I guess finally, as we're talking about this, one of the things I also hope that we can also look at, aside from, we're picking out a number, but exactly for this, I know in the first year it's non-enforceable, but if you're really going to talk 5 years, and I think that's actually in some ways counter to the original intent of the legislation. The reason we have first year not being enforceable is to learn from that. So we're already baking in 5 years. But exactly how many entities are we going to take this target and apply it to? We should have an idea about, so what exactly is the workload burden on the agency? So how many individual entities are we applying this to? So for example, are we, well, I assume for Kaiser, because we actually have specific language that it would be Northern and Southern California Kaiser. We're not going to break it up into separate pieces. I don't know whether we're going to, for some hospital networks, apply to the whole network or to individual hospitals. Same with medical groups, so forth. Exactly how many entities are we going to apply this target to when we finally make it enforceable? So I'd like to know that number and also the subcategories. So exactly, and so exactly what is the burden if we decide to pin the number at a point where 60%, let's say, of everyone is over the line. How many entities are we talking about? We're going to have corrective action plans and other types of things that we're looking at. So if I can have that information at the next meeting, I'd appreciate that. Thank you.
Thank you.
Yes, we could follow up on that.
Thank you, David.
Yes, I was just going to make a comment about technology, and this kind of harkens back to my days as a early health services public health student, and we were talking about healthcare technology in health economics classes, and I was fully educated on the difference between introductory cost of technology and eventual system cost of technology, and the introductory prices were always really high, intimidatingly high. One example was what became a very common surgical procedure, and I won't be more specific because I won't necessarily invoke a specialty specifically. But this is a procedure that was initially done as an open procedure involving a scalpel and things like that, and it took a long time, and it was very expensive. It was labor intensive. Within a few years, however, more expensive technology was introduced that shortened the time for the procedure significantly. However, the surgeons' reimbursement rates remained the same. They were doing 4 and 5 and 6 times as much surgery, getting paid 4 and 5 times as much. but the cost was a fraction of the original cost. The reimbursement, the actual cost of the procedure remained the same, even though the cost of performing the procedure was much lower. So it's just an example. I think we see examples today. We have high introductory costs for pharmaceuticals, for other types of technology, but those won't reflect the downstream expenditures associated with that, especially when we factor in the system effects, the public health, lives saved, productivity enhancements, things like that. So I think cost and technology require a more sophisticated perspective that looks at the long-term benefits versus the long-term costs, not just the upfront, very expensive cost of technology.
Elizabeth?
Thank you. I hadn't intended to comment on technology, but I really appreciated Dr. Carlisle's comment because I work with manufacturers and tech companies from other industries, you know, Apple, Microsoft, Salesforce, and to Dr. Carlisle's point, like costs go down with adoption of effective technology and deployment. So anyway, I think that is something we should be really considering as we as this goes forward. But my other thought is on the maternity issue, because I can't speak to Medi-Cal. I know that obviously many of the barriers to making those appointments may not be out-of-pocket costs, but include transportation, time off work. And we also know that income is going down because wages are harmed by healthcare costs. But I represent sort of commercial purchasers, and they pay for the other 50% of births. And there are major cost barriers on the commercial side for maternal health care, not only sort of in addition to the maternity deserts and all of the other access problems we're having, cost of childbirth, of prenatal care, all of that are creating significant barriers on the commercial side. Again, can't speak to Medi-Cal, but I think we've got to really look at that because it is a crisis and it will have long-term impacts. Obviously, the longer-term health impacts of poor prenatal and early child care are substantial.
And just as a representative of the state, want to note, deep concern about the fact that more Medi-Cal children aren't having their wellness visits, and of course their well child visits, and of course that's a responsibility. 99 point whatever % of those children are in a Medi-Cal managed care plan, and of course DHCS is taking significant steps to hold the plans accountable for making sure that those children get their well child visits, and it's why. One of the reasons, as you know, that the legislation is balanced to make sure that we're looking at equity and quality standards and investing in primary care to make sure kids are getting their well child visits, including in Medi-Cal.
Thank you. Richard, did you have?
I also wasn't commenting on technology, but given the conversation, two comments. One, I mean, there are, I think, as we all know, exciting technologies that are cost reducing. I was talking the other day with a health system administrator who was talking about the introduction of AI scribing tools that are writing physician notes, and the primary care physicians in the system, they're still kind of testing that out, are reporting 90 fewer minutes a day writing their notes, and at least so far as they try to evaluate the quality of the notes, it looks to be, the scribing tool is not hallucinating, at least, and they're also saving money on not having scribes. So very exciting stuff. On the other hand, we all know, or at least I, and I'm sure many of us have, many colleagues and friends with hip and knee replacements that 20 years ago would have been hobbling around, and that obviously is cost increasing technology, and there will be more of that. But I did not intend to talk about technology. I have one minor question of clarification and then a process question. The clarification question, CJ, if you go back. On my deck, it's slide 25. slide or two, I think. Yes. So there's a comment there, don't make the job harder, reduce costs by restricting tools providers have access to because of outside forces. And I didn't understand what that was.
So I think this was more in the context of making sure that we have sector-specific targets sooner than later, as opposed to a uniform approach across the board, because there may be areas within the healthcare industry that need to grow at different, should grow potentially, was the, I don't want to put words into the speaker's mouth, at different rates, and if everybody's at 3% immediately, there could be undue consequences to that.
And then the process question, I mean, I think as board members, we all can, and I appreciate the more detailed feedback on the advisory committee. We can all read that feedback, listen to the advisory committee discussion, and form our own opinions about the credibility, validity, strength of the arguments that advisory committee members make. But I wonder, as process, is the office planning any response from your point of view to the arguments made by advisory committee members, or is that left entirely to board members for each of us to form our individual opinion?
Thanks very much for the question. I think we can certainly take that back, and if the board would find it helpful for us to address some of them. I think, you know, the statute requires us to make a staff recommended, an office recommended target and methodology, and we have done that. So certainly, to the extent there are any changes in our recommendation based on the feedback that we've gotten, we would report back to the board on that. But we can take back whether it be helpful, or you can express a view as to whether it would be helpful for the office to respond to some of the comments.
I think it would be helpful.
Okay.
Is there a right answer, dear? Yes, I think there is. It would be helpful to me. There are some comments about, say, the age adjustment that seem like there was a fairly easy response, that maybe it shouldn't be part of the target, but we've already discussed adjusting individual provider performance for age and gender. And I saw the comment about Medi-Cal dollars being put into the system. Maybe again, a comment there about kind of back-end adjustment rather than front-end, but others that is sort of less clear to me what the response might be, and to the extent that you got responses, it would be helpful to see.
Thank you.
Thank you. And I do know later in this section, we're going to be looking at some of the downstream implementation questions, and maybe in that context, you might address some of that. Vishal, back to you.
Thank you. So our next portion of this agenda item is to follow up on some board questions we had at the last meeting, as well as returning to an earlier topic. So the first two items listed here are related to board requests for more information from the January meeting. The third item, regarding the extent to which healthcare spending affects employment-related outcomes, is a follow-up from an earlier board meeting. Board member Kronik had requested a projection of spending target impacts on the healthcare workforce. Board member Mitchell also expressed interest in OCA identifying impacts of healthcare spending on other sectors beyond healthcare. Based on our review, we did not find any publicly available research on the effects of healthcare spending targets on the healthcare labor force that could inform a projection along the lines requested. In our search, we did, however, find several studies that examine the effects of healthcare spending on employment-related outcomes. Today, we'll provide a summary of that literature. So I'll cover the first item, which is changes in per capita spending from 2020 to 2021. And the next slide. To give you a little background, in January, we shared information about the 5 states that publicly reported their performance against their targets for 2022 to 2021. We noted that only Rhode Island had met its cost growth target, while Oregon exceeded their target by 0.1 percentage points, growing at 3.5, just above their 3.4% cost target. We also noted that the other states, Connecticut, Delaware, and Massachusetts, surpassed their targets by 3 to 8 percentage points. In today's presentation, we've included a Health Affairs blog post from last June, which goes into more detail about the 2021 healthcare spending performance for these states. Specifically, the performance is broken out by market category. The observations include that, all states reported increased healthcare spending in 2021. This growth was expected since COVID-19 contributed to a sharp decline in utilization in 2020. In particular, there was double-digit growth in commercial spending, which contributed to overall spending growth in 4 of the 5 states. Rhode Island was the exception. Some explanation for Rhode Island's performance is that they have a existing statute that allows them to cap the growth of hospital prices. I'll just kind of pause here in case board members have any questions.
Richard?
Yeah, I'm curious because we see a large variation in the Medicare increases. Do we know what's driving the large disparity? Can I get from 1.4 to? This is a federally run program, right? In fact, Connecticut and Massachusetts and Rhode Island are, well, they're not in the same healthcare market, but in their same sector of the country. And then, of course, we even see the variation not as much in the Medicaid side, and of course, that's maybe driven somewhat by state decisions. But so I don't know if there was any comment about that wide variation that also happened in the Medicare space.
Yeah, I just want to check if Michael Billett's on the line, and if we could unmute him.
Yep, I'm here.
Hey, yes.
I'm here, but I'm afraid I don't have an answer why there's so much variation in the Medicare spend. I'll note that the Medicare spend includes both traditional Medicare and Medicare Advantage, and the Medicare Advantage penetration by state is variable. And so that might be a factor, but I can't tell you why it varies to the degree that it does, and it's considerable, as you see. There's also variation, although not as dramatic in Medicaid spending.
Okay, all right. Yeah, I'd be curious as to, because even as we're trying to apply, or even as these states try to apply a uniform cost target, right? And we're talking, so unlike commercial, we're talking, yes, there is traditional and there's Medicare Advantage, but this is essentially our country's single payer system, and we see all this variation state by state, right? And so understanding that might provide us some insights as to what's going on, how do we effectively or not effectively manage cost targets, right? As a state, as a government entity.
Yeah, I'll note that one limitation that states have when understanding Medicare spend, especially traditional Medicare or Medicare fee-for-service, is that CMS does not provide a breakdown of traditional Medicare spending by service category the way that states collect it from insurers. So it makes it difficult to understand, at least in the traditional Medicare market, what's driving overall trend.
Thank you.
Richard.
Thank you. And Michael, you may have done this already, but given how strange or how anomalous spending was in 2020 and 2021. It would, I think, be more useful to see this for 2019 or 2018 to 2021, kind of on an annual basis. Even that will obviously be somewhat strange, but at least a little bit more normal to kind of smooth out the 2020 dip and the 2021 increase.
Yes, right. This was a really strange year because of the rebound from 2020. So we do have data for preceding years that I could prepare to share with you. I will note that these states will all be reporting their 2022 performance over the next couple of months. And so we'll have what I'll call, quote, post-COVID data very soon.
Yeah, that would be helpful. And following up on Richard's question, you again may have already told us this, but if you could remind us how the Medicare spending data are collected. What combination is that from CMS versus from payers reporting on Medicare Advantage?
Sure.
And then just a comment, Vishal, you said correctly that Rhode Island, the rate of increase is lower than in other states, and that may be partially due to the hospital rate control or price control mechanism in Rhode Island. It's still pretty high number, obviously. Yeah.
Yeah, I'll say, Rick, across all these states, most of the growth that occurred this year was utilization, whereas in prior years, particularly in the commercial market, it was increases in payment per service unit that drove spending growth. In 2021, it was growth in utilization, particularly after it was significantly depressed and actually declined in 2020. And that was the case in Rhode Island. I'm sorry, there was a question that you asked. Oh, about Medicare. So for Medicare Advantage, for commercial plans, for Medicaid managed care plans, states typically collect spending data from insurers by market and by broad service category. And by that, I mean retail pharmacy, hospital inpatient, hospital outpatient, professional long-term care, other. Medicare fee-for-service data that comes from CMS does not provide a breakdown by service category. They give total spending and they give a count of covered lives, and that's it. They also do not provide data at the provider entity level. So that's the difference and the limitation in trying to understand the submission from CMS.
It probably makes sense to me, at least, to investigate the feasibility of using the individual level fee-for-service claims information that CMS makes available to researchers to be able to do more with the fee-for-service data than is published by the sources that you're looking at. There is, question of timing and claims lag, but CMS has gotten better at making those data available. I've been using both fee-for-service claims and Medicare Advantage encounter data for the last year and a half or so. And I believe that 2022 fee-for-service data are now available. It would take some resources on the part of the office and a data use agreement with CMS to do that. But worth looking at.
Yeah, Rick, the HPD or California's APCD includes Medicare claims data. So we'll, as part of our cost driver analysis, that will be available for us to look into to drivers of what's spending, because the aggregate numbers only tell us so much.
Yeah, Rick, the all of these states have complementary analyses that use their all payer claims database. The problem with the traditional Medicare is it's significantly delayed. And so, you noted that 2022 is available. I can tell you that none of these states have 2022 data. I shouldn't say none of them. Those that I know of do not have 2022 data in their all-payer claims databases yet. And so that's the challenge. You do get it, but you get it really late.
Yeah, I know that ours was delayed. I think I'm not sure HPD has 2022 data yet, although I hope we'll have it soon.
Yeah, I guess it is available to researchers. So it's through ResDAC, through a data use agreement. There may be some delay in getting it into the HPD, but trying to figure out what that is and when it can be sped up, yeah, it's worthwhile.
So I think we should move along, but before you go, Michael, I believe David has a question for you.
Yes, greetings, Michael. I assume you're in the frozen city of Boston somewhere. Greetings from California. My question was similar, and I think you've spoken to this already, but you mentioned states making their data available in a few months, and I was going to basically echo the same sentiment. Is there any way to facilitate our access to the data even before it's formally reported by the states?
They guard their data pretty religiously because it's a big event in these states when they report out their performance every year. They usually do so in a big public meeting or a press release or a big report. So it would be difficult to get them to provide it in advance. I can tell you that I know that spending growth was far, far reduced in 2022 and much closer to these states' spending target levels. I'll also share with you that I do not think that that's going to be sustained in the performance that we're going to see for 2023 and 2024. And that's due to the lagged impact of the increase in inflation.
Thank you, Michael.
Mm-hmm.
Back to you, Vishal.
Thank you. I'll now turn it over to Andrew Fair. As I mentioned, he's a research manager in the Healthcare Spending Targets branch, and he'll cover the two remaining discussion items.
Thanks, Vishal. So just for background, this is a inquiry that Don Moulds had during the January meeting, which effectively centers on the differential between historical spending growth and the initial state spending target values that states arrived at. Volume. Is this better? Yeah, it is. All right. Sorry. Okay. So, sorry. Okay. Here we go. Board member Moulds was interested in the extent to which there was variation across states with respect to their initial spending target values and their historical spending growth patterns. California has the added benefit in that in summer of 2023, CMS updated its time series of state-level healthcare spending data on a per capita level, but every prior state only had access to the 2014 time series. And so obviously up to 2014, you end up missing a number of pretty consequential policy developments in the healthcare space. So what we ended up doing is looking at absolute differences in the state's initial target values, as well as their latest target values relative to that 20-year time series to which they had access at the time they were setting their spending targets, which was up to 2014. And because the next slide is a little bit busy with numbers, we'll just sort of give you the punchline here, which is that states' initial target values were between 1.3 and 2.2 percentage points lower than their 20-year average spending growth rates. And then if we look at their latest target values, which tend to be lower on average, that differential increases marginally from between 1.4 to 2.6 percentage points relative to their 20-year average growth rate. And so we can go to the next slide just to sort of concretize what those differences look like. So just looking across that first row there, we'll start with Connecticut, just for illustrative purposes on how to read the table. So if we look at that 20-year time series from 1994 to 2014, spending growth in Connecticut was 4.8%. Their initial target value was 3.4%. And so that difference in absolute terms was 1.4 percentage points. And then we have two entries there, the last two rows for California. So we sort of mock it up in two different ways. One, assuming we only had access to the same time series data that other states did, which would have been up through 2014. And you can see there that 20-year historical spending growth rate was 4.7%. And so under the proposed 3% spending target, that materializes into a 1.7 percentage point difference. And then that last row there has that updated time series through 2020. And so there you see 5.4 minus 3.0 gets you to that 2.4 percentage point difference. But whether you look at sort of the initial or the latest target values, that California difference is relatively consistent with what you see in a couple of other states, including sort of Oregon, our counterparts in Washington, among other states like Delaware. So happy to pause here and make sure that we addressed Board Member Molds' question.
Fortunately, Board Member Molds isn't here. I know Dr. Pan will have a question. I also, I want, just in terms of time, I want to recognize that we're a little behind, but Dr. Pan, please.
Thank you. Well, I would note that the gap is larger for at least what we're proposing, as shown in this table, right? If we're talking 2.4, that's actually the largest number, minus maybe Oregon. Oregon, Delaware, but you know, it's in that range. But I guess just to follow up on my previous request in terms of getting the, you know, exactly how many entities, because again, California is a large state, it would probably be good to also know, and I assume these states also looked at particular entities, let's say what the top 100 entities we're going to apply these to when we establish our target in terms of at least the 100 largest entities that the target would be applied to is in our process. Thank you.
All right. Any other questions before we move on?
Rick?
Very quickly, and this may be more a question for Michael than for you, Andrew. If I'd been sitting in one of these states, I know that the state health spending data were only available through 2014, but there was national health spending data available, you know, through a year or two prior to setting the target. I would have probably taken the state health spending data and then adjusted it upwards or downwards by changes in national health spending in the intervening years. And I wonder whether states were doing that when they were trying to anticipate or trying to estimate what the growth had been in the 10 or 20 prior years.
So I can take a first pass and then I'll pass it off to Michael as well. So I should note there was a paper by Johnson et al. That was published in 2022 in Health Affairs that tried to close that gap between sort of that time series. And so what they ended up doing is estimating state level per capita spending through up to 2019 and provided annualized growth. The extent to which states actually leveraged a Health Affairs article, I would open it up to Michael. Obviously, we at HCI, we don't currently have a subscription to Health Affairs, but we're working on that. And maybe others were willing to pay. We're getting there. The work order is in process. But I would defer to Michael on whether or not other states were using some sort of creative arithmetic to sort of back into filling out that trend.
Yeah, Rick, the other states did not do so. I'll also say that they considered historical growth, but to differing degrees, they were not fixated on it. In some cases, they were also looking at what was happening for premium growth. And in Oregon, there was a legislative directive for spending growth for their Medicaid and public employee health plan. So that the states often were considering a few different reference points when they were setting their target, in addition to looking at the 20-year growth. But to come back to your question, none of them did the type of approximation that you are suggesting.
Ready to move on to the next item?
Please go ahead.
All right. So this is, as Vishal noted, in response to Board Member Mitchell's request to dig into a little bit more about the effects of healthcare spending on employment broadly, and particularly with a focus on non-healthcare sectors of the economy, as well as looking into the effects of healthcare spending on wage growth or depression on wages. So we can go to the next slide. So the approach we took here was commonly referred to as a systematic review. You can think of it kind of like a structured literature review. And so what we did, based on access to the databases we have here at HCI, we looked at 3 different databases, the National Bureau of Economic Research, or NBER, JAMA, and PubMed. And the inclusion criteria we used for a systematic review basically had to be an empirical evaluation done in the US within the past 20 years. So that means we excluded editorials, commentaries, and theoretical articles or theory-based articles. Lots of titles that seemed relevant, but ultimately at the end of the day, about 15 articles kind of met the inclusion criteria for the question of interest here. And so those articles fell into 2 kind of broad buckets. So basically the effects of premiums on employment-related outcomes, and then the effects of adverse health events. So things like hospitalizations, which obviously increase spending, and how those then have downstream consequences for employment-related outcomes. As with any empirical approach, systematic review is not going to be without limitations. So in this particular context, if it's not published, it's going to be hard to sort of pick up on these unpublished studies. And we know there's kind of a file drawer problem that often persists in academic contexts. And then obviously we didn't touch on the gray literature. So things that are published outside of traditional publishing formats, we're not picking that up in our systematic review. So just want to hands on the table as far as how we can interpret a systematic review that focuses on published studies. We can go to the next slide. Okay, so we'll summarize briefly that initial bucket of papers. So when we look at kind of the effects of premiums on employment-related outcomes, so we'll focus on both kind of the extensive margin, right, whether or not you still have a job, and then the intensive margin. There's a lot of sort of bundle of different characteristics associated with one's job that could be affected by higher premiums. And so there are sort of adverse effects on both dimensions. So higher and rising health insurance premiums, particularly within the employer-sponsored market, tend to be associated with reduced probabilities of employment, reduced hours worked, increased likelihoods of part-time employment, lower wages and total compensation, reduction in benefits, greater employee cost sharing, and then higher rates of unemployment in non-healthcare sectors, which then have kind of downstream consequences on sort of what are known as deaths of despair in the academic literature. We can go to the next slide. So then the second kind of bucket of studies here, looking at adverse health events. So the effects of, say, a hospitalization on subsequent employment-related outcomes. Here we see increased likelihood of disability claimants, decreased likelihood of employment that has spillovers to other members in the household who serve as caregivers, increased out-of-pocket medical spending, unpaid medical bills, higher rates of bankruptcy, and then reduced earnings and income associated with that decreased employment probability. We can go to the next slide, and this will be kind of a deeper dive or a little bit of a case study on the last paper that made entry into our systematic review. And I think this speaks quite directly to Board Member Mitchell's inquiry about wage stagnation potentially. So you have this recent JAMA Health Forum article by Hager et al., which looks at both overall effects of ESI premium growth on compensation, and then it stratifies that outcome by income quartile or quintile in this case. And so you can see the pooled results that they find is between 1988 and 2019, so 30-year period, the share of compensation absorbed by ESI premiums increases by about 10 percentage points, so just under 8% up to just under 18%. And then this figure here from the paper focuses on income quintiles. So the effects are much more pronounced for those lower on the income bracket. So in 2019, for example, the most affluent folks in their sample, so those who make 95% in the 95th percentile of compensation, allocated about 4% of their compensation to ESI premiums, whereas those in the lowest 20th percentile allocated about 28% of their compensation to health insurance premium. So obviously we've heard about the regressivity of ESI, and this is just sort of an empirical instantiation of that phenomenon from a recent paper. And then we can turn to the next slide. Last bit from the paper here. So the authors then work through an exercise where they simulate sort of lost wages or foregone wages due to growth in ESI premiums. And so they assume a counterfactual wherein employee compensation as a share of premiums remain fixed at 1988 levels, and then they sort of use the actuals that they observe from ESI premium growth to then accumulate foregone wages. And so over the course of that approximately 30-year time series, they estimate on average that the ESI premium growth has resulted in about $125,000 in foregone or lost earnings as a result of premiums. So I know we're short on time, so I will stop there and see if there are any questions.
Thank you. Elizabeth, we'll start with you.
Thank you. First, I just want to thank you for the thoroughness of the response. I really appreciate it. And it's, it is as stark as expected, and the impact on affordability, I think, is obvious. There's another study I heard of. I'm sure it's not in here because it's very recent, but it said millennials will lose half of their lifetime earnings to healthcare cost. So whenever that makes its way through the literature, it would be an interesting addition. But I just, again, I mostly wanted to thank you for the thorough and thoughtful review. And I think because our charge is addressing affordability and its impacts, I think it's very helpful. Thank you.
Thank you for the presentation. I would make note, as someone who graduated medical school in '91, that medicine is not the same now as it was back then. There have been a lot of advances. The other thing is actually the previous slide. I am curious, what was the impact of the Affordable Care Act? Because I know you have this thing going up all the way back to 1988. So that was passed, we had a lot of, by the way, there was a lot of cost shifting, adverse selection going on. So, this is looking at people who, but you had people who basically got into job lock, et cetera, because of the discrimination against people with pre-existing conditions and so forth. So is there any comment about the impact of the ACA on, and it look at sort of, I guess it's around 2010, 2011, right? Not to say that we can't do better, but it looks like it flattens out a little bit there. But was there some analysis of the impact of the ACA, which is obviously a very large event that happened in terms of the healthcare market that was in existence back in 1988?
I'm hesitant to speak extemporaneously on somebody else's research in that level of detail. So we can take that offline and just follow up if there were any ACA specific nuances associated with that analysis. I suspect, to your point, there's going to be some compositional changes in sort of the survey sample as a result of take up of different coverage sources. But beyond that, I don't know exactly how they treated the ACA in their time series. So it's a good question, though. Thank you.
Rick, please.
Thank you, Andrew. I add my thanks to Elizabeth. Thanks. I am chagrined at the lack of response to my request, but understand that there may not be anything in the published literature on that. A parochial comment, and perhaps this was missed because it was too old, or maybe because you don't have a subscription to Health Affairs, but in the mid-90s and following, I and my colleague Todd Gilmer published 2 or 3 articles about the effects of rising premiums on the number of uninsured people that connected rising premiums to increases in uninsured. Richard's last comment, I would hope that that analysis is no longer valid post-ACA. My suspicion is that it probably, that the relationship has attenuated, but maybe hasn't completely disappeared. And it might be worth noting that one of the effects of rising premiums is to increase the number of people who are uninsured entirely. Again, post-ACA, probably not so much, but maybe.
Just to pick up on, and I, again, realize we're short on time, we did look into trying to sort of draw blood from turnips, so to speak, in addressing your question. There are 2 recent articles. I think the way we sort of approached systematic review, the right-hand side variable was healthcare spending of some form or another, and then the right-hand side variable was, or the dependent variable was sort of employment. I think your question spoke to sort of what are the effects of a spending target of some form or another on unemployment or employment change. There are 2 recent articles that just speak to descriptive trends in the employment workforce in the healthcare sector. And so what that speaks to, and I'm going to stylize a bit here, there's a dip, a pretty substantial one during the early stages of the pandemic, so 2020 and 2021, and there's been a pretty robust rebound in 2022 and 2023. I think the article just came out as recently as last week in JAMA Health Forum by Auerbach and al. That's not speaking directly to the relationship between spending growth or spending change on employment in the healthcare market, but it suggests that there's been a pretty strong rebound from the pandemic among the healthcare workforce. So not sure that's entirely satisfactory, but those were 2 articles that we did find that kind of address specific healthcare related dynamics in recent years.
It's sort of close and would be helpful, I think, to summarize for the board.
And I think Michael Baylett has his hands raised. Could we unmute him? He may have a response on this.
Thank you. I don't have a response. I actually just wanted to note that in this slide that's before you, that it only includes premiums and it doesn't include out-of-pocket spending due to coinsurance and deductible, which we know during this time period exploded for people with commercial coverage.
Thanks very much for that, Michael. I think we're going to hear some more about that later today, but I'll say in my own experience, if you hold steady for plan design, the numbers on this chart are perhaps double that number in the Bay Area at least. Any other questions on this topic? If not, I do at this point. I think we're going to have to move forward. We're probably going to have to shrink our lunch break, but we'll move on to the next piece, Michelle.
Thank you, Board Member Lewis. So I'll be shifting gears to our next portion of this agenda item. And I want to lay out some context for this discussion. So we'll be spending some time discussing how OCA will approach assessing performance against a statewide spending target. The reason we want to have this discussion today is that we've heard from several stakeholders that have advocated for adjusting the target for what they consider drivers of healthcare spending. These include, but are not limited to, new state mandates or the high price of specialty drugs, for which providers may or may not have many levers to manage costs. Because a driver of healthcare spending, such as high-cost specialty drugs, does not impact every payer or provider in the same way or by the same amount, OCA's point of view is that it would not be appropriate to apply a uniform adjustment to the spending target. We've also said the same with regard to applying a technology adjustment, because it would assume equal rates of adoption across all healthcare entities, which is not consistent with practice and the literature. Nonetheless, OCA acknowledges these issues are important and valid. Today, we'll focus on how we can consider these issues and where OCA believes is the most appropriate place to address these issues in the implementation of spending target programs. Today, we want to focus on issues that can be taken into consideration when determining compliance with the target, and note that there will be many more detailed implementation questions and conversations that will follow in the months and years ahead. So I'll take it to the next slide. So this slide lays out the 3 phases of spending target implementation. The first step is to set a target value. As you all know, the conversations to date have been rooted in consumer affordability. And then along the lines of what I spoke to just now, a statewide target cannot uniformly account for circumstances impacting each entity's performance against the target. And the second step that we're showing in the dark green is assessing performance. OCA will assess each entity's performance against the target. During this phase, OCA can consider circumstances that may have impacted performance. The third step is progressive enforcement. This details how progressive enforcement works. The details on how progressive enforcement works will be an area of future board discussion and public engagement. As a reminder, the components include technical assistance, public testimony, performance improvement plans, and as a last resort, financial penalties. For today, we want to focus the conversation on the middle green box of assessing entity performance against the statewide spending target. We'll begin by covering what's in the enabling legislation, and we also want to get the board's input on additional reasonable factors that may impact entity performance against the target. Next slide. So here we cover portions of section 127.502.5, which is the relevant health and safety code pertaining to healthcare spending targets and enforcement. I'm drawing your attention to the language we bolded, in which the director shall consider each entity's contribution to cost growth in excess of the applicable target and any actions by the entity that have eroded or are likely to erode access, quality, equity, or workforce stability. Factors that contribute to spending in excess of the applicable target and the extent to which each entity has control over the applicable components of its cost target. In the next slide, the rest of the language from this section summarizes the progressive nature of OCA's enforcement approach. So this is all part of section 12750.2.5 subdivision A. Next slide. OCA has heard from the board and the public about potential factors that should be considered when assessing an entity's performance against the target. Such factors may contextualize an entity's spending growth, as well as potentially mitigate steps in the progressive enforcement process. Some of the potential factors that have been surfaced to OCA by the board, advisory committee, and stakeholders include statutory changes impacting healthcare costs, investments to improve care and reduce future costs, acts of God or catastrophic events, emerging and unforeseen advances in medical technology, and then, as I mentioned, the high cost of pharmaceuticals, costs associated with increases in organized labor costs, and then annual changes in the demographics of the population. Next slide. So, we want to have a discussion about the factors that we've laid out, and we also want to solicit input from the board about additional reasonable factors that may impact entity performance. And I'd now turn it back over to the chair to facilitate discussion on this item.
Thank you. So I should say I've been asked by some members of the public if we're taking action on the target itself, and we're not. There's an open public comment window till March 11th, so there'll be ample opportunity for us to discuss that if without limiting any of the discussion here as much as we can focus on the question here on the board. That would be ideal. Thoughts? Richard?
So I appreciate the list. I think there's other things that in the statute that in terms of things we should think about adjusting for. But aside from the factors, I guess the question is how we're going to go about doing this, right? And we need to do it in a way that engenders people's trust and confidence in the decisions that are made. So, for example, let's just take cost associated increased organized labor costs. Are we going to have a safe harbor process by which, obviously, we're going to have to negotiate different things, but that basically, is there a process by which you can submit information and if you're following certain guidelines that we're not going to have to sit there and wait for the office to process that or make a judgment or whatever, that we clearly understand that this is, that if you negotiate a collective bargaining agreement and if it's a 6% increase that we're going to allow not for 6% across the board, but the proportion, et cetera, for that labor cost or not. That is there, are we going to create essentially policies about how we're going to address these things in a way so we can apply consistently across the different entities, so that there's clarity to the entities as to how they can get that kind of adjustment versus, well, we don't know and we'll look at each one as they come and it could be arbitrary. And so I think we need to be sure we don't have arbitrariness in decision making.
Thank you. Vishal, do you want to respond or take?
Yeah, sure. So those are good questions that you've flagged. Those I note that they're more operational and kind of operational questions. We do certainly, want to bring that back to the board for discussion. But for today, we wanted to kind of focus on the reasonable factors that could impact entities' performance.
Elizabeth?
Thank you. I have a question. A lot of these items that you've listed here, obviously they are dynamics, but won't increased transparency help staff identify them? Like if you have more visibility into drug cost, as an example, and the increased available of hospital and TIC data coming from CAA and other federal legislation will make those more visible. So I'm just wondering how you will sort of integrate this increased transparency with some of the evaluation.
Yeah, thank you. I think we'll absolutely look at the additional I mean, I think we have both HPD as a tool, and we can certainly look at some of the other transparency data that's available as we do our report on the trends, and we'll have to. I think that will be helpful. Yeah, thank you.
Back to you, Richard.
Well, in terms of factors, I think one of the other things we need to look at is, and I, as I again referenced our the lack of well-child visits in our Medi-Cal program, but you do have things, certainly we have things you can point to that we quote maybe overpay for, but we also have things we underpay for that have significant public health consequences, right? And so actually vaccine administrative fees often are lower than the actual costs for many practices and so forth. People do it because it's important for public health, and so they eat the cost. But so I do think that, and I'm looking at our Medi-Cal program where we have for decades actually tend to underfund and expect people to cross-subsidize with commercial, et cetera. So I think one of the issues maybe is that we talk about statutory changes, but basically figuring out how do we correct for underfunded entities, particularly and I would particularly make note, we've talked about how do we incorporate public health and so forth, right? But if there's so again, when we're applying a target and we're saying whatever percent that is, well, if it's significantly underfunded, and actually we're trying to correct for that underfunding as a matter of public policy, we don't want to then have that entity go back and say, well, great, you can only take this money if we, not deliver other services and so forth, so that we don't have unintended consequences. So I think we need to look at that, and particularly things that have been primarily funded by the Medi-Cal program in the past.
Thank you. Richard and then David.
Thank you, and thanks for this list, Vishal. One item that's not on the list, we've had robust discussions earlier about clinical risk adjustment, and we have made the decision or the recommendation, and I think the board or the office has adopted it not to do clinical risk adjustment. But if a healthcare entity's patient base has changed significantly, particularly if they've changed provider groups with which they're contracting, I would think that an adjustment for potential changes in the acuity of the patients that the healthcare entity is taking care of would make sense, and it's not on this list. And then I think maybe implicitly on the list in the first statutory changes, but might be good to make explicit is changes in Medicare and Medi-Cal reimbursement. We've heard from the advisory committee the investment that Medi-Cal is making, and that should be reflected. And again, that may be implicit, but making it explicit would, I think, be helpful. And then relative to or following on Richard's earlier comments about sort of how would this get done, I would second the recommendation for developing criteria and algorithms that are explicit as possible and as uniform as possible. I worry that the healthcare entities that have better consultants and are able to hire people to put together the argument more convincingly will do better. And those that, either have fewer resources or have made poor decisions about which consultants to hire to put together the case, will do worse here. And particularly if we go forward with a target at 3%, and my expectation is correct that a very large fraction of covered entities will be above that target. So you'll be looking at a lot of requests for adjustments that we may end up with an inequitable and inefficient system. So trying to make this as uniform as possible would, I think, be very helpful. And then finally, a question, at what point will we be discussing adjustments in the target itself? I mean, particularly following up on some of the questions that we received in our confirmation hearing. There was a lot of interest from the Senate, and I know there's been discussion here about not having a one-size-fits all approach. And these assessing performance against the target is one way to not have one size fitting all. But another part of that is, will the target itself be adjusted, and for high quality, low cost entities compared to low quality, high cost entities, and I'm wondering where in the timeline will that discussion be entertained?
Yeah, with regard to, so I'm just only talking about the statewide target. There are provisions for equity adjustments and quality adjustments in the statute. We do have active work streams at OCA that are working to create a potential approach for how OCA could implement those. So we do intend to bring those to the board. I can't give a definitive timeline, but it would be sometime within the next year. So a quality adjustment would be if a provider is exceeds the target, but they performed high in quality, then kind of to what extent could OCA provide an allowance for that? Within kind of the guardrails that we don't want to exacerbate kind of affordability issues. And then for equity adjustments, there is some thinking happening on how we could implement targets or make adjustments to the target. It's kind of a question of whether you want to adjust performance, or do you really need to adjust the target itself? So there are some considerations where we're thinking through about entities that have not, may have been under-resourced historically, so allowing them to grow more. So we're thinking that through as well.
Thank you. David, you had a question?
Yes, and my question has to do with the adjustments in the modeling also. I recognize that there might be a couple of categories of examples here, and I think this is a pretty good list. Rick's point about risk adjustment, I think, is very relevant to this list. One conclusion that I would make based on some of our earlier discussions is many of the items, or several of the items on this list, may be strongly correlated with the last item, which is age and gender. And I think we may actually encompass some of the variation that we see by this focus on age and gender. But that said, a question that I have is, are we thinking about different types of adjustments or different granularity of adjustment based on the granularity of the entity that we're looking at? Regions versus, say, a medical group. There may be different sensitivities depending on the size of the entity to consider, basically.
This is regard to the age and gender. Okay.
Or any adjustment.
Okay.
Things may be relevant at different levels of a consideration. A statewide health plan may be very different from a local health plan.
Yeah, we could definitely think about that. Yeah, for like our workforce stability, kind of different topic, but it's for workforce stability measures that OCA is required to look at. Those are more relevant for healthcare entity or for providers, not necessarily health plans as much. Yeah, there may be kind of, it may be more relevant and have a larger scale for certain types of entities.
Terrific. Elizabeth?
Thank you. And I know, Mr. Chair, you're trying to move on, but I did want to agree with Rick's request for a transparent and formal process. I think that's really important. But I do also have other questions that maybe are for future meetings, but sort of to the point of, historically underfunded entities, is there, just as an example, a scenario where independent primary care practices are exempted? Or, we look at the regionality, which did come up in the Senate hearing several times, looking at sort of rural entities versus urban. And so when will we be having those conversations? Oh, and sorry, also, how are we looking at health plans and other intermediaries like PBMs in this? And when will that all be sort of teased out?
So the statute, we're focused on the statewide target today, but in the future, in the next couple of years, the board does have the flexibility to set sector targets. So those could be geographic regions. So, given that healthcare costs vary by geography, so that could be kind of one way to take a more a differential approach in kind of how targets are set. And then regarding PBMs, those are included as a healthcare entity under our cost and market impact review regulations. So if they're engaged in a transaction, and they meet the thresholds and the circumstances, they would need to file. And then regarding kind of on the spending data side, we are going to get a lot of data from payers about prescription drug spending, but we're also going to need to look at cost drivers, and PBMs are part of the supply chain. So we'll have to kind of think through how they fit in with our healthcare spending targets. Do you have a follow-up?
Do you have a sense of timing on that?
For kind of how OCA is going to look at PBMs?
Well, and health plans, intermediaries generally, but okay. PBMs are mostly owned by health plans, but also sort of the regionality and sector.
Yeah, for the sector targets, they could be set on or before 2028. So there's flexibility for when the board could approach that. For the PBM issue, we haven't received our first kind of data submission yet from the payers, so we will kind of we'll have to add that to the list of things. But they are an important focus in terms of prescription drug costs and increasing transparency in the supply chain.
Thank you. There's nothing else now. I think there's going to be a lot more conversation on this topic. I get the sense. I think next we're going to open it up to public comment. Before we do, if it's okay with our presenters, I think we'll move the next agenda item till after lunch. We'll take an abbreviated lunch to allow for public comment now and folks to fill their bellies. We go to public comment, please.
All right, at this time, we will now move to public comment on this item. To ensure equitable access, we will alternate between individuals in the room and those attending virtually. If possible, please keep your comments to 2 minutes so that we can hear from everybody. We will start with virtual attendees at this time. Mary Jo, we see that your hand is raised. You are unmuted on our end. Please go ahead. And Mary Jo, you are unmuted on our end. You might need to unmute on. We will now move
I'm
to.
sorry, it was.
Go ahead. We can hear you.
Yes, it was raised unintentionally. My apologies.
Ah, I see. We will now move to the individual at the podium. Thank you.
Hi, Ben Johnson from the California Hospital Association. California's hospitals share the goals of improving affordability while protecting access to high quality and equitable care. And while we believe the office is showing a clear commitment to improving affordability, its final recommendation for California's first statewide spending target misses the mark in pursuit of OCA's other objectives. And we urge the board to reconsider the proposed 3% target for 2025 through 2029, which represents a 40% drop in healthcare spending relative to long-term historical trends. We are concerned that the proposal entirely ignores the drivers of healthcare spending, including policy changes adopted right here in Sacramento. So, for example, Governor Newsom has made a historical commitment to invest in Medi-Cal to improve access to care. And this set of investments, largely stemming from the managed care organization tax, on their own will increase statewide healthcare spending by well over 1% over the next couple years. In other words, a single policy change would comprise 1/3 of the proposed target. And the result is that healthcare entities would be at serious risk of violating the target for realizing the critically needed investments that the state is making. Relatedly, Medi-Cal is projected by state fiscal experts to grow by between 5% and 6% on a per capita basis over the next several years. And we are setting a statewide target that applies to Medi-Cal and not just on the commercial side. Would note that a lot of work needs to be done on the enforcement process in our view, including but not limited to looking at what factors OCA looks at when assessing entity performance against the target. And just to conclude, setting a spending target is the most impactful decision the OCA board is likely to make this year, not only shaping the growth trajectory of a $500 billion sector of the economy, but also affecting Californians' ability to access life-saving care. And so we asked the board to take the time needed to reach a thoughtful decision on the spending target, including taking seriously the feedback OCA receives from regulated entities through the public comment process. And so we asked the board to use that March board meeting to deliberate over this feedback and return at a later date within the time afforded by statute to make this consequential decision. Thank you.
Thank you. We will now look virtually. William Kramer, we see that your hand is raised. You are unmuted on our end. Please go ahead.
Thank you. I'm Bill Kramer, Senior Advisor for Health Policy at the Purchaser Business Group on Health. Clearly, we have a healthcare affordability crisis. This is unsustainable from an employer perspective. Furthermore, high healthcare costs are squeezing out wage increases, crowding out job growth and business investment, creating barriers to needed care, and causing health inequities. We have a unique opportunity in California to address the affordability crisis. Our recommendations are, first, targets should be set based on affordability for consumers and patients, using the 20-year average median household income. We understand that meeting the targets will be a challenge for some hospitals, health systems, provider groups, and health plans. But the board is not tasked with forecasting the likely trends in healthcare spending based on provider input costs. Its task is to set targets and improve affordability. Second, we are concerned that the 3% growth target would do nothing to improve affordability, since it allows healthcare costs to keep going up at the same rate as median household income. We know this is achievable since there is enormous variation in the costs and cost growth between geographic areas and specific entities in California. Many hospitals and provider groups are able to provide high quality, accessible, and equitable care at relatively low costs. Third, we recommend there should be no prospective adjustments to targets for factors that might increase provider or health plan costs. We know there will be a mechanism to take into account major unexpected cost drivers in assessing entities' performance against the targets in future years. Fourth, we believe there should be no delays or phase-ins of the targets. The legislation has already allowed a multi-year process before targets are set and publicly reported and before entities are held accountable. And finally, we should move quickly to setting targets for geographic areas, industry sectors, and specific entities. A single statewide target allows high-cost providers to continue to increase costs at the same rate for low-cost providers. The focus should be on high-cost outliers and to ensure fairness to all providers. Thank you.
Thank you. Moving back to the individual in the room, step to the podium and please make sure the microphone light is green.
Hi, my name is Glenn Mercado, and I am a hotel worker from Daly City. In the 18 years I've dedicated to the hospitality industry, I have never faced as much financial hardship as I do now, and I know that I'm not alone on this boat. Even though I am a single person who splits the house bills with 3 family members, I can barely afford a healthy social life. When my employer discontinued my health coverage as millions were losing their lives to COVID during lockdown, I thought premiums would be reasonable enough just to secure standard health care for myself. I was wrong. I had to dig into what little savings I had because the premium was so expensive, around $300 a month. Eventually, I learned that there were programs to cover the cost, but until then, my anxiety intensified. Now I'm back at work, and I feel a lot of pressure to work enough to qualify for health insurance because I know how unreasonable and absurd the cost would be if I didn't get it from my employer. And I know that if health insurance were cheaper, less of my compensation would be going to insurance companies and I could have more money in take-home pay. Money is already tight. I could really use that extra money in my paycheck. Healthcare companies are making life so challenging. It's like I'm being cornered into a place where my sole purpose in life is to simply work. Even when I'm not at work, the pressure is on my mind. What happened to the respectability of holding down an honest job? Our hands of everyday working class people build this country's wealth, and we are just about sick and tired of being cheated. I can't fathom a just reason for cost hikes, but we are asking not a penny over 3%. My understanding is that this board was built upon the burgeoning necessity for us to be recognized. My hope is that no one loses sight of the immeasurable difference they are here to make for our future. Thank you.
Thank you. Moving back to the attendee virtually, Kelly, we see your hand is raised. You're unmuted. Please go ahead.
Kelly Brooks on behalf of the California Association of Public Hospitals and Health Systems. Public healthcare systems strongly support improving affordability for patients and consumers. However, we are concerned with OCA's initial spending target proposal of 3% for 25 through 2029 and the potentially detrimental impacts it could have on patients and access to care. We understand and can empathize with OCA's interest in connecting the target to a measure related to consumer affordability. However, we would strongly encourage the board to consider additional factors in the target's development, such as economic and population-based measures and major healthcare cost growth drivers. If the target does not account for the experience of providers and the spending and cost pressures they are facing that are beyond their control, there could be blunt and harmful impacts to healthcare access in our state. We would also urge for further considerations related to Medi-Cal. Public healthcare systems provide 35% of all Medi-Cal and uninsured hospital care statewide. Imposing this target in Medi-Cal implies that baseline spending is adequate to begin with, but Medi-Cal reimbursement is nowhere close to covering the cost to provide care, and this must be taken into account. Furthermore, Medi-Cal financing is complex and little discussion has been had on how the spending target will apply in Medi-Cal. For example, stakeholders are unclear as to what spending will be measured, how certain financing arrangements will be treated, or how spending would be attributed, among other issues. We look forward to having further discussions with the administration on this and for more information being provided to the board. For these reasons, we urge the board to adopt a more realistic and attainable spending target and to limit it to an initial one-year cycle. Setting a one-year target will allow for more deliberation on these important issues and time to develop a workable methodology. We look forward to providing additional feedback on the target proposal via written comments, and thank you for your consideration.
Thank you. Moving to the individual at the podium, please go ahead.
Thank you. Nick Luizos with the California Association of Health Plans. Thank you for the opportunity today, and we will be following up with written comment after this meeting. We'd just like to start off saying that we agree with OCA and the board that affordability and access go hand in hand. And Dr. Pan knows this very well. It's an argument that we make frequently in the legislature. when we face, the annual parade of expensive mandates and other bills that seek to unravel managed care in the state of California. And that's no different this year. And in fact, there has been a piece of legislation introduced that will revisit the essential health benefits that are offered in the state of California. That might be a good thing. That might be a bad thing. I think the point I'm trying to make is that, the debate that goes on in the legislature and the debate that we're having here, and it's not necessarily the responsibility of the board, but sometimes it feels like from an outside observer, there's a bit of a disconnect. Having said that, we do share OCA's long-term vision of working on affordability for the benefit of consumers. Fundamentally, our member plans are supportive of a multi-year spending target. However, we do believe that the decision over the target should be based on very thoughtful analysis and discussion of the underlying methodologies and the like, so that we can get this right the first time, instead of going through the stops and starts that other states have experienced when they've initially implemented this. So we would like to reiterate that we believe it would be a mistake for OCA to make a quick decision on such an important matter. Again, it's been restated already. The board has until June, and we feel like a May vote would be more appropriate for something like this. You should take the time afforded under statute, ensure fair consideration of all stakeholder feedback. There are specific reasons for this. We still have questions about how the total medical expenses are going to be displayed so that it can generate actionable information. And before OCA adopts a spending target, our members and perhaps other stakeholders believe they need a better understanding of how this information will be presented and characterized, because it'll ultimately lead to the entity's performance against the benchmark. So I'll make this quick. We do believe a 10-year period for historical median household income is better. We appreciate the green box of enforcement that was presented today. That answered some questions, but I think we have further questions. We would like the consideration of a glide path approach and other considerations that we think would enhance the cooperation between OCA and the regulated entities in this endeavor. So we want this to work. Thank you. We'll follow up with the letter. Thanks.
Thank you. Moving virtual, Kathy, you are unmuted. Please go ahead.
My name is Pearl. I work at Gourmet Airline Catering at San Francisco Airport for 20 years. I have a daughter. She already in college. For me, it's very important to have affordable health care because of my family. My husband got sick a few years ago. At that time, my insurance was so bad. Every year I have to pay deductible like 4,000 plus the premiums 800 per month, and plus some medicine. My husband needs dialysis every times per week. So every year I receive many medical bill until I pay all the deductible 4,000. But that is not only one time; it's for every year. It's make me a lot of stress and cannot sleep. I already thinking how can I make more money to pay off all my medical bill. I don't have time to stay with my family. I use to work. And for all this, I had my husband was sick. I work by myself to support my family. So please don't increase too much the cost for the medical. Thank you.
Thank you. Going back to the room, the individual at the podium, please go ahead.
Thank you very much. Teresa Stark with Kaiser Permanente. We wanted to come here today to share our comments and feedback on your proposed target. We did submit a letter a few days ago, so you should have that. First and foremost, Kaiser Permanente wants to stress we also agree with the goals and the mission of the office. We are absolutely committed to affordability. It is a topic of conversation in my organization every day at all levels. I can attest to that. And we absolutely share the objective of the state office. We were pleased to be part of the legislative process with many of you here today, and we want to continue working with you. We are committed to the success of the office and the achievement of the goal. It is in that vein that we are here today to offer our feedback as you deliberate this important comment. A lot of this has been discussed already. I won't repeat. We would urge you to consider we understand the desire to connect to the growth in household income as that directly ties to consumer affordability. We would suggest that that 20-year look back is probably not the best way to go, given that it is such an extensive time and there are a lot of outlier events that happened. Perhaps a 10-year look back, the forecast. Just reiterate that we would encourage you to look at that time period. We would also suggest possibly a glide path approach. So instead of a locked-in target, drive to that goal, drive to that strict cap, but maybe start a little bit higher to give healthcare entities a little bit more of a roadmap, a little bit more time to tweak and to work with you to drive toward that goal. That is something we wanted to suggest. We would reiterate the need to better take into account pharmaceutical costs. I know it's a struggle. I know it's been discussed. It is an absolute significant cost driver in the system. You all know that. Even Kaiser Permanente, because of our model, because of our size, because of who we are a direct purchaser of pharmaceuticals. We can drive discounts for our customers, and we do to get them the best value. But our trend on pharmaceutical spend is nowhere near 3%. So that's an issue. We need to understand better the labor cost adjustment and how that is going to work. We are very proud of our market leading wages and benefits. Labor costs, which are people costs, are going up, and it's more than 3%. So we need to understand that better now as you're setting the target rather than some adjustment going forward. So reiterate, please take the full time that the statute allows you. You have several more board members. You have an incredible advisory committee. There are differences of opinion. It's a complex topic, as you've heard today. We feel like more conversation, more exploring would be helpful. Perhaps bringing other experts in, lessons learned from other states, panels of providers and workers, really dig into
3 minutes.
it. We want you to. It is consequential, complex and consequential. So just to reiterate again, our shared commitment to this collective work. We want to be helpful and positive and constructive to help all of us be successful in your goal. Thank you very much.
Thank you. Moving back virtually, Mira, you're unmuted.
Good afternoon. I'm Mira Morton with the California Children's Hospital Association, and I appreciate the opportunity to speak to you today about our concerns about how the proposed 3% statewide cost target could harm the state's sickest children and their families. Specifically, our members have concerns with the 3% target, the lack of any upfront adjustments, and the proposal to lock this target in for 5 years with no ramp up when there is significant reason to believe that the majority of providers will not be able to meet it despite their best efforts. Children's hospitals are tertiary hospitals that treat the highest acuity patients and as a result provide the most costly care. For the same reason, they are also the most impacted by new costly therapies like gene therapy cures for sickle cell disease, transfusion-dependent beta thalassemia, and soon perhaps Duchenne's muscular dystrophy. Without an upfront adjustment to the target to accommodate these new treatments, our members will have no guidance about how accelerated spending growth due to these drugs and future ones will be handled by OCA staff. Children's hospitals are also teaching hospitals that train 50% of the state's pediatricians, and they do this with significantly less public support than other teaching hospitals. The state is facing a severe shortage of pediatric specialists, and we cannot afford to leave children's hospitals wondering whether future investments in their residency programs will be approved of by OCA staff. OCA staff's recommendation is to set an extremely low target, lower than the majority of hospitals, and especially children's hospitals likely can meet, and also to make no upfront adjustments to give providers a sense of the board's priorities and values about what care and other hospital services should be funded, even if doing so requires growth that exceeds 3%. Instead, it would have our children's hospital members ask for forgiveness 2 years after spending on life-saving care, pediatric residencies, and other critical services have already occurred, and hope that OCA affirms their decisions about their necessity rather than taking corrective action and instituting fines. Our children's hospitals are very mindful of the impact the rapid growth in healthcare spending has on families and payers, both public and private. They take their responsibility to constrain costs seriously and will continue to do their part to ensure California's sickest children receive the best care as efficiently as possible. But we would urge you to make adjustments to this proposal to make the target more realistic and provide clear guidance to the providers about what spending you value and do not want to see cut. These changes will not eliminate the incentives you hope to create with the target, but they will ensure that the target does not inadvertently discourage or penalize critical health activities and services. Thank you.
Thank you. Going to the individual at the podium.
Good afternoon, and thank you for the opportunity to provide comments today. I am Amber Tervroot here representing Scripps Health from the Office of the President. And while we too, as you've heard, support the mission and the goal, we are also here to respectfully urge you to reconsider the proposed 5-year 3% growth target. Scripps Health was founded more than 100 years ago. We are one of San Diego's largest safety net providers. Each day at Scripps, we put the vision of our founders into action, dedicating ourselves to quality, safe, cost-efficient, and socially responsible healthcare for the communities that we serve. We serve more than 600,000 patients annually through the dedication of our affiliated physicians, 5 acute care hospital campuses, 2 level 1 trauma facilities, our clinics, imaging centers, and 3 highly respected graduate medical education programs. We cannot keep pace with the escalating costs and lack of reimbursement. Government reimbursement has not kept pace with the rising costs of labor that we face today. Of labor and supplies and drugs that we face today. Scripps Health, like many other providers in California today, operated at a loss in 2023. And this year, we are targeting a 0.5% operating margin. We work hard to control costs, but we incur many costs that simply cannot be contained to a 3% target, like, as you've heard already, pharmaceutical costs, rising labor costs, cybersecurity costs, increasing supply chain, and state-initiated legislative mandates, including healthcare minimum wage and seismic compliance. Yet we must have that margin to invest in the services that our community deserves. We need to have the ability to invest in programs that promote an equitable future and one that invests in partnerships and innovations, like you've heard already today, that will ultimately reduce these costs in the long run to ensure that we can continue to provide excellent care for the communities we serve for the next 100 years. Sincerely appreciate your time today. Thank you for taking our comments and would respectfully urge you to reconsider the 5-year 3% target. Thank you.
Thank you. Moving back virtually, Angela, you're unmuted. Please go ahead. Angela, you're unmuted on our end. You might need to unmute on your end. We can't hear you yet. All right, we will come back to Angela. To the individual at the podium, please go ahead.
Thank you. My name is Rosaura, and I work in Hilton Garden Inn in Monterey, California, as housekeeper. I live in Seaside with my husband and my 3 kids. My little one, her name is Corinne. Since she was little, apparently she was fine, but suddenly she got sick with high fever and stomach pain. It was happening like every 1, 2, or 3 months apart. On October 2020, when the pandemic was, she got sick, very bad. I took her to the hospital and doctor said it was just air in her stomach. When we came back home and she was worse and worse with stomach pain, then with mucus diarrhea and blood in her stool. We took her to the hospital again and she stayed there for 3 days and they couldn't give me a diagnosis for sure. Then they sent an ambulance to San Francisco CFSC hospital and finally they gave us a result that she had IBD. That means inflammatory bowel disease. After 2 more days there, she was discharged, and since then she's taking medication for the rest of her life, or at least until something new comes for her illness. In that time, she only had medical, and also they gave a program, CCA, for a special skill condition like she has. I didn't have to pay anything, but I can imagine I will be done without those programs. In Monterey area, where we live, rent is so expensive. To get worse of that, all necessities that you need are too expensive. To support a house is not only about rent. You need more, and with the salaries that we have a tab on that. We had my coworker didn't get a wage increase last year. I will not survive if I will have to pay this hospital for my daughter. I know the hospital are very expensive, but Cham Community Hospital, Peninsula, where my daughter was, is one of the more expensive in California. I thank you, all you guys, for giving me a moment to hear this problem that our community, we are struggling, is suffering about the cost of the hospitals in Monterey, California. Please do something as soon as possible. One more time, thanks a lot.
Thank you. Moving virtually, Tim, you're unmuted on our end. Please go ahead.
Thank you. Good afternoon, members of the board. My name is Tim Curley, and I'm Director of Public Policy and Advocacy at Valley Children's Healthcare in Madera. On behalf of Valley Children's, I want to provide a few comments regarding staff's recent recommendation for a 3% growth target for healthcare spending. First, I want to start by just thanking OCA and the board for your commitment to healthcare that is accessible, affordable, equitable, high quality, and universal. Valley Children's stands ready to collaborate with you in ways that do not sacrifice any of these key tenets. Valley Children's is Central California's only healthcare network dedicated to children, and we play a vital role in meeting the healthcare needs of some of our region's sickest and most medically vulnerable residents. On any given day, 75% of the patients that we treat are covered by Medi-Cal, and 80% are patients, or 80% of our patients rather, are an ethnicity or race other than white or Caucasian. As a specialty provider, the services that we provide require significant investments, including specially trained providers, sophisticated medical equipment, and cutting-edge drug therapies. And while we do a very good job managing our spending, we cannot fully anticipate the types and volumes of medical conditions that will be called upon to treat, the resources needed, and the associated costs. Regarding the proposed spending target, we want to make sure that the spending target accounts for those factors that impact healthcare spending, such as inflation, trends in labor and technology, policy changes, and the investments hospitals, including specialty hospitals like Valley Children's, make to ensure that we are providing the best care possible. Under a 3% spending target, it's going to be very difficult for us to continue to provide the level of services that we currently do and that our community and patients demand and deserve. Valley Children's respectfully ask that the board reconsider the 3% growth target and work with hospital leaders to design and adopt a data-driven spending target that reflects the resources needed to provide life-saving care. Thank you very much for your consideration.
Thank you. Moving back to the individual at the podium.
Good afternoon, ladies and gentlemen. My name is Fortunato Pasqua. I'm a hotel worker out of Monterey, California. Back in March 2023, I was hospitalized with syncope, and I was there for about 3 hours. It was billed about $17,000, and out of my pocket, I had to pay over $3,000. When I saw the amount, I thought that was outrageous. It was just not affordable for me to pay, and still paying it at this time. I have a wife and 2 kids, small kids to support, and it's very hard to manage the affordability of that bill. Thank you very much.
Thank you. Moving back virtually, Kim, you're unmuted on our end. Please go ahead. Kim, we're unable to hear you at this time. You might need to unmute on your end. All right, moving back to the individual.
Okay, let's try again. Sorry, Kim Stone, Stone Advocacy on behalf of the California Orthopedic Association. Respectfully urge the board to consider, as well as wage data, the actual cost drivers for healthcare costs, and also urge a shorter than 5-year time frame. Thank you very much.
Thank you. Going to the individual at the podium.
Good afternoon. My name is Elika Valdez. I am an organizer with Unite Here, Local 19, for almost 4 years. The crisis we're facing in Monterey County with the hospital high cost is causing so much struggle and pain to our members. Besides the side effects of whatever treatment they are dealing with, they are suffering from the stress and the anguish of how much each visit will cost them. Last year, many of our members didn't get a wage increase. They are struggling to survive in a month-to-month in Monterey County. They fear the uncertainty of not knowing how much will they end up paying and how much they're basing their basic needs. I'm going to share one story of one of our members who could not come here, but he asked me to share this with you guys. His name is Rodolfo Maldonado. He's a Highlandings worker. He's a cook for 40 years. He had insurance, but back in 2008, he had there was a cap on the health insurance. The insurance will not pay more than $500,000, so he exceeded that amount. He ended up paying a lot of money that took years for him to pay. They sent their employer to hold his wages for over $35,000. They ordered to take the money that he had in the bank. He had 20 apartments that he was renting for the community in Stockton, and he had 3 in Seaside. They were renting for local families. They forced him to turn them in. So 20 families end up without a house, and those who stayed, their rent was increased so much. He tried not to be affected physically or emotionally, but it was impossible. He suffered a lot of stress during that time. From his income, 25% was taken out of his check. He ended up paying
2 minutes.
Another $25,000, so he could not lose the house that he was living in. So he's asking you guys to do something about it. So he doesn't want any other family to pass what he passed. Thank you for listening.
Thank you. Looking back virtually, Travis, you're unmuted on our end. Please go ahead.
Hi there, Travis West, Regulatory Policy Specialist with California Nurses Association. We just wanted to quickly echo the comments of the working people who have taken their time to comment and share their very powerful stories today, as well as the other labor organizations that have commented in support of the 3% spending target. We would also like to thank the OCA staff and board for your hard work on this issue, as well as their overall efforts to make healthcare more affordable for consumers in California. Thank you.
Thank you. Going to the individual at the podium, please go ahead.
Hi, I'm Ivana Krajcinovic. I'm Vice President for Healthcare Delivery with Unite Here Health. We're a national Taft-Hartley covering unionized hospitality workers, including here in California. We cover the coverage of the workers that you have just heard from. In 2022, we paid CHOMP $6.4 million, an astounding 559% of Medicare. Had we paid double the rate of Medicare, we would have saved over $4 million. If you divide that by the members we have in Monterey, people like Fortunato and Rosaura, they would have each received another $3,800. And instead, they got a wage freeze last year. We're lucky that we process our own claims and own our data. Not all payers, even large ones, have that ability, so we can see it. But CHOMP's even hiding this from commercial payers. You would think that the Price Transparency Act would have done something about that, but to this day, CHOMP is not providing inpatient pricing for populations that are not government funded. If you go to look for commercial rates, their inpatient pricing file says payer-specific case rate. This does not apply with the mandate, and this lack of regard for a federal mandate that's over 3 years old shows how far they're willing to go to hide the exorbitant amounts they're charging commercial payers. Besides Monterey, our biggest pain point this past year has been our Kaiser renewals. Like a lot of labor trust funds, we were hit with renewals in the 15% range. This, in our case, was despite the fact that our utilization was low, and Kaiser's previous rate-setting practice would have suggested a concomitant low increase of about 4%. A number of years ago, we arranged to have a third-party data warehouse actually translate Kaiser's data into something more resembling claims data so that we could validate the renewals. And we spend tens of thousands of dollars every year doing this because it's such a big spend for us. But this year, Kaiser just let us know up front, like, don't even go through that exercise. We're just going to charge everybody an extra, 10% for the usual things that we're hearing about supply chain issues and labor costs, right?
2 minutes.
It's hard not to imagine that part of the reason we were asked for these renewals was because of the work of this board. They know, get the money now because you're not going to be able to get it down the road because OCA is going to be watching and, putting some price caps on. I mean, we think what's going on with Kaiser is the same thing that's going on in Monterey. These are entities with tremendous market power, and consumers don't have a lot of choice of where they go. Kaiser has talked about these various cost drivers. It doesn't mention that they paid the Golden State Warriors a reported $295 million to brand the neighborhood outside the team's new arena, Thrive City. And now we're being told, don't be hasty, let's have more panels. I mean, the time is now. Consumers have been footing the bill for all the waste and inefficiency in this industry, and it's time for that to stop. So we strongly support your recommendation of the spending caps, the 3%.
3 minutes.
And urge, it's a big state, I'm sorry. Urge you to adopt them without diluting them with ramp-up times or other accommodations. Thank you.
Thank you. Going to the individual, Grace, you're unmuted.
So much. Grace Coughlin on behalf of Providence, and we want to thank you for the opportunity to speak here. Providence is an integrated delivery network that includes 17 hospitals in Northern and Southern California. Over 35,000 caregivers and approximately 11,000 physicians ensure patients receive the highest level of care in the communities we serve. Supporting its acute care settings in California, Providence features hundreds of affiliated medical group clinics and outpatient centers, in addition to Trinity Care Hospice and Trinity Kids Care Pediatric Hospice. Providence High School, home healthcare services, 10 wellness centers, and a multitude of telehealth services. We recognize and appreciate the board's commitment to improving affordability. However, we're here to respectfully urge the board to reconsider the proposed 3% spending target, as well as the 5-year timeline. We specifically hope that this board considers striking a balance between promoting affordability and maintaining access to high-quality, equitable care. We also hope the board will take into account the majority of external factors that influence healthcare costs, such as inflation and California's aging population, and will align with other states that have spending targets, almost all of which are higher than 3%. I thank you again, and Providence is happy to be a resource throughout the consideration of this proposal.
Thank you. Going to the individual at the podium.
Members of the board, Steve McDougall with CFT, a union of educators and classified professionals. What I'm hearing from special interests, I'm from the not so special interests, the consumers. And the members that I represent are consumers. But what I'm hearing from the special interests, be they providers, networks, medical professionals, I'm hearing tone deafness. That's what I'm hearing. I bet you if your target was 6%, we'd be hearing the same special interest pushing back, saying that the board and staff is harebrained. You haven't thought it out. You haven't been thoughtful. Boy, if I was on that board, I'd have something to say, but maybe that's why I'm not on the board. They need to get it together and figure it out. They're lucky it's 3%. Because this is all public record, and I can see a time where we just line these recordings up over in the Capitol when we're talking about single payer. So figure this way out, because that's what's coming next if you can't. Sorry, I wasn't really talking to you, the board. I was talking to some other folks.
Thank you. Moving virtually, going to Angela. You're unmuted. Angela, you're unmuted on our end. Can you unmute on your end? We can't hear you yet. All right, we'll come back to Angela. Going to the individual at the podium, please go ahead.
Good afternoon. Thank you. Tim Madden, representing the California chapter of the American College of Emergency Physicians. And emergency physicians have some concerns over the target rate as well as the time frame for the implementation of the target rate. As I know you all understand, emergency departments are currently overcrowded. Wait times continue to increase. Boarding times continue to increase. A couple of factors contributing to this include the lack of access to care and also patients avoiding care due to the high cost associated with that care. When we look at the target and the time frame, our concern is what happens to those low-cost entities that we've been talking about, or those underfunded healthcare entities who are now looking at how do they meet the new cost requirements. Given some of their fiscal fixed costs, perhaps they look at just reducing staffing. So then that further contributes to the lack of access to care, which then in turn drives more people into the emergency department. We're seeing people with higher acuity at this point, which is also then building into the higher wait times. So we would urge the board to take this in consideration when you're looking at the time frame and the rate, and think about what the larger impact might be in terms of, is this actually contributing to more costs into the system because people are not having access to more upfront care? Thank you for your time.
Thank you. Going virtually, Kay, you're unmuted on our end. Go ahead, please. Okay, we're unable to hear you. If you could unmute on your end. All right, we will come back to our virtual attendees. To the individual at the podium, please go ahead.
Good afternoon, Bill Barcelona, America's Physician Groups. I represent a segment of the provider community that has for the last 30 years taken financial risk along with payers in order to bend the cost trend and improve quality of healthcare delivery. Our concerns about the cap are more granular. At the present time, we don't understand how a 3% cap translates to our continued sustainable capitation rates and whether there would be a conflict between the enforcement of Knox-Keene Act law over at the Department of Managed Healthcare versus the imposition of your 3% cap on our groups. For example, the Department of Healthcare Services, another department, is increasing spending for Medi-Cal providers in California, and we estimate that the difference between the 2023 spend and the new TRI 2024 schedule will increase payments from our groups to providers by 20 to 25% on average for the 81 groups that participate in Medi-Cal. We don't understand how that increase in spending will be considered under a 3% cap. We don't understand how, for example, increases in Medicare Advantage rates, Medi-Cal rates, and commercial rates are offset or considered as the caps are applied across the board to these risk-bearing entities in California. And we urge you to take the time to study this, to study the potential conflicts in law that exist between the regulatory enforcement schemes of DMHC, of HCI, and DHCS, and perhaps add that into your deliberations prior to your adoption of the 3% cap or whatever
2 minutes
model you intend to adopt. Thank you.
Looking back virtually, Angela, you have your hand raised. You're unmuted. Please go ahead.
Can you hear me now?
Yes, we can.
Oh, wonderful. My name is Angela Gilliard. I'm the Director of Health Policy for the University of California Health System. UC Health shares the same goals as OCA to provide accessible, quality, affordable, and equitable healthcare to all Californians. The 5 UC academic health centers are part of the state's 21 public health care systems, which form the core of the state's healthcare safety net. We intend to submit a comment letter to the board requesting that the board exercise its statutory authority to select a single-year target instead of the currently proposed 5-year target. Many outstanding issues remain that would provide important additional context for a target, such as Medi-Cal financing, what costs will be measured, and how costs will be attributed to providers. Opting for a single-year target will enable OCA to collaborate with stakeholders to work through these issues and further develop a methodology that ensures we achieve affordable, quality, equitable, and access to care. So thank you very much.
Thank you. To the individual at the podium.
Hello, my name is Harvey McKeown. I'm a field rep for the Carpenters Union, and I'm also a proud member of Carpenters Local 713 in the city of Hayward. We're going to submit a comment letter, but firstly, I'd like to today thank the board and the committee. It's been a fascinating discussion over the past few months, and we've definitely learned a lot as an organization by participating in this body to the extent we can. The NorCal Carpenters Union supports a statewide spending target of 3%. And one of our reasons generally for supporting a price cap is that in many industries, it's relatively standard for price caps to play a function to stop companies from abusing a dominant market position or an unfairly weighted negotiating position. And in this latter regard, our union observes that Kaiser Foundation Health Plan, which provides healthcare for most of our members, appears to hold a dominant or near dominant position in the markets for numerous California healthcare related services, including 60% of all Californians enrolled in large group plans, according to DMHC data. And coincidentally, it's in the large group market where premiums went up the most in the past cycle. And in implementing this price cap, I want to emphasize that even though they're not the workers that we represent, we don't believe that this should be implemented on the backs of frontline healthcare workers. Instead, without even looking under the hood, so to speak, you can see visible examples of spending that I would personally call corporate excess. For example, Kaiser wants to spend $5 billion on a entity in Pennsylvania using assets held under charitable trust in California. Kaiser reportedly spent hundreds of millions, as you've heard, on the naming rights to a sports stadium. Kaiser Foundation executives.
2 minutes.
I've finished soon. Kaiser Foundation executives make millions, even though it's supposedly a non-profit organization. So how does this excessive corporate spending really help California patients? I hope that in implementing the price cap, this will energize future areas for policy discussion. And ultimately, we'll be outlining our views more in a letter, but we urge the board to adopt this spending target without any delay. All working people are in urgent need of relief from rising healthcare costs now, and this won't do anything to address the quadrupling of premiums that our members have already suffered over the past 20 years. Thank you.
Thank you. Going virtually, Kay, you're unmuted. Okay, we're unable to hear you on this end. Go back to the individual at the podium. Thank you.
Hello, my name is Robert Blunt. I'm a member of Drywall Leathers, Local 9109. Adjust this a little bit, I'm too tall. The Carpenters Union represents 11 crafts and is the single largest construction union in the state. We support the spending cap of 3%, and we thank you for your support of that spending cap as well. Most NorCal carpenters are enrolled with Kaiser Foundation Health Plan. Kaiser has quadrupled premiums for our members in the last 20 plus years. And the reason why they do this is because they can. There are no rules. We need rules. A price cap can stop organizations like Kaiser from abusing its negotiating position. We urge the board to adopt this spending target without any delay. All working people are in urgent need of relief from rising healthcare costs right now. Thank you so much. Bye.
Thank you. Looking back virtually, Kay, we see that you still have your hand raised. We understand this might not be intentional. We'll give you another opportunity to make a comment. Go ahead. All right. We encourage you to submit your comments online. If you're unable to make them during public comment, make them over email. We'll go back to the individual at the podium. Thank you.
I'm not tall enough, so. Good afternoon. My name is Omar Hernandez. I'm a member of the NorCal Carpenters Union as well, Local 9109 here in Sacramento. I too am here to support a statewide spending target of 3%. We urge you to do this. In 1952, our members went to strike in Northern California to achieve health and welfare benefits for the first time. Now, our union was ready to fight healthcare then and remains ready to fight to make it affordable today. Our members already pay hundreds of millions of dollars out of their total pay to health providers, most of all to Kaiser. Raising healthcare costs threatens the wage increases our union has bargained for, benefits our hardworking members have earned. I appreciate the efforts of the OCA board and its staff to bring some relief to working people. We urge the board to adopt this spending target without any delay. One thing I wanted to mention, right, is here we are sitting talking about putting a cap on increases in wages. We do it already, right? Landlords have a limit of, 10%, I believe, in the state before they're capped. They're not allowed to make any increases. Housing is just as important as healthcare. We need it. We need a cap in order to be able to make it affordable for everybody. Again, wages go up a little bit, and they use that as a podium to talk and say we need to increase our wages. People need to also live their lives and afford their lives. You know, I saw somebody that showed up here with a shirt stating one job should be enough, and that does not fall short from the truth. So I urge you to please vote on this measure. Thank you.
Thank you. Looking virtually, guest Yamamoto, we see that you have your hand raised. Please go ahead. We're unable to hear you at this time. Please unmute. All right, going back to the individual at the podium. Thank you.
Hello, Board. Mohit Ghosh with Anthem Blue Cross. Thank you for convening this month again on this important subject. We went through a lot of data this morning around looking at where states have been, how they've done things. One point that I think the Bailiff team probably knows is that the Connecticut Office of Health Strategy just on Monday recommended that their 2024 cost benchmark be increased from 2.9% to 4%. And this is a recognition of the underlying 2 to 3 year catch up of a 9.2% inflation factor in the years 2021 and 2022. So as a result, when we're looking at blocking things in for up to 5 years at a time, it simply doesn't take into the realities of what's happening in the marketplace overall and what's driving those costs. So we would again urge, as we have before, that the target itself be reconsidered for the variety of reasons you've seen here, that there may be a glide path that could be incorporated that's realistically based on a year-over-year review, as opposed to locking it in for 5 years at a time, and that we look back 10 years and look as a predictor, better predictor of the forward 5 years of spending, as opposed to looking back 20 years and smoothing out the household income brackets to where we need them to be. So respectfully, given the changes that are even occurring in the systems that the Bailiff team runs in other states, I request that both the target and the timeline be revisited. Thank you.
All right, looking to the individual with their hand raised online. We see that your hand is raised. We haven't been able to hear you at this point. You are unmuted on our end. You will have to unmute the microphone on your end. There should be a microphone symbol at the top of the screen. It has a cross out through it. If you can click that button, you will unmute and we will be able to hear you. Please go ahead, guest Yamamoto. We are unable to hear you at this time. Going back to the individual at the podium.
Hi, Carrie Sanders with the California Pan-Ethnic Health Network, a multicultural statewide health advocacy organization dedicated to eliminating health disparities in strong support of the 3% spending target on median household income, and think 3% is the least we can do. It's not going to make healthcare more affordable. It simply keeps it from becoming even more unaffordable. I know there will be concerns raised about reduced access, but access is inequitable today, and the primary factor driving access and inequitable access is cost. As the NORC CHCF survey showed us, Black and Latina residents are more likely to report different types of medical debt. The high cost of care has contributed to personal bankruptcy, with communities of color more likely to experience debt. Medical debt also threatens the outcomes for communities of color. A survey, for example, found that half of Californians reported skipping or delaying care in the past 12 months. People who are Black or Latina were more likely to delay care and reported worse health outcomes. This is the case for Brian Ive, a factory worker from Orange County who earns about $26 an hour. He suffers from chronic pain from a lifetime of manual labor jobs, but often treats his pain at home with remedies or traditional practices. Going to the doctor is simply too expensive for him. Our partners at the Cambodian family in Orange County know a lot of families whose kids that have kids who break or sprain their fingers and feet, and they don't know for months because they can't go to the doctor. We support the recommendation not to make population adjustments at this time, and hope we'll continue to look at downward adjustments in the future to push the healthcare system to innovate and provide better, lower cost care.
I think the most important thing is actually improving the system. Today, people die from painful and preventable conditions because the incentives in the system are wrong. I serve on the OCA Investment and Payment Work Group, where we are looking at Dr. Pan's question about how we can better incentivize primary care. And
2 minutes.
And I also appreciate points about when we do provide preventative care, sometimes it's not, folks don't take advantage of that care. But we know when we talk about, care, that for many folks, discrimination, feelings of discrimination are what make it difficult for people to actually go and see the doctor. Several years ago, CPEN and our partners in Black Women for Wellness conducted listening sessions with Black women who reported staggering rates of discrimination when they went to the doctor's office. When they raised concerns, they felt their concerns were dismissed. Achieving more equitable care means we must move away from a system where the primary motivation is profit, not only to lower costs, but also to provide better care for everyone, not only for the lucky few. We urge the board to adopt and support the 3% spending target now, and we look forward to continuing future conversations on how we can change the current incentives that reward costly care, instead funding preventative trauma-informed care. Thank you.
Thank you. Looking virtually, noting that we have 104 virtual attendees at this time, seeing no other hands raised beyond guest Yamamoto. We've been unable to hear you at this point. You are unmuted on our end if you'd like to try. One more time, we will go back to the
Hey, can you hear me now? Can you
Yes,
hear me now?
thank you.
Oh my
Yes, we
gosh,
can hear you. Please go ahead.
All right. Well, I appreciate appreciate the opportunity to speak. Maybe more grateful than normal, given the technical difficulties I've had, and appreciate the work that the OCA board has done in ensuring affordable healthcare. My name is Kei Yamamoto. I'm a resident of the Bay Area. I'm 29 years old, so I'm one of the millennials that the board has spoke about, and I urge the board to support the spending target. Recently I've had a broken wrist, and I could not afford the ensuing care that it costs, and would not have been had it not been for the help of my parents, and all the measures that could be taken to make sure that healthcare is affordable and accessible to people, especially young people. Very much appreciated, and thank you for the opportunity to speak.
Thank you. Going to the podium.
Janice Rocco on behalf of the California Medical Association and our nearly 50,000 physician and medical student members. We appreciate the review today, the summary of the comments about concerns that were raised at the advisory committee meeting, and would suggest that folks not only listen to that meeting, but the one that will be in March, because they get very detailed, and it's helpful to you in making your decisions to listen to all of that. I appreciated the recent Senate confirmation hearings. It was great to hear the comments from all of you who participated in that, and to have the legislature push some on the fact that one size doesn't fit all, and that we are going to need flexibility. And I appreciate the discussion that we had here today about that. Better care, investment in primary care, and the integration of behavioral health with primary care, and timely access to care when people need it are things that will cost less than waiting for people to end up in the emergency room or needing hospital care generally. But for the provider who the patient is seeing for routine care, providing that care isn't less costly. Instead, it's more that the patients can be kept healthy, and have less need for specialty care and ER care and hospital care that is more costly to the patient and the healthcare system overall. So if we spend money in the right places, and we enforce network adequacy laws, over time, we should be able to lower growth for the total healthcare expenditures for the state as a whole. But that doesn't necessarily translate to the physician who's seeing and treating the patient, helping prevent the need for some of the more costly care that would otherwise be needed down the road. And so they're not going to be spending less on a per capita basis as they see their patients. So it'd be one thing to set a spending growth target that relates to THCE for the state as a whole, but that wouldn't make it the appropriate target to set for each individual healthcare entity.
2 minutes.
Individual healthcare entities like physician practices are still going to be impacted by inflation, increased cost to practice medicine, and the increased workforce costs and the investment in the TRIs. So we'd ask you to consider all of those things. Thank you.
Thank you. Looking virtually, seeing estimated 103 attendees at this time, no hands raised. Going back to the individual at the podium.
Beth Capel for Health Access. We appreciate that a number of organizations have acknowledged the importance of affordability and then proposed to make it worse. Again, the lack of affordability is what translates into a lack of access. The proposal for a glide path or a ramp up appalls us. Not only is there a 5-year transition built into the law, but most of the organizations who have spoken in favor of a glide path or a ramp up were well aware years in advance that the governor had proposed the Office of Healthcare Affordability and had the opportunity to participate in public hearings in front of the budget subcommittees, which considered this, as Dr. Pan will recall, and I do as well. You heard from one organization that it was a 40% cut in spending. It's a 40% cut in the growth in spending from the 5 to 6% growth they're currently enjoying to the 3% that's proposed. That's not a cut in spending. That's a cut in the rate of growth. Similarly, you've heard from organizations today that have proposed premium increases of 15 to 25% in this year, and we believe in future years. We believe storing up premium increases in advance of the target. At the same time this meeting is occurring, the Integrated Healthcare Association is presenting at another state agency, the Department of Managed Healthcare's Financial Solvency Board, with a finding that those entities that actually rely on alternative payment models have tracked at 3% growth, and those that have not tracked between 9 and 12% growth. Sorry, I just saw it this morning, so I'm a little not as sharp on the numbers. A few other points to make. Yeah. The request for delay reminds us of the unending request for delays of hospital seismic, a requirement that has been in place in this state for 50 years, 1972, longer than some of the people in this room have been alive. Additionally, you have heard the assertion that what OCA is proposing is outside the range of what other states have done. As we review the data that was presented at the last meeting, other states are in the range of 2.8% to 3.3%, which puts the OCA recommendation squarely in the middle of that. Finally, based on the conversations we had at the prior meeting, we looked at healthcare worker employment in the state of Massachusetts. And over the decade that the targets have been in effect, employment has increased. So we thank you for the opportunity, and we look forward to, we will submit written comments and more on the factors. Thank you.
Thank you. Looking back virtually, seeing we have 102 attendees at this time and no hands raised. Looking back to the room, if you'd like to make, okay, please step to the podium.
Good afternoon, everybody. Cesar Lara. Last time I spoke to you, I was the second director of the Monterey Bay Central Labor Council. Now I'm the outgoing and work at the California Labor Federation for Workforce and Economic Development. And staff's recommendation, we support staff's recommendation coming from a county like Monterey County, where issues of economic development are being affected by the cost of healthcare. When unions negotiate their rates, it is swallowed up by the healthcare premiums. We are a poster child for a community that needs something done beyond just the normal. Rural California, especially Northern and Central Valley, have an emergency level crisis, and having this board in place is important. The staff's recommendation of 3% is, we like it. It could be lower. we're okay to that. But just wanted to highlight the importance for working families that we take into consideration how this is holding back our economy. For many workers, and for example, in Monterey County, 2/3 of all workers are in hospitality and ag, farm workers, housekeepers. This is an issue of economic development. This is holding back our economy, even though healthcare is a sector. Talking to affected unions, it's not going in their pockets, it's going into profit margins. Many systems that are supposed to be set up for public good are maximizing profits just like the private hospital systems. And so just want to support staff's recommendation and also put on the table you could be more aggressive. So thank you very much.
Seeing 102 attendees at this time, no hands raised. Looking to individuals in the room, if you'd like to make a comment, please step to the podium. Seeing no hands and no one at the podium, that concludes public comment on this agenda item. We will now break for lunch. Adjusting our break and shortening it, we will reconvene at 1:25.
Sounds good. Thank you, everybody. All right, I think we're going to reconvene and take roll again.
All right. David Carlisle.
Present.
Rick Kronick.
Present.
Ian Lewis. Elizabeth Mitchell.
Present.
I'm sorry, Elizabeth Mitchell, did we hear you in the mic?
Yep, I'm here.
Thank you. Richard Pan.
Present.
And just noting, Mark Galley, Sandra Hernandez, and Don Molds are absent, as I understand. Thank you.
So again, thank you very much for the robust discussion this morning. It went a little long, but it was really contentful, and I, for one, do appreciate it. I think we're going to move now to Deputy Director Pagani. If you'd introduce the next piece.
Thank you, Chair. I'll be turning it over to Assistant Deputy Director Margaretta Brandt.
Good afternoon, everyone. Good afternoon, members of the board. We are excited to share today another example of a cost-reducing strategy. And so I'll start with a few overview slides. So as a reminder, the goal of this cost-reducing strategies project is to highlight examples of successful cost-reducing strategies that also maintain or improve quality. And we are working with healthcare entities, health plans, hospitals, physician organizations to highlight examples of cost-reducing strategies that have demonstrated results within their organizations. And we believe these strategies can be a resource to support healthcare entities as they are working towards meeting the spending growth targets. So as a reminder of our process, we interviewed healthcare entities across California and are continuing to do so to identify these strategies. And from these interviews, we're working with organizations to bring presentations to the board and the advisory committees, and also to develop summaries that we can share on our public webpage. So, and also as a reminder here that we did not independently verify any of the data or results shared by these healthcare entities and are not endorsing these strategies. These are really examples that we want to highlight as a resource. So before I introduce Memorial Care to share their cost-reducing strategy, I wanted to remind everyone that we are seeking additional examples of cost-reducing strategies. So if a healthcare organization is interested in sharing, these are the types of information we are looking for, and you can reach out to OCA using our general inbox listed on the slide. And we'll follow up to learn more about your strategy. So now I'd like to turn it over to Barry Arbuckle, PhD, President and CEO of Memorial Care, and he will share Memorial Care's cost-reducing strategy focused on using community-based ambulatory care centers.
Thank you, Margaretta, and I want to express my appreciation to the board for having this component of your board meetings, sharing some of the cost reduction strategies of providers and payers and others in the healthcare ecosystem. Memorial Care, I'll just zip over. We're moving in lightning speed. Memorial Care is oftentimes thought of as a hospital system, but our compilation of delivery sites makes us a little bit different than many hospital systems. That is to say, we have 4 hospitals, but we have over 100 community-based centers in our delivery area, as well as probably 75 locations for our physician practices that we're strongly affiliated with. And this system has been designed to thrive in value-based care, to actually succeed in reducing costs for the end consumer. So you see we have the imaging centers. I might just mention the imaging centers, the physical therapy clinics, the dialysis sites, and the ambulatory surgery centers are all joint venture relationships. We don't own them wholly. Our strategy was go out to someone who does it for a living, who does it exceptionally well, who shares our values, partner with them, integrate with them, and let them run it, because they know how to do it, frankly, better than we probably do. You'll also see on the bottom, we have one now, co-located primary specialty practice with a dental practice. That might seem like a real one-off, and it is. It is one of a number we intend to develop in the coming months and years, and it's largely predicated upon what's called the mouth-body connection. The scientific literature is increasingly demonstrating the connection between oral health and overall health in areas like cardiovascular disease, preterm birth, diabetes, and Alzheimer's. And we thought how much better to put a primary care clinic in the same suite as a dental practice, share the same EMR, and have the opportunity to get ahead of some of these diseases, because the dentist can sometimes see them before a primary care doctor might. So these are just some of the statistics for Memorial Care. I must admit, since I was at the advisory committee meeting last month and saw Sharp show their statistics, that I had to do the same thing. But it does, I think, reinforce that we are an unusually configured health system, as health systems tend to go, in that we have such a significant amount of our activity outside of the hospital setting and across the continuum of care. Unique, but not something that cannot be replicated by others. This is what it looks like on our map. It just simply shows a very deliberate geographic dispersion of these access points. Our goal is to have access points close to people, where people work and where they live. And we cover, as you can see from this, this map, South LA County and Orange County. So Memorial Care over the last decade has very much committed itself to value-based care. We have and continue to participate in what I believe is every type of ACO and alternative payment model that exists. We have ACOs on the back of a PPO. We have ACOs on the back of an HMO. We have attributed membership ACOs, which, if you're unfamiliar with the term, those are ACOs that the members are assigned to your ACO because they've gone to your providers more than someone else's providers. However, they don't know they're in your ACO. You don't know they're in your ACO until they seek care at your one of your facilities. And so it's very difficult to provide education and prevention to bend the cost curve, which is to say, in full candor, we are moving away from the attributed ACOs because we simply don't think they can bend the cost curve. The alternative to that are called delegated or network ACOs, where the individual, the folks in an employer-based plan or a Medicare plan or otherwise, choose to be in your ACO. In that case, you can reach out, you can do preventive work, you can do education work, and there's a much closer connection between the patient and the provider. We also have direct-to-employer models from as large as the Boeing Corporation. We were the first direct-to-employer in the state of California when we received that contract a number of years ago. But we've also set up the same kind of direct-to-employer relationships for medium and smaller employers, like the likes of Activision Blizzard or the very local F&M Bank down in Southern California. We've also participated in the CMMI ACOs, as well as some of their other cost-reducing strategies along the way. These are, and I apologize for the font is not terribly easy to read, the lightness of the color, but these are what we believe to be the key ingredients of a value-based system or supporting an ACO infrastructure. I share this for a couple of reasons. It is different than operating a traditional hospital or health system or provider group. You need different resources, a different infrastructure, which requires very deliberate investment. And so that's something that I think we'll have to ponder as we want to move the industry more toward alternative payment models, which I very much support. We need to remember there is a bit of an investment to it, and I'll touch upon some more of the aspects as well. The fourth bullet, the ambulatory access points, is what I'm touching upon today. And then I should also mention on the last bullet there, the extensive portfolio of virtual care. Certainly for all of us, the pandemic launched us into that in much faster than we ever imagined being in virtual care. It is something now we will never move away from. And we have at Memorial Care virtual visits, virtual urgent care that's offered 24/7, e-visits, e-consults, remote patient monitoring. And if you might be unfamiliar with some of those, I mean, by example, an e-consult, most people don't know what that is. In the typical doctor-patient, primary care patient relationship, the patient presents to the primary care doctor thinks they might need a referral to a specialist. And in the old days, or in the typical model, they would get a referral for that specialist. They'd go home. They might make the appointment. If they make the appointment, it might be in 2 weeks. They may or may not go to that appointment. They have to take off work again if they go to that doctor, that specialist. That specialist might run some more tests just to be safe. With e-consults, the primary care doctor sends all relevant information electronically to the specialist, sometimes while the patient is still there or immediately after they leave. Our specialists will respond in less than 24 hours, usually 4 or 5, and they will tell the primary care doctor, this patient does not need to see me. Do these 3 things. What % of the time does that cause a patient to have to avoid entirely a specialist visit? We've collected data now for 2.5 years. Across 16 specialties, it averages 72% of the time they don't have to go to a specialist. So it's a model that works. There's only one commercial health plan that pays us for e-consults. I won't name who they are. The government is paying for them now, but it's a fairly challenging process, so I'm not even sure we bill for it. So it's something, again, that the systems need to kind of catch up with these technology. So moving into the topic I was asked to speak about, and that is our ambulatory access points and our strategy with having community-based ambulatory centers. So this slide simply introduces you to the concept, one that you might know very well. Outpatient procedures, and that could be imaging procedures, surgery, any number of kinds of testing, various therapies, et cetera, can either be done at a hospital outpatient department, that is an outpatient activity that's under the license of a hospital, or a community-based ambulatory center. So, okay, that doesn't have to be under the license of the hospital. The cost to the payer, employer, consumer is, as you saw, I'm sure, in the charts that are coming, markedly different. Now, currently in California and across the nation, the commercial health plans, many of them are using clinical criteria to determine in pre-authorization which location is best for the patient. Is it the HOPD or is it the community-based ambulatory center? I will mention, as you likely know, that CMS chose to use several years ago what they call site neutral payment, which is basically lower the price of whatever, lower to the lowest price that exists, which is the community-based ambulatory sites, and use that as the basis for payment. I would have heard that, as I say on the screen, as a blunt instrument. It was a simple approach, and it's frankly not one that's informed by clinical science. It's also not one that's rational by understanding the cost inputs of those 2 locations. And I'll touch upon that as I go. Why did CMS do that? I would argue is because they and Congress weren't given any alternative. The industry just said, we don't want site neutral, and fought that, rather than saying, we agree that there's some inequity here. Here's an alternative that makes clinical and financial sense. And that's what, fortunately, many of the commercial health plans have done. This first example is in colonoscopy, something that sadly we're probably all familiar with. To orient you to the chart, they all follow the same kind of taxonomy. On the blue side, these are commercial rates. These are real numbers. These are not hospital charges. These are real negotiated rates on average in Southern California with hospitals that you know. The blue bar represents the commercial rate for colonoscopy in an HOPD, and the green bar reflects the community-based GI center. The difference in price is not significant, but we have to say that patient conditions vary, or they should. When I say they should, there are still a number of procedures being done in HOPDs that don't need to be there. The patient doesn't need to be in that setting. Their clinical criteria do not suggest they need to be there and therefore incur the higher cost. So we can do a better job, which is kind of the main theme of my presentation, of establishing those clinical criteria and enforcing them to move patients to the right site of care. Why would a patient go, as you see on the left-hand side, to an HOPD? What are some of the clinical criteria that are used today by California's commercial health plans? The patient being moderately or morbidly obese. You have the GI centers typically take those. They're too dangerous. You need them around the resources that an acute care hospital has, just in case. Also, a patient with multiple comorbidities or significant drug allergies. Next example is a knee replacement procedure, something that was unfathomable maybe a decade ago being done in an ambulatory surgery center. We do them now quite regularly. We also do hip replacement procedures in ambulatory surgery centers. You arrive at 6, your surgery is done by 8 or 9, you stand up at 1, you walk at 4, you go home at 6 p.m. When I was, well, I won't tell you. When I started in this profession, it was a mandatory 4-day length of stay in the hospital. Very prescribed 4-day length of stay. So healthcare is moving and rapidly, and it's allowing the patients to receive sight or receive care at the right side of care. You can see here again a rather significant difference between the HOPD and the community-based ambulatory center. But again, there are reasons why certain patients shouldn't be in an ASC for this kind of procedure. It could be advanced age, it could be multiple comorbidities, it could be difficulty with anesthesia. An ASC will not take a patient that has difficulty with anesthesia. It's simply too dangerous for them. And then finally, the example of a chest CT, a fairly significant difference here. And on the left-hand side of that, you can see some of the reasons. Again, these are reasons that are the California's commercial health plans, those that have clinical criteria, have called out for being reasons why they would authorize a patient to have their chest CT in an HOPD, an imaging center on the hospital campus, versus a imaging center out in the community. So why are HOPDs paid more, as you saw from my slides? And this is a sampling of, just a tiny sampling of those that exist. The tests and procedures are the same, but the entities are structurally very different. From the availability, hospitals, HOPDs are part of a hospital. They are a 24/7 operation if need be. There are material differences in regulatory burden. That's simply a reality. You see on my second bullet there, and it's something that most people don't think about. A hospital imaging center might need to buy a CT machine, just like a community-based imaging center would. The CT machine probably costs roughly the same amount. Installing it, maintaining it, a wild difference. The HOPD, because it's in a licensed hospital, has significant more regulations they must adhere to, and those are expensive. Sometimes they double the price of the technology. So that is one reason for the difference, and I'm not saying it's a bad thing, it's just simply a reality. The acuity of the patients, as I pointed out in the prior slides, is or should be different between the two locations, possibly the age of the patient, et cetera. As I mentioned, medical technology, the advances in science is allowing a lot of business to move out of the acute care hospital into outpatient settings, out of hospital-based outpatient settings to community-based outpatient settings. That will continue. There's also an unintended consequence of that is straining hospitals today, and that is many physicians who used to split their time between community-based ambulatory sites and caring for patients in the hospital have moved away from the hospital. It used to be those doctors were the very ones that would do hospital ER call and sign up for that call by specialty, because we're mandated by Title 22 to have physicians available on call 24 hours a day in multiple specialties. It used to be that it was part of the Hippocratic Oath to provide that care. That is gone, by and large. We're paying at our hospitals for ER call on average $1,000 per specialty per day, irrespective of if they're ever called, and setting aside any revenue that they collect because that's theirs. Anesthesia is $7,000 a day, $2.5 million for that one specialty, because anesthesiologists would prefer to work in an ASC. They operate from 7 a.m. to 4 p.m., sometimes not on weekends. It's not an acute care hospital setting. So we're finding a challenge getting those folks. Radiologists are the same. Neurologists for us is $2,000 a day. So again, some of the fundamental differences that justify that price, again, why I said that the CMS blunt instrument of site neutral simply is illogical. I can't undo that. I tried when it was being discussed in Congress, but I think the path that we need to continue heading down is stronger enforcement of establishing clinical criteria to differentiate where these patients should go, therefore justifying the delta in price. Some of the barriers and challenges, I mean, you might ask, is memorial care unique in this? I'm not going to say we're entirely unique, but many health systems have not invested in this robust network of community-based ambulatory sites. Again, we are very mismatched in terms of the number of acute care sites and the number of community-based ambulatory sites that we have within our health system. Those health systems have prioritized other capital investments over expanding out into the community-based settings. In a fee-for-service contract, you have to know that the value that is created by the network I have in a fee-for-service relationship accrues to someone else, typically the health plan. Let me just give you one example. 3 years ago, we were negotiating with one of California's largest health plans. That health plan gives Memorial Care about $250 million of business a year. It was an aggressive negotiation, as they can sometimes tend to be. We had a 1% delta between what they wanted to give us and what we were willing to accept. We went to full-blown termination, which is really a travesty. 1% on $250 million is $2.5 million. I was able to present to them data that using my community-based ambulatory setting, without any clinical criteria requirements from the health plan, had saved them over $20 million. They didn't know. And if they didn't know, they probably didn't pass it down to the consumer. So that's one reason we don't see people running to embrace this, because I'm investing in these joint ventures, I'm integrating my EMR with them, spending money, and I'm saving someone else money. How much better to get 100% of the HOPD rate than in my JVs less than 50% of a much lower rate. That's what I've done for the last several years, and it's cost us dearly, tens of millions of dollars a year. But we believe it's the forward-thinking thing to do. We think it's the right thing to do. And in all honesty, it's helped us perform well under our value-based contracts because it's allowed us to bend the cost curve. Finally, oopsie. You might ask, in terms of the clinical criteria that the commercial health plans have, how broad-based is it? From our research over the last couple of months in preparation for this presentation, we pulled the information from California's 6 largest health plans across 5 clinical areas: outpatient surgery, outpatient imaging, physical therapy, occupational therapy, outpatient infusion, and radiation oncology. One health plan has published clinical criteria to differentiate when a patient should go to one site or the other for 65% of those outpatient areas. 3 in California have less than 50%, and 2 have none at all. So there's certainly a movement there where we can actually continue to escalate this movement out to the right side of care and bend the cost curve. Lastly, my final word, I applaud OHCA for moving to increase adoption of alternative payment models. It won't be an easy task. It does require investment. But in my view, a lot of the things that we might have been focused on over the last several years to try to reduce the cost of healthcare for the consumers is a lot like playing whack-a-mole. And you rarely win at the game of whack-a-mole. If we can get the providers into alternative payment models where they're at risk for the health of the population they serve, all those things take care of themselves. If I was fully at risk, a health system was fully at risk for the health of a population, I wouldn't think twice about having a robust network of community-based ambulatory centers. I would want to move them there because it's 100% my cost. I'm not passing it on to somebody else. So the faster we can move it there into true risk-based models, I believe we'll meet our goal much more quickly. So with that, I apologize if I went over. I wasn't watching time, and I'm happy to answer any questions at your direction.
Thanks very much. Why don't we start with David and then work our way around?
Well, thank you. That was indeed an intriguing presentation. The example that I used this morning was a procedure that started out as a hospital intensive procedure, moved to hospital outpatient departments, and is now performed in ambulatory surgery centers, probably 10 minutes a shot or so. So it can be done and has been done. So apart from, or more specifically, with regard to alternative payment models, where do you see the ability to kind of squeeze things further if you want to try to focus on cost reductions?
Well, I mean, I think continue to advance the virtual care options has the potential to do that. It gives faster access to care and care that somebody doesn't have to go to the ER not knowing what to do. We have a virtual urgent care. And the majority of time, you don't need to go to the ER. That's a whopping savings. The incorporation of behavioral health into primary care. Unfortunately, that was bifurcated several years ago by well-intentioned legislation trying to give it fair, even due to healthcare costs, but it separated it. We're forcing it to be integrated now. Several years ago, we started to, as a pilot, and now it's spread throughout the health system, embed behavioral health workers, typically MSWs and LCSWs, supervised by a psychiatrist who can supervise many at a time, into our primary care clinics. Physicians aren't generally trained to understand how to deal with depression, anxiety, bipolar disorder, schizophrenia. So when they suspect a patient might be depressed, rather than give them a referral to some health plan's network of behavioral health workers, hope they actually follow up. The appointment might be 2 or 3 weeks later. They might not feel as depressed that day, so they're not going to seek services. It simply doesn't work. So we have these folks in the medical clinic. It's a warm handoff, and we've seen depression, the movement toward remission of depression much faster than anything else, and it reduces our healthcare expenditure. So spending money in behavioral health actually causes our healthcare expenditures to go down for that population.
Thank you.
You bet.
Thank you, and I really appreciate your presentation, and actually appreciate what you just shared about behavioral health. For example, there was a model that actually was involved in way back when was Massachusetts, actually still going around now, where psychiatrists are actually available, not on site because you couldn't have that many out, but actually virtually at the point of care. So what you described with the e-consult. So literally you could contact the person and they would tell you like, okay, well, these are the things you need to do now. Do you need a referral or not, right? Because you got to avoid unnecessary referrals, et cetera. But the problem is no one wanted to pay for it.
Yep.
Right? They're like, no, that's separate. The psychiatrist didn't see the patient directly because it's all through the primary care doctor. So basically we had, missed opportunity there, right? And too often, and this is something I ran into over and over again, is that we'll do pilots, whether medical home or other types of things, and the question to ask afterwards is why didn't you take those to scale? Except the payers didn't want to pay for them at scale, and so that becomes a problem, right? So we have these things where we increase quality, reduce utilization, right? Got people, et cetera, and didn't happen. So I appreciate what you're saying here. Actually, one other thing that's interesting I'm dealing with right now, I have a friend of mine, a physician friend, who's actually asking for my help because apparently a state agency is not allowing their hospital to actually telling them they have, in order for them to perform fairly, I don't say simple, but not overly complex procedures, that they need to actually upgrade their place to a full OR in order to perform the procedure, which the hospital doesn't actually have space for, versus essentially a procedure room. And so again, this is where it's our government that's forcing them to increase the cost. They don't have enough volume to make sense to grade it to a full OR, but then the hospital is being told that's the only way you're allowed to do the procedure, even though there are clinical guidelines from national bodies that said, no, you can do this in a procedure room, right? And so they're having a fight right now, with the person over the agency saying like, well, look, otherwise we just can't do it. There's not enough volume to make it support this. The national guideline says you can, and otherwise what it means is that if we don't, then in which case we just won't do it, and then people have to drive hundreds of miles away in order to get the procedure, right? And of course that also increased both costs as well as, of course, the barriers to the patients. So I think there's a lot of things that we can do. It's not just the providers. Sometimes it's the payment, and by the way, the government's a large payer, and as well as our own regulations getting in the way. That's driving up costs, and hopefully, we need to recognize that. But I guess the question I have for you here is that so you've done all these things, thank you, and you're here and you're telling us about it. We're talking about 3% cap on increases. You've already kind of squeezed that out of things, some of these costs. So what do you think you're going to be struggling with if we decide to do a 3% cap for, you're here because you're an example of how we can do things better and less costly.
Well, the question might be reframed, will we be able to stay at or below the 3%? And the answer is I don't know, in part because when folks think particularly of hospital costs, they've got something in their mind, and that rarely includes the highest cost pharmaceuticals that are administered in a hospital flow through as hospital cost. The highest cost medical devices, lovely innovations that the hospital does not choose. They're chosen by independent surgeons, usually influenced by a sales rep at a medical device company. The doctor doesn't know what they cost, nor should they, but the hospital absorbs that cost in most payer contracts, certainly Medicare and Medi-Cal. So we see that kind of technology flowing through. We could see blips, but again, I think the system is such that those could be explainable if you can demonstrate that. One of my concerns, and it has been since Assemblymember Wood was working on some of this in the precursor world of OHCA, was we're not all starting from the same place.
Right.
I mean, that we've been working now for a decade, much to our own detriment, which I don't expect people to be terribly sympathetic about. We've lost millions of dollars, and last year had a significant negative bottom line. We don't have that many more areas to turn dials, whereas some other elements of the healthcare system have more areas where they can turn dials. So that, I think, is an unpredictable aspect of where we might be going.
Okay. Well, I appreciate that. And again, thank you for the investments you've made. Recognizing it's like an over a decade, right? So this isn't something you just did in a dime. And appreciate the presentation. Thank you.
Thank you.
Elizabeth, please.
Thank you for that. I have a few questions. So first of all, this is sort of like a model program. That's exactly why we're having this section, to learn what is doable. Do you have an estimate of sort of how much you have saved total cost of care with this sort of specific intervention that you shared?
With the community-based ambulatory sites, we've not done that math, but if we take, albeit it was one of the largest health plans in California that I could demonstrate on imaging and ASC alone, I saved them $20 million over doing it in HOPD, one health plan. So I'm guessing it's probably 60 to 80 million a year, year over year. So it's not insignificant.
Yeah.
Statewide, we're talking hundreds of millions of dollars.
Yeah. That's very significant. My question is sort of, so you've talked about the challenges that you overcame to do this. Why haven't others taken this path? And sort of what are the barriers? Because clearly your leadership is exemplary here, but why aren't other community-based systems or hospitals moving in this direction to become more affordable?
Well, I think more and more are, but again, I lay a lot of the blame on the historic fee-for-service system, because to do those things, investing in behavioral health, investing in a community-based ambulatory center, you're spending money to cause yourself to be paid less. There's not many businesses you'd be around too long to do that. Now, healthcare's a little quirky, but again, not to beat a dead horse, so to speak, moving more rapidly APMs, that stuff happens naturally. You do it because it's in your interest, and it just happened to be also in the patient's interest, which is a great combination.
Well, it's also in employers' interest, and Activision, Blizzard, and Boeing are my members, and so you are literally outlining what they want, like integrated behavioral health, appropriate clinical sites of care for a lower cost. So if employers who are actually paying the bills and the providers want it, do you have ideas for how to get everyone else there?
Well, certainly the next topic you're going to discuss, setting the targets for APMs, I think will go a long way. I don't know what teeth it may or may not have. That's beyond my pay grade. But I think if we can move not only providers, but also health plans. I mean, it's not critical of health plans, but most of them are publicly traded companies. They have an obligation to shareholders. They know business will continue to move from a more expensive setting to a less expensive setting. They probably want to appreciate that delta. They're getting charged the same premium, but they're going to have lower costs. We need to encourage them to hand that off to the providers and let the providers manage those patients.
Thank you.
You bet.
Rick?
Thank you so much for the interesting presentation. Two really quick questions. Do you have a kind of a rough sense of what fraction of your revenue is currently coming either from capitation or from sort of significant shared savings arrangements?
It's probably, well, it depends by hour because we're an integrated health system. On our physician side, it's probably 80 to 90%. On the hospital side, it's probably, try as we might, maybe 30, 35.
Great, thank you.
You bet.
And then a sort of different version of Richard's question. He was asking about the future and 3%. Do you have an estimate for the last, 3 years or 5 years or some period of time of what the year-over-year increase in costs, either total costs or even better costs kind of per attributed person or HMO person or some denominator?
I don't, but I probably have people that could compute that in the back of the home.
I think that would be useful for us. You're sort of an exemplary system here. What does this look like for exemplary system?
Building exactly on that question, sort of what you will do to meet a 3% or lower target to continue these innovations, sort of what you would do and maybe some recommendations for the industry.
Well, I think continue to expand the behavioral health integration because it makes an enormous difference. I'm talking 300% delta in the same cohort of patients. I'm talking seniors, between those that have managed depression and those that have unmanaged depression. I mean, it's a shocking difference. Another area which I know might step on some toes, the incorporation of artificial intelligence, both on the administrative side as well as the clinical side. I think we have no idea the impact that can have. So I'm a big advocate of that, although I'm also a fan of guardrails to make sure it stays from running amok.
David.
Yes, a great discussion, and thank you very much. Very interesting. I don't really know, so I want to ask you, how prevalent are systems like yours in California? I don't want to ask you to necessarily name systems, but what's your sense of the prevalence today?
I think it varies. I don't know too many that have this proportion of community-based off-license sites versus hospitals. In fact, I know of none. It's just something we've been very passionate about. So that's unique. But again, it's replicable. I mean, there's nothing magic, frankly, about it. It just took a commitment and, frankly, a very understanding board who saw negative margins for some time because we were trying to do the right thing.
I think from your presentation, you have your own plan?
We do have our own health plan, yes.
What percentage of, I guess, your business is through your own plan versus contracting with other plans?
Yeah, great question. While it is a full Knox-Keene license plan,
right.
I made the decision that competing against the big health plans was probably not in my best interest, and so I don't. The only commercial product we have is for our own employed physicians and their families. That's it. All the other business we do is plan-to-plan Medi-Cal, because we have a big children's hospital. We have a hospital in downtown Long Beach. It's a big Medicaid population, and so we play in the plan-to-plan space.
Okay. Well, a part of the reason I'm asking is, and I appreciate that, is that sometimes payers say they want something, but they're not willing to pay for it. And so that prevents you from innovating in that because you're not going to get reimbursed or paid. So, obviously, hopefully with an APM, we get around that. But sometimes plans are very specific. As I said, they weren't willing to pay for the psychiatrist. So therefore, if we didn't find money ourselves, digging in our own pockets, it stopped happening.
Right.
So that's what, if you had your own plan, you could decide to pay for it.
We could do that, yeah.
But if another plan doesn't, then you're digging, you have to do it yourself. Thanks.
Or direct contract.
Or direct to employer contract.
Yeah, go ahead, Rick.
I was struck, one of your slides showed 400 primary care physicians and 1,500 plus affiliated specialists. And so fewer than less than 25% of physicians being in primary care. That strikes me as kind of lower than at least health services researchers, health policy people would want.
Right.
Is that, am I getting that right, or am I missing something, or is that something you're trying to change, or does it work well for you the way it is?
Yes, and no. You've got it right. We are trying to change it. We're trying to add a lot more primary care. That said, the model of employing primary care physicians, it's a significant financial loss to health systems. So we're better with an aligned IPA. We deal with a lot of IPAs. One of them we're completely financially aligned with, so we kind of move in the same direction. We're looking to expand that. The number of contracted specialists is largely on the IPA side because that's kind of the model they've always had, to have a neurologist, everywhere they possibly could. So some of those folks have very little business, so that it looks more inflated than it probably is. But your point is a very good one. Primary care is really where it needs to sit.
Okay, just one, as we transition to public comment, thank you very much, Dr. Arbuckle. And just a question for staff as I was listening to this really interesting presentation. My mind was going back to something that came up in the previous public comment about, I think, a presentation that the IHA is doing today for DMHC, I think it is. I was just wondering if maybe we could invite the IHA to make a similar or deeper dive presentation. It seems like that might, to us here on their findings. Maybe you could take a look at that.
We're happy to take a look at that. Thank you.
Thank you. So could we call public comment, please?
Yes, thank you. At this time, we'll be taking public comment on the most recent agenda item. If you wish to make comment here in the room, please make a line at the podium. And we'll also be looking for virtual raised hands from virtual participants at this time. Please do try to keep your comments to 2 minutes or less. And we'll start with the individual at the podium.
Beth Capel on behalf of Health Access. The longer we sit in these conversations, the happier I am that the law includes not only the spending target, but the emphasis on primary care and behavioral health and the alternative payment models in the conversation you're about to have, and the investment that this organization is making in the, I'm sorry, I still call it the primary care work group. It has a more elevated name, has been working together very collaboratively across consumers, payers, providers, and purchasers. And so I think this work is very important. The other thing I'd say is I think if we, as consumer advocates, thought that the use of hospital outpatient clinics was primarily driven by clinical reasons rather than revenue, we'd probably have a different attitude. And so about site neutral payments and that sort of thing, that what you heard described to you today, where it's a very thoughtful use of clinical criteria, is the sort of thing we should be pushing towards. And every time I hear another anecdote from Dr. Pan, I have another thing to add to my list of the things we should try to avoid doing. Thank you.
Thank you. Now looking to our virtual members for any raised hands. We see none at this time, so we'll move back to the podium.
All right, Bill Barcelona, APG, America's Physician Groups. I was gratified by that presentation from Memorial Care, and APG is supporting the proposed alternative payment model standard that will be presented today. And we're very thankful for being involved in that work group. This is so important. Organizations like Memorial Care that are taking a global payment and integrating their delivery system to provide a coordinated level of healthcare delivery are doing this mainly under a capitated delegated HMO model that provides first dollar coverage. This is one of the things that SB 184 does not exactly address. And to my way of thinking, this is really an area that we need to focus on if we are truly going to achieve cost control in this state. And I'm going to take you back to 2013 when the Berkeley Healthcare Forum issued its report that called for a rapid transition to this type of a coverage model with this type of a delivery system married together in order to achieve $110 billion in savings. Now that was 10 years ago. And we didn't do that. And here we are today. And what has happened in the interim? Well, this coverage model and this delivery system model has actually shrunk over time. I can recall when I was back at DMHC in the early 2000s, we had about 10 million lives under this model. Today, we only have 2.6 million lives. And I believe it is the loss of that first dollar coverage model joined together with this type of an integrated delivery system that's based on value-based payment that has led to the cost increases in this state. We asked Milliman to do an analysis back in 2015. And the question we posed to Milliman was, what would California's healthcare spend be if there were no capitated delegated model in the state? And it was based at that time on 2.7 million lives in the commercial model. And they came up with a figure of a 5% increase in total healthcare spending at a cost to Californians of $3 billion annually. So please remember this when you're thinking about how we can actually cut the cost of healthcare by changing the inputs into our system. Thank you.
Thank you. Looking to our virtual members, seeing no raised hands, and looking here in the physical room, no one else at the podium. That concludes public comment for this agenda item. Thank you.
Thank you. I think that's an easy segue to Margarita Brandt, who I think is going to step us through the alternative payment model.
Yes, good afternoon again. And yes, Margarita Brandt, I'm the Assistant Deputy Director for Health System Performance, and I'll be sharing today our proposed recommendations for alternative payment model standards and an alternative payment model adoption goal. And joining me this afternoon is Mary Jo Condon from the Friedman Healthcare team, who will help answer questions from the board. So, as a refresher, these are the 5 focus areas for promoting high value across OCA. So promoting a high value healthcare system alongside our work to look at healthcare consolidation and slow healthcare spending growth. And so our intent is to not simply have a low cost system, but to reorient the healthcare system towards greater value. And today we'll focus on that highlighted box of alternative payment model adoption and the work stream there. So as you heard from some of our public comment speakers, OCA began convening a monthly multi-stakeholder investment and payment work group in June of last year, and this work group supports our work on primary care, behavioral health, and alternative payment model adoption work streams. And regarding alternative payment models, the work group provided input into the draft standards and implementation guidance, informed the definitions we'll be using for data collection of APMs, and then also helped craft the APM adoption goal. And work group members have helped us refine these recommendations as we incorporated feedback from the advisory committee and other stakeholders. So we'd really like to thank these work group members for their extensive input throughout the past 6 months or more, and for getting us to these recommendations we'll share today. So as an example of some of the topics and the questions we've considered in the work group for alternative payment models, we've considered things like how can we use implementation guidance to support healthcare entities to best meet the best practices we laid out in the OCA alternative payment model standards. How can the APM contracting standards and implementation guidance support improvements in health equity? And then, should OCA require alternative payment models to have a link to quality in order to count towards our adoption goal? And what are the trade-offs of the various ways to structure the adoption goal? So turning to the statutory requirements, a brief overview of that guided our work. So essentially, our work in alternative payment models has 4 areas. So one is to move more payments from fee-for-service to alternative payment models, measure the movement of this payment, and set a statewide goal for the adoption of alternative payment models. And the goal could be based on a % of members, providers, or payments. And to adopt contracting standards that providers and purchasers can use to support alignment and promote equity and the greater adoption of alternative payment models. So, and the statute also notes that we can require payers, fully integrated delivery systems, and other healthcare service plans to submit data and other information to support the measurement of the adoption of APMs. And so it specifies the types of data that we can collect for these purposes. So for the alternative payment model work stream, we organize the work into 3 areas. So the first, of course, is drafting the alternative payment model standards, and we approach these standards as serving as best practices to guide healthcare entities in developing contracting terms that promote equitable, high quality, and cost-efficient care. And then the next work stream is defining an alternative payment model and what counts as an alternative payment model towards our third work stream, which is setting adoption goals. So this is just a figure that outlines the process we worked through, especially with the work group and leading up to our work group discussions. So we essentially have 2 phases of our process. So we gathered input from the work group, we used stakeholder interviews, we also focused a lot on coordinating and collaborating with our sibling state departments. We did a fair amount of literature review, data review, what's going on in other states and nationally related to alternative payment models. And then in our second phase, we have again reiterated or iterated based on feedback we're soliciting from the work group, the advisory committee, and again, our sibling state departments. So the timeline for our APM work streams, we began our work last summer, as I mentioned, and today we look for your feedback on the draft APM standards and adoption goal. And so based on feedback today, we'll revise the standards and adoption goal, come back to our work group, and then continue to revise leading up to seeking board approval in June of this year. So getting into our standards. So a little bit of additional guidance for the standards is included in the statute. So the statute notes that the APM standards should facilitate multi-payer participation in APMs by leveraging best practices and enabling flexibility. It requires the alignment of measures and focusing on protecting from unintended consequences of alternative payment models. And the standards are also meant to reduce administrative burden through alignment across state, national, and payer programs. So we used this guidance as essentially a set of principles that the standard should aim to uphold. And this slide outlines our approach to developing the standards and implementation guidance to support the standards. So we are proposing standards that are best practices to support contracting decisions across alternative payment models. And the purpose is not to develop specific contracting language or standardized contract terms, but rather to encourage alignment across current and future APM arrangements. And then the implementation guidance is technical assistance that can support healthcare entities to meet the APM standards. And then wanted to share what we see as the vision of success for the standards. So the standards, again, are only successful if they are used by healthcare entities and used to inform alternative payment model contracts in the future. So the first milestone we envision is that stakeholders, potentially like sibling state departments or purchasers, would endorse the standards and commit to using the standards to inform future contracting. And then following endorsement, we look to see for additional alignment across alternative payment models that makes it easier for payers and providers to participate in APMs. And then, of course, looking for our end result is really that performance improves, that affordability improves, quality and equity improve. So a little bit of background or feedback we incorporated from the advisory committee based on our presentation recently. We presented to the advisory committee in November. So what the standards you are seeing today and the supporting implementation guidance have been revised based on advisory committee feedback. So these are some of the key points that we added based on that feedback. So we increased specificity on what payment model should incentivize to improve affordability. We added more detail about how to reduce financial barriers for preventive services. And we put more emphasis on supporting a range of providers in participating in APMs. And then also we highlighted that the standards should support addressing inequities in patient experience, in addition to what we had previously had was a focus on cost and quality and equity. And then lastly, we added a specific reference that technical assistance to providers should support on helping those providers meet and improve their performance metrics on the measures and metrics that impact their payment. So here are the first five of 10 alternative payment model standards. And I want to provide a little bit of background before I walk through the 10 standards. So from the feedback we received from the work group, the advisory committee, and our sibling state departments, we noted that the standard should explicitly state that APM should result in improved affordability, quality, and equity, and really realign financial incentives to promote preventive care. That the standards should support models that are linked to quality and should be budget-based. That the standards should support alignment across payers on APM model design and performance measure, and support models that promote interdisciplinary primary care teams. So the full set of standards and implementation guidance were published for public comment along with the board materials. And then also in the link you have on the slide here, there's clean and red line versions posted that show the changes we've made from the advisory committee feedback in November. So we're proposing 10 alternative payment model standards, and the first 5 standards are to use prospective, budget-based, and quality-linked payment models that improve health, affordability, and equity, to implement payment models that improve affordability for consumers and purchasers. 3 is to allocate spending upstream to primary care and other preventive services to create lasting improvements in health, access, equity, and affordability. 4 is to be transparent with providers in all aspects of payment model design and terms, including attribution and performance measurement. And 5 is to engage a wide range of providers by offering payment models that appeal to entities with varying capabilities and appetites for risk, including small independent practices and historically under-resourced providers. So compared to the standards we just reviewed, standards 6 through 10 really emphasize focus on addressing inequities and improving the capabilities and capacities of providers to participate in alternative payment models. So a theme we heard from our work group and other departments is that we really need to acknowledge that demographic data collection needs to improve in order to be used in alternative payment models, and then also more broadly to adjust payments for the purposes of addressing health-related social needs and inequities. So standards 6 through 10 really focus on those themes. So 6 is collect demographic data, including real SOGI data, to enable stratifying performance. 7, measure and stratify performance to improve population health and address inequities. 8, invest in strategies to address inequities in access, patient experience, and outcomes. 9 is to equip providers with accurate, actionable data to inform population health management and enable their success in the model. And 10 is to provide technical assistance to support new entrants and other providers in successful APM adoption. So now that we've reviewed the APM standards, and we look forward to your feedback on that when we pause for discussion, I wanted to walk through our APM adoption goal recommendations. So starting with a little bit of background and framing in terms of how we will collect data and the definitions we'll use, and then we'll also walk through some data on current APM adoption in California and nationally. So to monitor APM adoption, we plan to collect data using an HCI developed framework for collecting non-claims payments. So we call this the HCI expanded framework for non-claims payments. And we plan to crosswalk this to the Healthcare Payment Learning and Action Network framework, or the HCP LAN framework, with which many people are familiar with. So this expanded framework that we developed, which is in your appendix of the slides, it allows HCI to collect more detailed information on non-claims payments that can be rolled up into these HCP land categories. A few other notes before we dive into adoption numbers is that adoption goals in other states and nationally tend to focus on the HCP land categories 3 and 4. And those are typically shared savings or shared risk arrangements, and then your global payments or your capitation type payments. And adoption is typically measured as the money or spend flowing through a contract with an alternative payment model, members attributed to an alternative payment model contract, or providers contracted under alternative payment model arrangements. So here is some data on APM adoption nationally from the HCP LAN. So nationally, APM adoption sits about 41% across those categories 3 and 4, and this is data from 2022. So, and we'll note that adoption was virtually flat across payer types from 2021 to 2022. So we see in this national data that APM adoption is the lowest in the commercial market at 34.6% and the highest in the Medicare Advantage market at about 57.2%. So moving to commercial adoption or commercial APM adoption in California. So this slide provides data on APM adoption in California using data from the Integrated Healthcare Association, or IHA. And I'll spend a bit of time walking through this to add some context and numbers to these percents here. So this data collected by IHA represents 88% of the commercial fully insured market, or a little under 12.5 million people for 2021. And self-insured data is excluded here. So commercial APM adoption by enrollment in California in 2021 differed greatly between HMO and PPO arrangements. And this data is based off of members, but IHA also looked at this data by spending and found similar results. So for HMO plans, we see really high alternative payment model adoption with 99% of members attributed to Category 4 arrangements. For PPO plans, we saw low APM adoption with about 16% of members attributed to Category 3 arrangements, or those APMs with shared savings or shared risk, and none in Category 4 arrangements. And so when you combine this on that bottom row, you'll see that 77% of members are associated with Category 3 arrangements, and this equates to about 9.5 million people, and 3% of members are associated with Category 3 arrangements, which equates to a little under 500,000 people. And the remaining 20% of members were associated with Category 1 or 2 arrangements, which is about 2.5 million people. And then of note here, about 50% of the commercial fully insured population is enrolled with Kaiser Permanente, which is included in the HMO Category 4 data here. And that's about 6.3 to 6.6 million people. And then an important note here for Category 4 arrangements and for a lot of this data is that we don't know whether these Category 4 arrangements have a link to quality. So there are some health plans that participate in the Integrated Healthcare Association programs, especially the Align, Measure, Perform program, that removed the opportunity to receive a quality incentive from their contracts. So those we're counting in Category 4 may be not linked to quality, and those are generally considered Category 4 in the HCP land framework. And for those members in Category 3 arrangements, it's unclear whether they would reach minimum risk thresholds that we are recommending, and we'll discuss that in a few slides. And before we move on to the next slide to focus on Medicare Advantage APM adoption, I wanted to note that we currently do not have APM adoption data for Medi-Cal, and we're coordinating with DHCS on total healthcare spending data collection for Medi-Cal managed care plans and considering how these recommendations relate or interact with the DHCS contract requirements. So for Medicare Advantage, we again here have data from IHA from 2021 that shows that just under half of California Medicare beneficiaries participated in traditional Medicare Advantage, while the rest were enrolled in a Medicare Advantage plan. And of those Medicare Advantage beneficiaries, about 94% in 2021 were enrolled in a risk arrangement. So, but similar kind of caveat here is that we do not know whether these arrangements would be considered having a link to quality. So this is about 650,000 beneficiaries enrolled in a risk arrangement. And then moving on to some adoption goals that we've seen in other examples, wanted to share that CMS is also looking to increase adoption of APMs within traditional Medicare. So by 2030, CMS is aiming to have 100% of traditional Medicare and Medicare Advantage payments in an alternative payment model, which they are identifying as HCP Land 3B or 4. So those would be arrangements with shared savings and shared risk, or global budgets capitation models. And one avenue for traditional Medicare to participate in APMs is through the Medicare Shared Savings Program or through the REACH program, the Realizing Equity Access and Community Health Programs. So I wanted to provide a little bit more context about kind of some of the decisions we've made and the approaches we're taking in terms of definitions and goals. So with the purpose of increasing and promoting a shift from fee-for-service to APMs and to better align financial incentives, we wanted to outline our definitions and adoption goals and how they interact. So we will be using the HCP LAN framework to monitor our progress towards adoption. And while we don't have the authority to enforce the adoption goal, we'll publicly report on our progress. And also talk about in a bit, we've drafted definitions to define what counts towards the APM adoption goal, to include quality and a minimum threshold for shared savings. So really thinking about promoting quality, equity, and affordability alongside adopting greater risk. So in getting towards our adoption goal, there were 4 key strategic decisions that we considered in our work group. So these are, should certain types of payment models count towards the goal? Where do we draw the line in terms of category 3 or category 4 or category 2 using the HCP LAN model? The next is whether the goal should vary by payer type, commercial, Medi-Cal, Medicare, or by product type. Should the adoption goal be based on % of members, % of non-claims payments, and then how should the goal be structured? So stair steps, absolute improvement goal, or a multitude of those. So before we review our draft goal and propose the decisions we made to answer those questions, I wanted to share an example from Oregon, who has made many of the same decisions in designing its APM goals. So Oregon limits the types of payment models that count towards the APM goals. It also does not vary those goals by payer or product type, and its goals are based on a % of total healthcare spending and are designed in a series of stair steps goals until 2025. So as I mentioned previously, in defining APMs and what counts towards the APM adoption goal, we are recommending 2 key decisions here. That one, that OCA, that we recommend that Category 3A and Category 3B APMs should count towards the APM adoption goal if they meet a minimum threshold for shared savings or shared risk. And this requirement ensures that APM arrangements that are still built on a fee-for-service architecture have tangible financial incentives or penalties that are contingent upon spending or quality benchmarks. And these requirements are in the appendix. And the second is that we recommend defining payments as linked to quality only if they involve potential for financial bonuses or penalties based on a provider's performance against predetermined quality benchmarks. So this would exclude categories 3N and 4N that are in the HCP land framework. And this definition again ensures that APM arrangements have a substantial connection between payments and quality outcomes. So getting more towards our proposed APM adoption goal, so we are proposing that we recommend monitoring progress towards the APM adoption goal using the HCP land categories and members attributed to HCP land categories 3A, 3B, 4A, and 4C. So only members enrolled in that highlighted box would count towards the adoption goal. And then another recommendation here is that we use a set of interim milestones in a stair-step structure to achieve the APM adoption goal by 2034. So this stair-step structure provides a path for each payer type to reach 75% APM adoption to those HCP land categories 3 and 4 by 2034 while recognizing the differences in starting places. And you'll note here the 75% goal, especially for commercial HMO plans, may seem low, and that is intends to account for the lack of the data we have on the link to quality. So we are requiring that HMO capitation have a link to quality in order to count towards our APM adoption goal, and we would get that through our data collection goals. Our data collection process. So to wrap up, our overall APM adoption goal is that we recommend a goal of 75% of members attributed to HCP land categories 3 and 4 across payer types, commercial, Medi-Cal, and Medicare Advantage by 2034. And just to outline some next steps, so we're excited to get your feedback today on these standards and adoption goal, and we'll also be soliciting public comment through our proposed memo that summarizes the standards and adoption goal. So using all of that input, we'll come back to our work group and review and revise our standards and adoption goal, and then come back to you all in June to solicit adoption of the standards and adoption goal. So I will pause here, and I'm happy to go back to any slides. I know we covered a lot of content.
Thank you, Margareta. We'll go around starting with David.
Well, thank you. I thought that was really interesting and a great presentation. Before speaking specifically to standards, I just wanted to get some more background. I appreciate the Oregon example. Among the other states that are pursuing affordability standards, how many are relying upon APMs as well, in addition to Oregon and California?
Sure. So Mary Jo might have more information on this that she can share. Oregon has APM adoption goals. They also have something similar to standards. They call them something a little bit different. Rhode Island also has something similar to standards, so they're really promoting APMs as well. Mary Jo, do you want to?
No, I'll just continue. I know, Oregon is in physical proximity to us, but their delivery system is similar in many ways to California as well, but most of the other states are probably significantly different.
I think that's right, but I also I think it was helpful to look at those states for some lessons learned and then think about how they might be applied in California, which may be different. More similarity, obviously, across the PPO market here than the HMO market.
Richard?
Appreciate the presentation and appreciate all the work that's gone into this. I guess I'm a little confused about, so it sounds like we're setting goals in terms of percentages of people who are in an APM, but, and maybe you alluded to this, but I think, well, I mean, I'm all in support of APMs, but they're not an end in themselves. They're a process end, right? Mm-hmm. So, and I appreciate that you're linking at the quality. So the question I have is that well, I guess what kind of quality measures are we tying to? For example, our biggest opportunity to reduce cost actually is trying to better control chronic disease. That's about 80% of our spend, right? We also know that the sickest 10% spend 2/3 of the dollar, right? If we can get the exacerbations down and so forth. So, so when we say APM, right, and link the quality, are we linking it to specific chronic disease outcomes? What kind of outcomes are we linking to? And the other thing, actually, just the other part, this is where an APM quality goal may not necessarily be. So, for example, some have argued that preventative services, all right, because they're more on a schedule, actually don't fit well into an APM approach, right? Because you basically want everyone, you're paying people to not show up or to reduce utilization. Well, actually, you want people to utilize their preventative services, right? So if you stick an APM over, let's say, colonoscopy screening rates or vaccination rates or something, it doesn't quite work out very well, right? So I'm curious about, aside from the mere percentage of people who are dollars or patients who are in APM, exactly what kind of APMs are we talking about? So what kind of quality measures are we tying this to?
So in terms of the types of alternative payment models, we are looking at category 3A, 3B. So those are, shared savings, shared risk.
Yeah, I get that. But what is it that they're targeting? So I get the shared savings, I get the et cetera, but what are what quality are we tying it to?
So the quality piece in all our standard, the implementation guidance that supplements the standards, we are referring to the standardized quality measures that are used by our sibling state departments. So the Department of Managed Healthcare, the Department of Healthcare.
All of them?
Cover California. They have essentially a very aligned set of measures that are across all of those organizations. Sometimes there's like a core set of measures that are aligned across those organizations. So yes, we've referred to those in order to not kind of increase administrative burden. We're looking to align with the other state departments on the measures that they currently use.
Okay. I appreciate that, and Olivia, I appreciate not having duplication. What I'm also concerned about is, depending on what all the different measures are, and we can go back and look at them, is that, so for example, okay, I now have a plan, right? I have people on APM. I do better on diabetes. I'm doing worse on COPD, and it averages out to be in the middle. All right. I mean, no, I see you shaking your head. So that's the thing, is like, are we going to be able to get organizations to focus on actual improvement in defined areas where to make the effort, right? Because what happens is that also, if it gets too diffuse, then what happens is the incentives don't work out, right? So what happens is, yeah, I did better in one, and then on average, financially, the cost sharing comes out to be the same. So in other words, people aren't going to be investing in making particular improvements that actually lead to better outcomes in a particular, in a particular, chronic condition, right? Because everything's sort of divided up amongst, let's say 5 or 6 different chronic conditions, right? So you do better in one, you do better in worse in the other, and you average out, you're somewhere in the middle. So I guess, are we sure we're creating the kind of incentives that's going to drive both improvement in quality and hopefully also, savings, and that the shared savings actually are very clear to the people who are doing this, that this is coming from their improvement in doing X, right? Because if it gets diluted out, then you lose the incentive.
I mean, that's very much our intention with these standards and the supporting implementation guidance, really focusing on that prospective budget-based quality-linked payment models that health plans and provider organizations should be using to pay their providers. I think we have a challenge with, in terms of data collection, to know exactly, what we are health plans are incentivizing, but we are promoting a set of standard quality measures and health equity measures, and focus on especially Category 4 adoption.
Okay, all right. Let's just put it this way, because I'd be interested in a lot more specifics about how this would operationalize. After all, I'm a physician, so like what kind of incentives does that translate down to someone who's actually delivering care? We probably don't have time to get into all this right here, but I just want to be sure, like, let's put it this way. Again, appreciate all the work that's going in. I appreciate you talking about these categories, but at this point in time, it sounds more like, a lot of standard speak and not enough about, okay, I'm a provider. What am I supposed to do? How do I get the shared savings? What are the things that I'm going to change in my practice that leads to better quality and hopefully lower costs? So we got to translate some of this language into specifically what do you want people to do, and what are we incentivizing people to do?
I might offer one clarification. This is not a single APM design. Each payer will continue to develop APM arrangements with the provider organizations that they contract with. Those arrangements will all look a little different. We hope that over time they better align with the standards. But with regard to the quality measures, very much in line with what you mentioned, not all the same quality measures are right for all the same types of APM arrangements, right? So if you have a colonoscopy bundle, you're not going to have the same quality measures as if you are caring for a population of patients as a primary care provider. And so there's no, the counting as an APM does not require you to have a certain type or certain
I appreciate that. Maybe I'll share an anecdote since Beth Cattell likes my anecdotes. I'll put it this way, like, okay, I'm a primary care doctor. We see multiple payers, and one payer says, do this for asthma care. Another payer says, do this for something else. Another one says that, and each one's a segment of my practice. Then I step back and say, well, what's my practice going to do differently? Right? And how much do I have to invest into that? Okay, because I have to get all my nurses, my clerks, and whoever else in the staff to do things differently than they're doing now. And so what happens when they're all fragmented across, and for each payer, they're like, oh, our big thing's gonna be this and that, et cetera. You don't. So basically, you end up doing either nothing, or you do one for one plan and you don't do the others. So again, I think this is great. We need to move in this direction. I'm all for it. But I think the implementation is going to matter, because in the end, what boils down to is that you need the people who are providing the care to be lined up, and they can see what the shared savings are, et cetera. Because otherwise I get a little bit of this, I get a little bit of that, and it's not, frankly, none of the little bits is worth the trouble of the cost of actually upending the way I do things in my practice. And then they don't do anything.
Dr. Pan, if I could, I just want to be clear. HCI doesn't have the authority to prescribe so this is what we can do, is to set these standards and to set a threshold. They are unenforceable standards, and I think we're being clear about that. But we can't prescribe what each health plan and medical group is going to do. So this is the level at which we're able to operate under the statute.
I appreciate that. We can talk about this more later. Okay, thanks.
If we can move on, Rick, and then Elizabeth, I'll call on myself, and if there's nothing else, we'll go to public comment.
Thank you, Ian, and thank you, Margarita. A comment of context. I was working in DC in HHS. I was the director of the Agency for Healthcare Research and Quality at the time that Secretary Burwell, who was a big promoter of this whole framework of paying for value and not for volume, and Petra Conway was running CMS and kind of created a lot of this HCP land. And I was somewhat of a heretic and somewhat skeptical about our ability to measure what matters. And I lost most of those arguments, as it's a not uncommon situation for me. I would encourage, and you may already have, you and the group to look at a recent piece by Bob Berenson and Laura Skopek from the Urban Institute that is a pretty scathing attack on the ability to measure quality well, and kind of suggesting that all the pay for performance that we've been doing for the last decade plus is misguided. But, you know, that being said, this is where we are. And of course, we need to pay some attention to quality. The two comments I would make is these adoption goals do seem very conservative to me. And you said that they are only 75% because we don't know how much of this is linked to quality now. You know, I'm not sure how much it matters. I know that in the framework of the HCP land, they need to be linked to quality, but you know, is this going to really get us to the sorts of improvements that we want? I'm skeptical, as I've mentioned. And I do think, you know, I know they're unenforceable, but the one of the two things that we might do that perhaps would lead to positive improvements would be to have more aggressive standards here, since we probably already have met the 2034 standards already for most of these categories. But second, and I think more importantly, and again, there may be nothing we can do other than perhaps report, you know, as we heard from Dr. Arbuckle earlier, he's got 80 to 90% of the professional revenue going into Memorial Health System coming through capitation now. So, you know, it's all in category 4 stuff, but only 35% of the revenue on the facility side coming through capitation. And I think if there's anything that we can collectively do to change that would be important. But unless I misunderstood it, nothing of what you've talked about today would actually push in that direction. And we're counting kind of 4A and 4B and whatever the other numbers are all the same.
You mean in terms of counting capitation at the facility level?
Yeah.
So I mean, we would have to look into how we could do that through our data collection, but we will be collecting payer data and how much of their payment is in these different categories. And we could look into how we could tie it to facilities.
Yeah, I mean, just you know, the IHA, I think, has reported that close to 100% of professional revenue to professional groups for HMOs, at least, is coming through capitation now. And again, I don't know how much of that's linked to quality, but the kind of challenge is to increase the capitated part of facility revenues, and trying to focus on that seems like it would be maybe the most valuable thing.
Yeah.
Enterprise can.
Rick,
We can take that.
yeah, Rick, regarding kind of the markets already meeting that 75% goal, I think for the HMO part of the market, for professional capital, you know, likely hit that goal. But Margaret, if you could elaborate on kind of the PPO.
Yes, we see adoption in the PPO market that is quite drastically lower, especially for commercial side. So I think, as we showed in that IHA data, it's about 16% of in the PPO market is in category 3. So I think, yes, the adoption goals may seem low and maybe like dispersed across the market. In order to have a single goal, we can, of course, revisit a single goal if that's something the board wants us to look at into. But really, the emphasis is on the link to quality, the minimum thresholds of shared savings and shared risk to really incentivize changes in behavior to improve quality. And then also, the focus is more generally on the PPO market to get the PPO market to move faster towards the adoption of value-based payments.
I mean, that makes some sense to me. You have 4 columns on slide 95 or 93, and it's the other 3 columns that seem like we've probably already met those targets and gone way beyond them. So it seems that part seems odd.
Yeah, that could very well be the case that those three market segments may already be there, but we would need to get the data to validate that. And the IHA data does provide some directionality, but we don't have the Medi-Cal numbers. Is that correct, Margareta?
We don't have the Medi-Cal numbers. We also don't, across all of these markets and all these columns, we don't have the details on the link to quality. So if that's a core piece, then it's a little unclear on exactly where we stand now, but we do know overall adoption is high across commercial HMO and Medicare Advantage.
Was your question on this subject, or was it
It's on the goal.
Do you mind if I just follow up then?
On the commercial PPO, I'm struggling to, so 16% at best, assuming probably the huge majority of that doesn't have quality metrics attached to it right now. Your targets have us more than doubling 16% in 2 years. And I heard Dr. Arbuckle say that they're looking at stepping back from the attributed ACO model. So I'm puzzled about what that looks like, how we promote that. Is that remotely achievable?
I think it is definitely, it's pushing the PPO market to move quicker towards APM adoption. But moving towards ACOs and shared savings and shared risk arrangements would be a way to get there.
Thank you. Elizabeth?
And forgive me if I'm just triggered, but I was on the OG HCP land. We came up with those categories. That was in the Obama administration. I then lost 3 years of my life to co-chairing PTAC, where we came up with all sorts of payment models. There's no shortage of models, readiness from the provider community. No one would implement them. The idea that we're going to say you don't have to implement them till 2034 seems completely contrary to our goal of achieving a 3% target, when we just heard from Mr. Arbuckle that that is one of the key barriers to actually reducing cost. So I have some feelings about this, because we have just given the industry a pass on moving to alternative payment models literally for the last 10 years. And now we're saying we're going to give them until another 10 years to do the change that is most likely to enable more affordable, higher quality care. So I just don't understand that. And I agree with you. A payment model is just a means to an end, and it obviously has to achieve better quality and lower cost. But the idea that we can just drift along for another 10 years when providers are telling us they have to have changes in payment, to me just doesn't make sense. I'm sorry. It was a great presentation, though. I just don't think this is going to get us there.
Well, this is incredibly helpful for us to hear your feedback. You all obviously have, all of you have deep knowledge and deep history in this, so we'll very much take that feedback back.
And are there suggestions for how, higher APM adoption goals? Are there other suggestions?
Yeah, I think we're going to have to really think hard about. I agree. First of all, we're at 75% with commercial HMO, so I'm not sure why we're not starting at 75 and getting to a higher number. I get it. You got some may have tied to quality, but you would think that's a fairly simple step. I mean, they may not like it, but it's a simple step. The one I'm actually kind of struggling with is kind of commercial PPO. Because why does someone sign up for a PPO versus an HMO? Well, because they want to be able to go to who they want, and they want to be able to kind of go out of network, right? And so out of network means, so how do you do an APM, a PPO in a way that keeps the people who signed up for the PPO happy, right? So we've got to figure out that bit of so notice, what does it mean to have an APM in a PPO type arrangement, given why people sign up for a PPO versus HMO? HMO makes a lot of sense, right? I mean, that's what you signed up for when you signed up for an HMO. And so, without figuring out what does that mean to have whatever percentage, right? Going from 16 to 35, right? Actually, what does that mean? And therefore, what are we expecting of the PPO? And also, what do the consumers who are signing up for the PPO going to be expecting as well? And is that lined up? So I think we're gonna have to figure that part out, because people, when they sign up for, well, let's say, sometimes you might not have a choice. That's the only thing that's offered to you. But for other people, they're choosing that. In fact, I think PPO rates are going up. People are rolling in PPOs at a higher. That's a growing segment of the market actually, over HMO at the moment. So we're gonna have to figure that out, and then figure out how do we make those things lined up so that we end up with the kind of value that we want to get. But and I realize, I appreciate that, at this level, yes, HCI and can't, et cetera. But I do think that if there isn't some leadership in figuring out how we better align folks, what happens is that you're going to have all sorts of mixed signals going to the providers and the shared basically everything's going to get blurred out, and then nothing will happen. It only happens when there's alignment and people get a clear signal about what they need to do in order to get the shared savings. So that's what Memorial Care does, right? They have a network and they say, boom, we're doing it this way. And everyone goes, okay, yes. And then, et cetera. If you have folks not having that clear signal, we're not going to see the kind of changes we need on the ground that's going to lead to the types of savings that you want to achieve.
Is it quick?
Just
Thanks, Rick.
to respond to Margaret's question about what to change. I would suggest not focusing on the PPOs, which I think, as Ian and Richard have said, it would be very, especially without having authority to require anything, it's going to be hard to make much change. Without having authority to require anything, it's going to be hard to make much change anywhere. But the one place that to repeat what I said earlier, might be possible at least to gather information and maybe to nudge along a bit, is around increasing capitation or strong shared savings arrangements for facility payments. It seems like I wouldn't call it low-hanging fruit, but potentially hanging fruit.
And just on the sort of theme of recommendations, I would shorten the timeline dramatically. I mean, people adopted to DRGs in months, and Medicare Advantage was able to figure out alternative payment models pretty quickly. I think we should expect more.
Thank you.
With that, I'll turn on my microphone, and we'll give public comment the last word.
Thank you. At this time, we'll take public comment about this most recent agenda item. Please do try to keep your comments less than 2 minutes, and we will toggle between individuals here in the room at the podium and members who are here virtually. If you are liking to speak from the virtual group, please do raise your hand as soon as possible so we have a sense of the queue. And with that, we'll turn to the person at the podium.
Beth Capel on behalf of Health Access. Perhaps to shed some light, and I hope not to further confuse the conversation. Not that it's confused now, but not to confuse it, not for me to confuse it. My understanding is that part of the question on Category 4 and HMOs is it's not clear whether, even in a system such as Kaiser, whether in fact there's a link to quality at the provider level. There's certainly Kaiser focuses on quality. They do lots of stuff in that area, but whether payment is linked to quality, which is the requirement for the A, B, and C categories, is not, I gather, as clear as it could be at this point. With respect to HMOs versus PPOs, our observation, yes, it is true that people buy PPOs because they think they want the out-of-network benefit. Our observation is people in California rarely use it. What they want is a wider choice of a wider network. And so that has its own challenges in an APM model, but it's not as grave as I think perhaps the focus on out-of-network use. And I think it is a knowable fact how much out-of-network claims PPOs have. That's actually a discoverable fact, not from any public data source, but the payers who operate PPOs should know that. So that's the second point. The third point, if my phone would stay on long enough, is that with respect to quality measures, the Department of Managed Healthcare, as a result of a trailer bill adopted in 2021, has adopted a standard set of 13 quality measures. And I will read off some of them because they're familiar ones: colorectal cancer screening, breast cancer screening, hemoglobin A1C, high blood pressure, asthma, depression screening and follow-up, something we fought for because it's comorbid with everything else.
It's 2 minutes.
Prenatal and postpartum care, childhood immunizations, well-child visits, child and adolescent well-care visits, plan all-cause readmissions, immunizations for adolescents, very important, and CAPS health plan survey. All of these are very familiar and common. They now apply to all state licensed health plans in the state of California. I think that's a pretty strong signal on the part of the state of California, what we want providers to focus on. The other thing I'd say is breast cancer screening is probably not a big deal for pediatricians, but it's kind of a big deal for everybody else. And yes, a lot of the costs are chronic care. I think we have the pieces in place to move this forward, and that's why we're encouraged. Thank you.
Thank you. Now we'll turn to the member of the public who is virtual with a raised hand, Travis West. We've unmuted you on our end. Please unmute and go ahead.
Thank you, Travis West, Regulatory Policy Specialist with the California Nurses Association. First off, thanks to the OCA board and staff for your continued work on these difficult issues. In drafting the alternative payment model standards, and specifically the measures for tracking APM performance, we wanted to applaud the inclusion of measures that monitor for unintended consequences. Things like tracking changes and potentially avoidable emergency department visits and hospital admissions. We would encourage the inclusion of even more explicit and robust guidance relating to tracking and preventing of unintended consequences. It's important that OCA do everything possible to ensure that providers don't seek to limit costs under APM models by avoiding appropriate and necessary care that could save lives and prevent higher costs in the future. We also encourage OCA to consider non-risk-based payments, such as global budget payment arrangements and other payment models as set forth in single-payer proposals, including AB 2200, the California Guaranteed Healthcare for All Act, which is currently pending before the State Assembly. Thank you.
Thank you. And turning to the room here in the podium, please go ahead.
Barry Arbuckle, Memorial Care. I apologize, you're hearing from me again. Just a couple of comments on the discussion. Just something to bear in mind on advancement to risk-based products or APMs with providers. They're very different in the senior and the commercial population. With Medicare risk, capitation on risk, if your patient ends up at someone else's hospital by emergency or otherwise, the most that they can charge you out of your risk pool is a DRG. That's manageable. On a commercial, the sky's the limit. So that's why you're finding fewer and fewer providers willing to go into capitation in commercial because of that significant risk. Sometimes you can reach through the health plan rates, which moderate it some. Otherwise, it's a percent of charges, and that's a challenging thing. On the topic that Dr. Pan was discussing in terms of the quality measures and metrics across the various health plans and various forms of APMs. That's a very fair statement. Even if they all agree to measure depression remission as one of their measures, we need to try to make sure they measure it the same way. That was one of our experiences as an early adopter of ACOs, is after we got into 3 or 4 or 5 of them, they measured depression with 3 different instruments and remission rates across 90 days or 120 days. The primary care doctors cannot keep track of that. So I would recommend, if you haven't already, chatting with the IHA folks, Jeff Rideout, because we did an initiative to try to harmonize the measures and metrics across not only commercial plans and senior plans, but also Medi-Cal and Medicare. It'll help advance the system, I think, more quickly. Thank you.
Okay, looking to our virtual group, seeing no hands. I'm not seeing anyone stepping up to the podium. That completes public comment for this agenda item.
Thank you. I'm told that we're going to be able to trim a little time off one of the agenda items, so we're not too terribly far behind. We have time for a 10-minute break, so let's start back up at 3:20. Thank you.
So for this item, measuring consumer affordability, I'm introducing Miranda Dietz, Policy Research Specialist and Project Director for CalSim at the UC Berkeley Labor Center, and Laurel Lucia, Director of the Healthcare Program at the UC Berkeley Labor Center. And they'll be walking us through a presentation on considerations for OCA to look at consumer affordability measures.
Can you hear me better now? Yeah, great. I'm going to give a brief introduction, but Miranda Dietz is going to give the bulk of the presentation. Vishal already introduced us, but to give a little bit of background on the Labor Center, the UC Berkeley Labor Center does research on labor and employment issues, including on health coverage and healthcare affordability for workers and their families. A little bit of history about the healthcare program at the Labor Center in particular, which is relevant to today's topic. Ken Jacobs, the co-chair of the Labor Center, started this research program almost exactly 20 years ago in the wake of double-digit premium increases in California and following a really large and prolonged grocery worker strike and lockout that many of you probably remember in Southern California. And so here we are today, 20 years later, and Miranda will be talking about how the affordability situation has gotten worse, unfortunately. And as you know, here in 2024, we're again seeing many workers in California facing double-digit premium increases. So next slide. The one after this, please. So why did we do this research that Miranda is going to present? Well, first, you know, the statute specifically charges OCA with lowering consumer spending on premiums and out-of-pocket costs, or developing a strategy to do that. And measurement seems like the first part of a strategy. And so we're going to be focused today on measurement. Also, Miranda and I were both really struck by the presentation by David Seltz from the Massachusetts Health Policy Commission at the board meeting last April, when he recommended to California that from the start, we really center consumer affordability in terms of what's measured and in terms of how progress and, you know, the achievements of OCA are communicated. I just went back and listened to that presentation because I found it really helpful. And he talked about how consumers feel affordability. And, you know, it's about premiums, it's copays, it's deductibles. Consumers don't as much feel total healthcare expenditures. So it's important to measure both. And they may not move in the same direction all of the time. So we wrote this report to kind of look back at the last 20 years of job-based coverage affordability in California. And I think our findings, you know, really reinforce the need for improved affordability and the need to measure affordability going forward. And then, as Miranda will describe, we have some specific recommendations for OCA on, you know, which measures and data sources would be good to track alongside total healthcare expenditures.
Great, thanks, Laurel. Good afternoon. So first thing we did is we looked at what these measures of consumer affordability could tell us about the past trends. And consumer affordability for healthcare has really deteriorated over the last 20 years. We're going to focus on commercial insurance, especially job-based coverage, which is still where most Californians, especially most folks under 65, get their insurance. So healthcare costs, premiums, and deductibles have grown faster than wages and incomes in the last 20 years. This chart is showing average annual growth rates from 2002 to 2022. And so this is where you can see that California's median wages and median household income have grown at an average of 3% per year. Those are those green bars at the bottom there. When we look at healthcare costs over the same time, they've gone up much faster. The size of deductibles, those are the orange bars, those have increased almost 8% per year for family deductibles and almost 9% per year for single deductibles. you can see that premiums have increased rapidly as well. Total premiums have increased about 5% per year. Those are the dark blue bars. So in dollar terms, the family premiums have gone from about $8,000 per year to more than $22,000 per year. That's you could buy a new car for the cost of family premium. And then the light blue bars, that's the worker share of premium, and those have also increased more than 6% per year on average. We can also look at this as cumulative growth, right, over the last 20 years. 3% per year means that wages and incomes, they haven't yet doubled. They've grown about 80% over the last 2 decades. And at the same time, premiums and deductibles have more than doubled, and their growth has far outpaced the growth in family budgets. It's not just that those deductibles are growing in size, it's also the case that more and more Californians face deductibles. So the Medical Expenditure Panel Survey, MEPS, looks at private sector establishments. This matters because public sector workers are less likely to have deductibles. But here we can see a pretty dramatic increase in the share of workers who are enrolled in coverage with a deductible, right? It was just 1 in 3 in 2002, went to more than half by 2012, and it's 3 out of 4 today. Even though most people don't reach their deductibles, it can have an impact on their willingness to seek care. Some economists hoped that this increase in consumers' exposure to healthcare prices would limit the use of low value or unnecessary care. But no. Instead, the evidence suggests that it leads to reductions in all types of care, including needed and high value care. The high cost of care is limiting access. And when we think about deductibles, they're particularly problematic for lower and moderate income families. The average family deductible was $3,600 in California in 2022, but that's the average. So for some folks, it'll be even more. But a survey of families in the US found that 4 in 10 had less than $4,000 in liquid assets. So deductibles that are this high and this prevalent are a real barrier to care for California families. The result of all this, the increasing premiums and deductibles, is that healthcare is taking up an increasing share of household budgets. So in 2002, you probably didn't have a deductible, and your share of a family premium was about $2,000. If you had median household income in 2002, that equates to 4.2% of your income. When we fast forward to 2022, chances are you do have a deductible, and you're paying more for premiums too. When we add average premium plus your potential deductible spending, it's more than $10,000, which is more than 12% of median household income. So what does all this mean? The cost of buying coverage and getting care are increasingly unaffordable, and this has negative consequences for health, for financial well-being, and for equity. When healthcare is unaffordable, people have trouble paying their medical bills, they incur debt, and they skip or delay care that they need. We've seen some of this data from the CHCF Health Policy Survey earlier today. This focuses on folks who are skipping or delaying care, and just over half the population say that they or a family member have skipped or delayed care in the last 12 months due to cost. Across all the possible services for which someone might skip or delay care, Black and Latino Californians are more likely to have skipped or delayed care, whether that's mental and physical care or getting a recommended test or a prescribed medicine. These delays in care have consequences for people's health, and they exacerbate the inequity by race and ethnicity. In the interest of time, I'm just going to focus here on skipping and delaying care, but there are financial consequences too, like we heard earlier from Vishal. And disparities by race and income are evident across all of these measures. Okay, so that was the history of what's been happening with consumer affordability in California. Now we want to look to the future and think about what it is that OCA can do to measure how things are changing in our state, right? If we want to move the needle on consumer affordability, we have to track it. So how will we know if OCA is having an impact for California consumers? Unfortunately, there's not just one number we can look at. So for example, you could look at premiums, but flat premiums might be offset by changes in the generosity of a plan. You could look at out-of-pocket spending, but lower out-of-pocket spending might just mean that care is so expensive that people are avoiding it. So we think you got to look at a bunch of stuff, and we find it useful to think about sort of 3 categories of things to measure. The first is, how's the cost of coverage changing? So how are premiums changing? Are firms offering as much or even more than before? Are workers taking up that coverage? Category 2 is about accessing care and the cost of accessing care. What are the trends in deductibles, copays, maximum out-of-pocket, actual out-of-pocket, and actuarial value? Actuarial value is a measure of the generosity of a plan, and we'll talk about that more in a minute. Then the third category we think is really useful is tracking the health and financial consequences of this unaffordable coverage and care. So that's skipping care, trouble paying for medical bills, and taking on medical debt. And finally, underlying all of these measures, it's vital that we track not just how the averages are changing, but track equity measures as well. So are disparities by race and ethnicity and by income improving? So those are the 3 categories that help us understand what we want to track, but how do we track these things? There's 2 main types of data I want to talk about, administrative data and survey data, and we need both. Administrative data is great. It's not a sample, it's the whole population, so we can use it for year-over-year comparisons. And we're lucky in California that we've got some good sources, namely from the Department of Managed Health Care, which collects quite a bit of data from fully insured plans, which is about 14 million lives, as well as the data that OCA is going to collect on total healthcare expenditures. But administrative data doesn't cover all of these metrics, so we also need survey data. Survey data can track long-term trends. It's also useful for monitoring equity. The DMHC data doesn't have information on income or race, for example. And survey data is currently the only data source we have for tracking the health and financial consequences of unaffordable care. We have some great sources for this as well. The Medical Expenditure Panel Survey Insurance Component, MEPS. Sorry if I say MEPS and use abbreviations. The CHCF Health Policy Survey, and others like the Employer Health Benefit Survey for California and the California Health Interview Survey, among others. A quick note on survey data. I think we're all kind of in this mode of thinking about year-over-year trends, right, given setting the spending targets, which are year-over-year. For tracking using survey data, however, we just want to be cautious about interpreting those changes year-over-year. This is a graph of worker premium contributions at private sector establishments in California, and you can see that general trend, right? The blue bars are going up over time, from $4,000 in 2011 to closer to $7,000 by 2022. But between any 2 given years, there's a fair amount of volatility, right? There's that 11% increase in 2016-17, and then almost no increase in 2017-18. If we had data from the whole population, we might know what really happened in those years, right? Was it a big bump in one year or more of a gradual, like 5 or 6% in each year? But we don't have that whole population. This is just a survey, right? There's some standard errors there. It just means we need to be cautious when we're looking at survey data, interpreting those year-over-year changes. Okay, back to administrative data. Let's take a look at what we have. So DMHC, the Department of Managed Health Care, looks at the more than 9 million folks in fully insured large group coverage, and then there's approximately 2 million in small group and individual market coverage. And they report on the average premium and average rate increases compared to last year. So these are data for 2022 to 2023. So we're not seeing the double-digit increases that we might see for 2024. but we still see these increases of 5 to 7%. We also propose looking at the actual consumer out-of-pocket spending on covered services that OCA is going to capture. We know there's been a lot of interest in looking at out-of-pocket non-covered spending, and the next presentation is going to dive into that and how OCA might go about getting some data there. But we think that the data that OCA is going to collect is going to be really useful, and it's going to help us answer this pretty basic question about consumer affordability. How much are people with commercial market coverage spending on out-of-pocket on average, and how is that changing? Right? We currently don't have a good answer to this fairly basic question, but we will. So the other great bit of administrative data we have from DMHC is on actuarial value. Actuarial value, or AV, is a measure of the generosity of a plan. So what share of medical expenses is the plan going to cover on average? Those of us with large group fully insured plans tend to have 90 to 100% of expenses covered, the range that Covered California calls a platinum plan. But in recent years, the share of people with this generous coverage has been declining. You can see here that by 2023, it's 72%. The next group that we can look at is small group coverage, where it's more distributed. About a quarter of folks there have platinum plans, but more have these kind of gold plans that cover 80 to 89% of expenses. And in the individual market, coverage is even less generous on average, with more than a quarter of enrollees in bronze plans that only pay 60 to 69% of expenses. AV, actuarial value, is a really crucial way of summarizing the generosity of plans. Given all the different ways that a plan can have cost sharing, right? Deductibles, co-pays, co-insurance. This is kind of a useful measure of understanding what people are getting for their premium. So those are our administrative data sources. And I'm just going to give you a few examples of how we suggest using survey data to supplement this administrative data. So for example, in the cost of coverage category, we can look at whether or not a firm offers coverage to their workers. And here it's useful to look at small employers specifically, those with fewer than 50 employees, because they're not required by the ACA to offer to their workers. And here we've seen some declines in offer rates over the last 20 years, though it's been fairly stable since the major provisions of the ACA were rolled out in 2014. We could imagine that if prices moderated, this offer rate would at very least hold steady and might even creep up. As we think about the cost of care, that next category, survey data can be useful here too. We can look at average family deductible and how that's growing. I want to just make a quick note here about some of the data challenges, right? We'd ideally like to know how deductibles vary by race and ethnicity as well as income. Unfortunately, there's a bit of a mismatch here, as the surveys of employers, which give us good data about the plan details, they don't have great data on employees' race and income. And the consumer surveys that have data on race and income don't have great data on some of the exact values for the different plan details, right? Generally, consumers don't know their plan design details by heart, or if they do, it's because something's pretty wrong. So, there are things we can do to piece it together, like we can look at people with deductibles above $2,000. But unfortunately, there's no magical data set out there that we can just grab exactly the cuts we want. Turning next to survey data focused on the last category, health and financial consequences of unaffordable care. Here, the CHCF Health Policy Survey lets us look at who reports trouble paying for medical bills, both overall and broken out by race and ethnicity. So to summarize here, it's going to be important to track across all three of these categories: cost of coverage, cost of accessing care, and the health and financial consequences of unaffordable coverage and care. Both administrative and survey data are needed to cover these categories. We're fortunate, we've got a lot of data to start with here, but there are key pieces of the puzzle that are missing, especially when it comes to equity impacts. And, you know, other data needs are going to arise as OCA gets experience monitoring these trends. And there are some key data needs to explore. So getting data on premiums and deductibles by race and income, thinking about what data can and should be collected by geography. And we're excited about the possibilities that the health payments database might open up once it's in full swing. So, as I described in the first part of the presentation, right, we've seen this real decline in affordability of job-based coverage in California. Over the coming years, it'll be important for OCA to measure whether that erosion is continuing. And it'll make sense to do that alongside the tracking of total healthcare expenditures. But tracking is, as Laurel said, just a first step. If there are disconnects in how healthcare expenditures are growing and consumer healthcare costs are changing, the board is going to need to further look into what's happening and figure out how to address it. But we think we've got a real opportunity here to learn from Massachusetts and to track this from the beginning, starting with that first annual report in 2025. And with that, I'll turn it back to Vishal.
Thank you, Miranda. A lot for us to consider, and glad to have this discussion. I think, you know, as you mentioned earlier at the beginning, THCE and kind of what that means to consumers and kind of trying to ground it in more in other measures outside of THCE. So I'll just kind of turn it back over to the chair to facilitate discussion.
Thank you. David and Richard.
I'm going to invoke back in the day when I was a young health services fellow. And this was in the early 1980s, late 1980s in my case, but there was a well-known study called the Rand Health Insurance Experiment. And people are nodding their heads. I mean, it's famous. One of the findings was that co-payments and deductibles, yes, they reduced utilization of services, but they were a very broad tool. Both necessary services and unnecessary services were reduced. So it's no surprise to see that as we're increasing co-payments and deductibles, more and more people are having trouble accessing health care. I'm not sure what the solution to that is, except that we clearly need to make healthcare more affordable. But I'm not surprised to see the conundrum that we're facing right now based on that research from 40 years ago.
Richard?
Thank you. Yeah, and actually, I believe if I recall the study correctly, they particularly focused on copays as being the effective driver. Deductibles less so. In fact, I think there's some question now whether how much deductibles actually deter unnecessary healthcare, right? And in fact, I actually even carried a bill to try to eliminate deductibles, but it unfortunately did not get through. And said copays were fine, but not deductibles. So I guess a couple of questions or comments or questions. So first of all, I appreciate you picking 20 years, but we did a major health reform that we implemented in 2014. We passed in 2010 called the Affordable Care Act in California, implemented in 2014. So shouldn't we be looking at 2014 moving forward? I mean, we're mixing a whole lot of stuff going on. So there's stuff that happened before that. I'm not saying that none of it's happening now, but we made a lot of reforms because of things we saw happening before then. So I guess, so to me, I'd want to really see what's happening since 2014, realizing that even some of the things that we implemented ACA took take a little time for people to, sort of get on the program, right? But we passed reforms that are related to, eliminating, lifetime caps. We, eliminate the discrimination for pre-existing conditions. So there are a lot of structural reforms as well as, the Medicaid expansion, et cetera. So I guess that would be one comment. I think let's not be arbitrary in terms of how many years we look back. We should be looking at landmarks. The other issue is, I guess, and again, I don't disagree that affordability is a major issue for people and it's a barrier to access to care. But I always say, well, let's also look at what the alternatives are and see what's going on in the alternative. So Medi-Cal, a third of all Californians on Medi-Cal, there's no cost share, right? It's actually in some ways the growth of that program is somewhat capped by our state budget and so forth. We get federal match, et cetera. And certainly here in the state, except I was in legislature, we did invest in expanding Medi-Cal, et cetera. But I would also make note that since the ACA implementation, studies have shown people with Medi-Cal still have greater unmet needs, delays in care compared to people in commercial insurance. So with all the affordability challenges. So again, I think, and by the way, Medi-Cal is going to be part of this as well. But I guess, can you speak to, well, I guess the question is that, yes, it'd be great if we just simply said, well, if everything was cheaper, of course things would be better. I don't disagree with that. But the question is that, can we get the same thing for less? That's, yes, we probably can get many of the same things. We talk about waste, et cetera. But at the same time, if you look at sort of the alternative model is, we have our Medi-Cal program, and so what happened in Medi-Cal, realize that this different population, but we also unfortunately have some of the same problems that you've cited in terms of what's happening on the commercial side, except worse in terms of delays in care, unmet needs, et cetera, that's been reported, and surveys have shown when they've surveyed both Medi-Cal and commercial that generally it's about somewhere around twice as worse. Although actually, interesting enough, it's getting a little better since the ACA. So any thoughts on that?
Yeah, so just to your first point about looking starting at the ACA, the ACA obviously had really big implications for where folks got coverage and changed the landscape in California, but it had pretty minimal effects on job-based coverage.
Well, but we're not just talking job-based coverage here. We're talking, and by the way, that's what we created. That's what we created the Covered California, right? So that people who couldn't get coverage, as individuals, like the individual market, right? So, I mean, we did do a variety of things to address, I mean, in many ways, and actually some of the things that we ended up doing, we created, the standard, the essential health benefits, right? There's some things we actually reformed that, even in the commercial market, right? There are commercial market reforms.
Yes, so there were certainly commercial market reforms there. Our report really focused on the commercial market because that's where most folks are getting their health insurance in California. So we wanted to focus on that, and because that's where underinsurance is the biggest problem. So this measure of kind of you have insurance, but it doesn't cover what you need to given your income. So that was another reason to focus on the commercial market, as well as thinking about sort of the levers and how the change in total healthcare expenditures, will we see that in what consumers are facing and what the majority of consumers are facing with their commercial insurance? That was the question that we wanted to focus on. We could have done a report on Medicare where there's also big affordability challenges, but given the federal nature of that, we wanted to focus here.
Rick, go ahead.
Thank you, Miranda, and Laurel, for really, I think, a very useful set of suggestions that I would hope the office will take seriously as putting together the baseline report. You talked about two questions. One, I don't know anything really about the actuarial value estimates that come out of DMHC, and I wonder whether they are good enough to support estimates of consumer out-of-pocket spending, at least on average. You had a sort of blank line and said, we needed data from OCA for that. But if those actuarial value estimates are, reasonably precise, it seems like you could multiply that. One could multiply them by the premium to get at least an estimate of average consumer out-of-pocket spending. And I wonder, is that a feasible approach? It won't tell you anything about distributions and a lot of other things we might want to know about. And maybe you don't, it's just something to consider. And then second, you highlighted the year-to-year variability that comes out of from the MEPS-IC estimates of changes in premiums, and I imagine we might see something similar in some of the other measures from MEPS-IC. And I wonder whether you've given any consideration to this cost benefit or cost and what the benefits might be of investing in larger sample sizes and say the California Employer Health Benefits Survey. In addition, I don't know whether that survey asks for any information about race, ethnicity of the employees at each workforce, but it seems like potentially there could be some information that comes out of that.
Yeah, the California Employer Health Benefit Survey is a great resource. They've made some methodological changes in the last couple of years, so looking historically there was challenging, but we think they're a great resource going forward. I'm not sure about asking employers for the race ethnicity of their workforce. There might, it seems worth, yeah, worth exploring.
Income levels of the workforce, so certainly.
Yeah, so there are these measures of like what share of the workforce earns over $70,000. So you can start to get at these things, but I'm a data person. I like graphs, but when I make that graph, I have to read it like 10 times to try and understand what I'm looking at. So I left those out. Yeah, so we can start to get at these things, but yeah, worth exploring.
I have to say, as a former director of ARC, in which the MEPS-IC, because it was slightly delayed relative to the KFF employer survey, was often treated as a second cousin in the media. I'm hesitant to push anything other than the MEPS-IC, but there is value in other, there are some value in other surveys.
And for my part, first off, I just want to echo appreciation for this presentation and all the work you do at the Labor Center. I don't know where our state would be without the work you've done, particularly on healthcare. The one piece that was missing here to me, I don't know that there's survey work or what have you to be added here, but in addition to increasing premiums and increasing deductibles, the two other phenomena that employers have been using to manage the cost crisis in healthcare is reducing employees' hours. So they're below the threshold of eligibility, but also eliminating retiree coverage. I believe over this same period of time, we've gone from having roughly 2/3 of large firms offering at least some number of their workers and families retiree coverage to barely 1/5. And that, of course, has knock-on effects to current retirees as well as future retirees in terms of the affordability of all the gaps in Medicare. And we shouldn't lose sight of those holes when it comes to affordability for seniors and people with disabilities. So just wanted to put that on the record, but not to fault the extraordinary work you do. So thank you.
Thank you.
If it's okay, we'll move on to public comment.
At this time, we will take public comment on the most recent agenda item. Thank you for creating a line in this room at the podium, and we'll be looking for raised hands from virtual participants. Again, please try to keep your comments below 2 minutes so that we can accommodate all speakers. And with that, we'll look to the person at the podium.
Beth Capel with Health Access. First of all, we are very pleased to see this report and to see the focus on consumer affordability, which is since the first meeting of this board. And so it's great to see a discussion of possible measures that can be used to measure our progress or lack thereof with respect to consumer affordability. We hope we will make lots of progress. With respect to the information that's presented, the two most striking figures to me are the reality that we've gone from 1/3 of Californians with job-based coverage having deductibles to almost 80%. That's frankly horrifying. The size of the deductible is bad. The prevalence is horrifying. And the reality that a family could face $10,000 a year when the median income is $85,000 or thereabouts. That's just an unimaginable amount of money for the median income family in this state. With respect to various, one of the fun things about reading this report is that so many of the data sources we have are California specific. and that we can have a conversation, whether it's with, Dr. Hernandez at CHCF or the Department of Managed Healthcare about the data they collect and see if we can collect additional data. It's to us very valuable that this focuses exclusively on employer-based coverage. We know a lot about the individual market because fundamentally everyone in the individual market who's below 400 or 500% of poverty is already in covered California, and we know what they're facing. We don't have an assembly of information about people in the employer market. And so actually that focus was very helpful and we think intentional. Thank you.
Thank you. Looking to members of the public online. We don't see any raised hands at this time, so we'll turn back to the room here and the person at the podium. Thank you.
Members of the board, good afternoon. I'm still Steve McDougall, and I'm still a CFT. There hasn't been a coup d'etat during this meeting, apparently. So, everybody remember the former Surgeon General, Dr. Adams, during the previous administration? Here's his denouement. He had a hard time finding work because of his association with the previous administration, as it should be. But he finally landed at Purdue. The Boilermakers took him in. And he had a work trip recently in Arizona and went on a hike. And he didn't bring enough water. And he ended up in the ER in Arizona. He got a $5,000 emergency room bill for a couple IV bags. So I'm just going to pull some quotes from his interview. Navigating his ER bill and getting answers and finding it has been mentally taxing. You'd think you'd know how to navigate an emergency room bill, wouldn't you? His qualifications. The system is broken. I've said that, and now the former Surgeon General has too. They coded his ER bill as level 5, cardiac event. They don't want to change it. They thought maybe he had one. He was dehydrated. He also said no wonder Americans end up with medical debt. That is the number one reason people are declaring bankruptcy these days, right? Lack of transparency in his bill. How about that? Impossible to shop around when you have a medical emergency. Yeah, we know that, especially Monterey County. The average Joe doesn't stand a chance, is what he said. And he decided when he got hired at Purdue to get into a high deductible plan. So he hasn't met it yet, $7,500. And he's not done. He didn't drive himself there and no one drove him there. He went there in a bus. He hasn't gotten that bill yet either. The Surgeon General of the United States complaining about an ER bill that he can't figure out. And we're supposed to navigate healthcare? Forget about it. Thank you.
Thank you. Looking online for any raised hands. Seeing none, we'll turn back to the room here and the person at the podium. Thank you.
Steve's always a hard act to follow. Ivana Krajcimich with Unite Here Health. I really enjoyed the presentation. I thought it was had a really great content. I kept thinking about wages during that presentation, and to give an example of why I'm thinking about that, because I think that they go, at least in collective bargaining circles, hand in hand with benefits. In Monterey currently, the contribution for healthcare is $9.23 an hour over wages, right? And it used to be that the bargaining parties would get together and, they would bargain a bucket of money, like $1, right? And that would pay for, something between 0 and 30 cents to healthcare, and then the rest would go to some pension and wages and some other things, right? Wages have gone up in our industry, like everywhere. Minimum wage is pushing up our folks who are just a little bit above the minimum. So you now need, something above $1, right? Well, our actuary just finished, costing out how much the bargaining parties need in August, and we need $1.96 to cover the deficit that's created by, the hospital pricing in Monterey County. That's a 21% increase, right? So what's happening right now is that workers in New York and Chicago and other parts of our country, because we're a national plan, are subsidizing that care. That's why we're able to do that. But at a certain point, they're not going to do that forever. And so then what we're left to do is change the benefits. It's already an 80-20 plan. And you've seen the people from Monterey who have testified here. They can't really pay for much more than that. It already has a deductible. So, you know, really the savings are kicking people off the plan, really just, to Ian's point, raising the hours so that fewer people qualify for medical care. So we'll end up with a plan where a smaller and smaller group of people can go to a set of more and more expensive hospitals, right? And meanwhile, wages will stay stagnant. So I just wanted to encourage folks to also think about that part of the equation, because even in a non-union setting, non-union employers are doing the same math. They are pulling money from the same buckets of money to pay for all of the compensation. And, you know, I think if OCA is successful, we'll see not only healthcare premiums come down, but wages go up in the state. Thank you.
Thank you. Checking for raised hands virtually, seeing none, and looking to the podium, seeing no more members here. That completes public comment for this agenda item.
Very good. I think we're moving on to our final item. Vishal, take us away on measuring out of plan spend.
Good afternoon. I'll be taking this one. My name is CJ Howard. So this next item is well timed, especially in light of the presentation. It's kind of one aspect or one element within the Labor Center's broader presentation. It's also a follow-up to various discussions that we've had in prior board meetings where we've talked around potential efforts to measure and track out-of-pocket or out-of-plan spending that's not captured through our total healthcare expenditures data collection efforts. So what we'll do today is share an overview of our current plans to approximate and track out-of-pocket and plan spend, current timeline to do so, and also just want to note that joining us remotely is Carrie Ann Laspina with Mathematica, who we've engaged with as a partner in this work. So starting off first with a little bit of definitions around what it is that we're intending to capture and track. So we know there's cost sharing. This would be the member's financial responsibility included by copay or coinsurance and deductibles. This is something that we do plan and are intending to capture through OCA's THC collection, data collection efforts. There's also out-of-plan spending. So these are costs for services that are not covered by insurance and costs that are paid outside of insurance or not through, not done through an insurance provider. And that those two together would equal total out-of-pocket spending. So why measure out-of-plan spending? So the board and advisory committee had concerns first that OCA's total healthcare expenditures does not measure out-of-plan spending, and so that we could have a full picture of out-of-plan spending and further understand what's going on with spending within the state as spending targets are created and established and ultimately enforced. So some possible reasons for out-of-plan spending include provider preferences for cash payments. Simply put, fewer providers may be accepting insurance or are accepting insurance. Research suggests that this may be more prevalent in some provider types than others, specifically fewer psychiatrists accepting insurance compared to potentially other specialties. Patients may seek care outside of a plan when they're unable to find or coordinate care within the plan and find a provider within their plan's network. Also changes to benefit design, different cost sharing or different strategies for how benefits are administered may incent patients to seek care outside of their plan. So to shed light on the scope of this problem and its implications for potential public policy, OCA is proposing this supplemental analysis to estimate out-of-plan spend. So our plan for doing so, tentatively, is to use the medical expenditure panel survey household component. It's a nationally representative sample of the civilian non-institutionalized population. Within this component of MEPS, this includes information from consumers on health insurance coverage and healthcare utilization and costs, including out-of-pocket spending. So spending in MEPS is defined for each medical event. For each event, data shows spending by private insurance, public programs, and self-pay or out-of-pocket. And then each event includes a type of provider, diagnosis codes, and procedure codes. This is a national survey, but we can create specific California estimates. In order to do so, we may need to pool years to produce reliable results. The MEPS out-of-pocket spending variable includes but does not differentiate payment for out-of-plan events. So OCA intends to build decision rules to estimate the portion of MEPS out-of-pocket spending allocated to out-of-plan events. OCA is developing the methodology based on the payment source and timing of medical events. And there's a slide I'm going to skip forward just to kind of walk through what that decision tree looks like. So in the MEPS variable, there's out-of-pocket spending on behavioral health services. So we'll look at the first annual event, and then there's a question, does the event include payments from insurance? If yes, then we would assign that to cost sharing. If no, we'd ask the question, do subsequent behavioral health events in the year include payments from insurance? If yes, then we assume the event was under the deductible and assigned to cost sharing. And if no, then we assume the event was, and subsequent events were out of plan. And so I'm going to back up in the presentation. So some of the examples of the questions that we can ask and what we can measure. We'll be able to estimate out-of-plan spending for behavioral health services. We'll also be able to estimate out-of-plan spending for other types of services, so not just behavioral health. We'll be able to estimate out-of-plan spending as a percentage of total behavioral health spending. Some of the research questions that we can answer include what is the level and change in out-of-plan spending for behavioral health and other services over time in California? How much are Californians spending out of plan on behavioral health conditions compared with other types of services? How much, and then also, of course, how much are Californians paying for out of plan services in totality as well? And so this last slide is the timeline for implementing our plan to measure out of plan spending. So this spring, we're developing and testing the initial methodology and running an initial analysis. In the fall, we'll update the analysis with an additional year's worth of data. By winter, we plan to present initial out-of-plan findings to the board. And then next summer, we'll update the analysis with an additional year's worth of data. And then in the fall, we plan to release a supplemental report on out-of-plan spending. And then we could annually update this report. So just wanted to circle back to the board, because I know this was a discussion that we've had, let you know what our current thinking is, and then also solicit any feedback that you have at this time, especially in light, I think, of the prior discussion that we just heard from the Labor Center.
Thank you, CJ. Richard?
So it looks like your main focus is on behavioral health, which I know that there has been particular challenges in terms of people not taking insurance. But we also know that, for example, concierge medicine is growing. I think the market's growing by over 10% a year. And then you have, I don't know if you call it concierge or concierge-like things like One Medical, which Amazon purchased, right, and is now offering through Amazon Prime. Are we capturing spending on those types of entities?
So I know that the presentation focused on, I think there's two different questions there. So the presentation focuses on behavioral health. That was, I think, part of the discussion that we had. It's one of, I think, the known unknowns, or we know that there's spending that's happening there. We don't know exactly how much it is, and something that we want to keep an eye on. I think the latter part, I'm unsure exactly how the One Medical would or would not be captured by MEPS, and it's a great question. I don't know if Carrie Ann, if you're on the line and able to join us, or that's something that we can certainly follow back with.
Yeah, and other concierge arrangements. I'm just one example, but yeah.
And this is a novel approach that we're, it hasn't been done before in terms of this hierarchy. And
sure.
So we want to definitely test it out with behavioral health, and then from there feel confident in that approach. We know it's an estimate. It may not be the actual numbers, but directionally it's an indication. So from there, we could go on to other types of categories that are of interest to the board and the public. But Carrie Ann, if you might have any background on other categories that might be a potential second order of analyses?
Yeah, can everybody hear me?
We can.
We can.
Sure. Yeah, I think we want to look at the data and kind of see where we're expecting behavioral health to be a place with growing out of plan spending. We are planning to look across other service categories and kind of see what trends we can find. I'm not sure about the Amazon marketplace though, but we can take that back and take a closer look.
Okay, I appreciate that. And again, I think, and frankly, as we're focusing on primary care, while they are, and now I'm not just talking about one medical, I'm talking about concierge growth. I mean, a lot of it is happening in essentially the primary care segment, and that raises some interesting equity issues. The other one that's probably more of a blip than anything else is, this whole thing about, we always have these waves where, we have now people paying out of pocket for ultrasounds in their pregnancy or whole body MRIs. Now, well, technically that again, that's not, we consider it healthcare now, but generates healthcare costs, because what happens is that when they find something, they then tell the patient to go to your regular doctor and your insurance company, and now we have to work up, what's this funky thing we saw on the MRI? We don't know, and we don't have a clinical correlation for, et cetera. So that's a generator of healthcare costs, even if the person's paying out of pocket for the actual exam or the imaging. And so hopefully, again, it's just a fad and a blip, but if that's what people start getting into, that does drive up costs.
I think David had a follow-up on this, and then Rick.
Or maybe Rick, why don't you go first, because I'm going to shift to a slightly different area.
Going to shift also. So.
Oh,
go ahead, Rick.
After you.
First, thank you very much. I and others raised this early on, and I very much appreciate you taking this seriously. And I think that of existing data sources, MEPS is the best one I can imagine to get at this. I will be very interested to see what your initial analysis shows. I suspect that there'll be pretty large confidence intervals. And you mentioned that the likelihood of needing to pool multiple years, and that will be valuable, but obviously will also limit the ability to make any statements about year-to-year changes. If we have to be averaging 3 or 4 years together, it'd be hard to know. And so I would recommend, and it's a longer term enterprise, but I would recommend investigating provider-based payment sources, either potentially adding to licensure or relicensure information. I don't even know how often therapists need to get relicensed, but I assume there's some periodicity. Questions about, do they take insurance or not? What fraction of their revenue is coming from insurance versus out of pocket? Either looking at trying to add to licensure, or maybe, and Dr. Hernandez is not here today, but trying to find a private philanthropy that would support a survey of clinicians, which probably could get better information than you can get on the licensure, but more expensive. Because I think that the MEPS is an excellent, hopefully an excellent start, but probably going to be tough to get very precise estimates. And minor kind of, I'm not a statistician, I don't think MEPS is designed to be a representative sample of Californians. And some statistician will come along and argue about that, but it won't be me. But I'm maybe Carrie Ann. It'd be good to get some reassurance that this is not a big problem. I'm sure there are people at AHRQ who would say, "Oh, you shouldn't be using it this way."
Thanks for those helpful suggestions. I don't think the licensure, the relicensure includes information about who's taking coverage and who isn't, but we can certainly look.
I'm sure it doesn't.
You're suggesting a change.
Yes.
Okay.
Yes.
Well, we actually had a significant change in the licensure renewals 2.5 years ago when HCI was recast to get better demographic information from the 17 Healing Arts Board, which was not a process for the faint of heart, but we will certainly take it under advisement and look at it.
Yes, why it might be that having some philanthropic approach to doing an actual survey would get better information and maybe be less painful.
David, over to you.
Yes, and I certainly echo my colleagues' sentiments, especially with regard to MEPS. I think that's a great idea. I'm not sure about statisticians, though. I'll have to think about that. But I wanted to, I wasn't sure if we decided up front to include dental services, because my impression, not having studied this, is that dental care has become more and more a uncovered benefit. Dentists are refusing to take dental insurance, even Delta Dental, Denti-Cal, and people are having to pay more and more out of pocket. And for vulnerable populations, this has led to I think a huge decrease in the accessibility of dental care, with some downstream effects in terms of employment, school attendance, and things like that. I'm even wondering, again, I have no idea what the magnitude of this is in comparison to some other things like behavioral health.
Is that something you want to speak to?
Sure.
I can.
Yeah, I could start off, Carrie Ann. But for dental services and THCE data, if it's a covered benefit, OCA will capture it, but most dental benefits are a standalone plan outside of health coverage, so we're not going to capture a lot of it. But as far as kind of measuring out of plan spending, that could be something we could look into after we do the behavioral health analysis. But Carrie Ann, did you want to add anything?
I was just going to note that dental is something we can look at in MEPS data if that's desired. And we have talked kind of internally about other kinds of, services that aren't always covered under insurance and kind of seeing what trends look like there.
Thank you.
In a similar vein to the previous discussion, does MEPS HC data have any data points that would allow us to look at racialized inequities, other inequities as we do this?
I'm going to punt to Carrie Ann, who knows much more.
I think sample size will be a problem, but certainly, yes, there's quite a bit of demographic information on the respondents of MEPS.
Thank you. Did you have anything, Elizabeth? Okay, I think we're on to public comment, and can we do both public comment on this item and general public comment to finish up the meeting?
All right, with that, we'll take both public comment from this most recent agenda item as well as general public comment. We'll look to folks here in this room at the podium and as well as raised hands in the virtual space. And we'll begin with the individual at the podium. Thank you.
Beth Capel for Health Access. Like others, we are pleased to see this. We would also commend the inclusion of dental. I think in addition to the various concerns Dr. Carlisle mentioned, the reality is that most commercial dental coverage has a $1,000 or $2,000 limit in a year, and anybody who's been uninsured for any protracted period will have substantially greater needs than that. It's also, I would note, lack of dental is a huge problem in the Medicare population as well. So you'll find a lot of unmet need, and you'll want to stratify by age. And we're happy that pediatric dental is covered under the ACA in individual and small group, but that's about 5 million Californians. And so there are lots of people that don't get that help. And so it's a big unmet need, as is behavioral health. Thank you.
Thank you. Looking to any virtual members for raised hands, and seeing none, we'll turn back to the podium here.
Thanks. Good afternoon. I'm Dr. Steve Packer, and for the past 25 years, it's been my privilege to lead Community Hospital of the Monterey Peninsula, CHOMP, and its affiliated entities at Montage. We are one of 4 hospitals in Monterey County that have been a frequent and indeed recent topic of conversation at these meetings. So I'm pleased to be here to provide our perspective informed by facts. Monterey County is indeed an outlier in terms of cost. There are 2 main causes that result in higher costs for healthcare in Monterey County. The high proportion of patients on Medicare and Medi-Cal that visit our hospitals, and the expense of recruiting and retaining workers in such high-cost area. Nearly 80% of the services we provide are to patients covered by either Medicare or Medi-Cal, whose payments cover only a fraction of the costs that we incur to care for them. By contrast, HCI data shows that the 85 hospitals in the 12 Bay Area counties to the north of Monterey County see, on average, a 50% higher share of commercially insured patients. As you know, commercially insured insurance is the only type of insurance that actually covers the cost of care. In fact, if community hospitals' commercial payer mix simply matched the Bay Area average, we could reduce our rates by 26% overnight. The second driver of higher costs relates to salaries and wages. Community hospital sets our wages for our entire staff, nurses, pharmacists, environmental service workers, food service workers at the 75th percentile of the greater Bay Area. So, by definition, our wage expenses are higher than the Bay Area average. This allows us to effectively recruit and retain staff in an extremely high cost of living area. We support our dedicated staff with higher wages so that they are able to live, work, and raise their families in Monterey County. This philosophy has proven to be very successful. CHOMP experienced an annual turnover rate of 7.8% last year, among the best in the state. This low turnover rate and corresponding tenure results in better patient safety and patient satisfaction. It's unfortunate that our critics have neglected to provide an accurate and complete explanation of cost drivers in Monterey County, and in doing so have detracted from this board's important statewide mandate. We believe it would be much more productive for our critics to join us in a dialogue along with other providers to explore sustainable solutions that would result in all Monterey County residents having access to and obtaining excellent care locally. Thank you for your time.
Thank you. Looking to our virtual members online, I see no raised hands. And so back to the podium. Thank you.
Hi, I'm with him, but my name is Garbella Kuma, so I get a little emotional. I'm a stroke survivor. I was a patient at Carmel at CHOMP. I 2 years ago I suffered from a brain stem stroke, so I was unable to walk. I was unable to eat, form sentences, and I lost some of my ADLs. And I spent a month at the rehab center. It's called IRU, and as I was waking up, I was shocked the fact that I had a stroke, and it was surprising that I had disability and my new diagnosis. As I was waking up in the IRU, sorry about that. The meeting, I guess is sorry about as CHOMP staff in that time were so supportive, so nurturing and compassionate. I had feelings of confusion of having a stroke as a younger and active person. Recovering in the IRU, the staff would set achievable goals with me, and we would achieve those goals together. They were intentional with my care. They made sure I was safe for discharge, and they gave me tools as I integrated my life back in society. Recovering from a stroke is hard work. I'm very sorry. I'm very appreciative of Tom and their staff as I continue to be very appreciative, and they walk with me still through this bumpy road, and it is easy for me to talk about the kindness I received from the CHOMP staff, and as I continue to be accepting of my new diagnosis. Thank you.
Thank you. Looking to our virtual online members, seeing no raised hands. So looking back to the room, is there anyone else who'd like to come to speak at the podium? Seeing someone approach, well, welcome.
Thank you. Good afternoon. Thank you for allowing us to be here. My name is Jennifer Reed. I am also from Montage Health. I have been at Montage Health, which was CHOMP, when I started, for 22 years this year. When I started this organization, I was a single mom working as a nursing assistant at night and then going to nursing school during the day and then trying my best to balance all those roles and be the best mom that I could be. I started with the work study program on a cardiac unit there. For 22 years, my colleagues and I, we have spent time getting to know the patients of our community. It has been many years of seeing these people go through some of their most unexpected, challenging, painful, or pivotal days and points in their lives. No one plans to be in pain or get sick or break a leg on vacation. After my daughter was independent and life allowed, Montage gave me the financial support to pursue my bachelor's and master's degree. This is not only true for me, but through various scholarships, hundreds of our colleagues. And this has allowed us to pursue further growth opportunities for advancement. These colleagues have become my second family. We have laughed and celebrated through graduations, births, marriages, graduations of our kids. We've shared in the joys of nursing together, delighting in the intricacies of the pathologies and circumstances that make each individual case so unique, while celebrating seeing the progression of illness to health. On the other end of the spectrum, I have vivid memories of having the honor of holding our patients' hands and brushing their brows as they take their last breaths. Then, with the team, we take a moment to honor that moment. This is the culture that we have at Montage Health, and it is priceless. Through Montage, I have grown not only professionally, but as a member of the community. I have been able to participate in volunteer events that collaborate with our community partners and programs that align with my values and connect me to the community. I've been able to participate in programs that benefit my emotional health, my physical health, and these programs exist for our community as well.
2 minutes.
I know that I will have the resources and leadership for support that I need to do my job and do it effectively, and I know this can't be said for everywhere. I've experienced many childhood adversities and difficult circumstances, as I'm sure others possibly have here, and my success in life could easily be said to have been against all odds, excuse me. But that being said, I'd like to think that the values that I hold and the fact that I have people in my corner who've believed in me along the way has been a huge contributor to me being successful in the many ways that we define success. And I think that Montage Health has contributed to that as well. I am grateful to be a part of this organization, and it's an honor to be a part of this organization that cares for our patients, our community, and our staff the way that we do. Thank you.
Thank you. All right, checking any raised hands online. Seeing one. Travis West, we have unmuted you. We welcome you to unmute.
Hi, thank you. Travis West, Regulatory Policy Specialist with the California Nurses Association. We would like to applaud OCA for the focus on out-of-plan spending and the impact on consumers. Out-of-pocket spending is a major factor in determining the degree to which healthcare is actually made affordable to consumers, and the affordability to the consumers, as we've heard multiple times today, is a primary driver of accessibility. So we very much appreciate the attention to this crucially important point on the issue of affordability. Thank you.
Thank you. Looking to anyone in this physical room who'd like to step up to the podium. Welcome.
Good afternoon. My name is Sharon Carey. I'm the Executive Director of Big Sur Health Center. It's a nonprofit rural health clinic in Big Sur. Big Sur is extremely diverse socioeconomically, and many of our patients are uninsured. Community Hospital of the Monterey Peninsula is our closest hospital, and they have always received both our insured and our uninsured patients. As a practicing physician assistant for nearly 40 years, I've always been confident in knowing that the uninsured patients I refer to Community Hospital will be able to receive assistance from the sponsored care program to cover part and sometimes all of the medical bills. The sponsored care program assists more than 1,000 patients each year and assumes over $3 million in debt annually to help these patients. One distinction for which Big Sur is known is our frequent large-scale wildland fires. During these events, Big Sur Health Center has played a key role partnering with the U.S. Forest Service to provide medical services to nearly 1,500 firefighters in each incident. During these disasters, the demand for urgently needed medications is high and supply is rapidly depleted. Community Hospital has readily stepped up on every occasion to donate medications and other needed supplies so we can provide prompt care to the ill and injured fire personnel. Finally, Community Hospital has been key to helping preserve the stability of Monterey County's nonprofits through grants, technical support, and other donated services. Clinics like mine around the county, as well as other nonprofit organizations offering vital services, have received critically needed support to help us support our important work toward improving the health and welfare of our Monterey County residents. Thank you for your time and for the important work you're doing.
Thank you. Looking to our online guests, seeing no raised hands, I'd like to ask if there's anyone else who'd like to come to the podium.
Thank you. Good afternoon. I'm Clement Miller. I'm a nurse by training and the Chief Operating Officer at Salinas Valley Health in Salinas, California. One thing I learned is I won't let Dr. Packer go ahead of me in the future since he's clearly articulated the needs of our community based on the demographics of the payer mix that we have. But what I wanted to really drill down on is the work that you were doing is clearly important for all of us, for the members of our community, and really the work that we strive to complete every day. We, as you look to make a decision on the 3% cap, I appreciate the conversation that I heard here today about where there is underpayment in the system. As Dr. Packer mentioned, we are struggling with reimbursement from our governmental payers where we see the vast majority of our patient population coming from. My fear is that if we set a cap that is focused on the right place, which is the reduction of cost of healthcare for our community, but don't look at the expenses that the hospital is facing, we'll create a sort of echo chamber where we're talking at each other and no longer listening. We have, for the last year or so in our hospital, struggled with really coming to terms with the expense of healthcare for the teachers in our community and the school district employees as a whole. And this started off by just conversations. Well, they weren't conversations, they were really pointed messaging around the cost of the care that we provided, where we would retreat and talk about what we needed to do to ensure that we were providing the highest quality care to every member of our community. We shifted that to actually sit down and have a conversation with the leadership of our school districts and have gotten to a place where we're now on the same page. And I'm happy to say, and I'm actually sad that Steve McDougall left, but as of last night, our hospital system, and our teachers, the teachers within our community now have a contract that allows them to receive care in our hospital and not have to travel outside of the community for care.
2 minutes.
Thank you. So yes, this work needs to be done. Yes, we are all on board. We also know that there's work that we need to do together to make this happen. And that is the focus that we'll have going forward as we partner with you to come to a decision that makes sense for all Californians. Thank you.
Thank you. Looking online, you see no raised hands there. Looking back to the room, is there anyone who would like to step up to the podium and speak? Seeing no one else approaching the podium, that completes general public comment for this meeting.
Thank you. Thanks to the public who commented, and thanks to my fellow board members for your patience with my hopefully one-time chance at chairing this meeting. This was a heavy agenda, but it was a very interesting one. So thanks very much. We'll see everybody next month.